you to KIMS. Thank you.
So I would like to introduce someone without which an event is completely unsuccessful, the masters of the ceremony. And why we say masters? Because they are going to drive the entire show. And we have two brilliant oncologists with us. We have Dr. Romila Tiwari, who is a medical oncologist, and Dr. Garima, who is a surgical oncologist. And they are going to be your masters for the next 3 days. Over to you.
Thank you. Thank you for that lovely introduction. A very good morning to all of you. For people who have joined the city, Bhubaneswar, the temple city, I hope you're having a good time here. I'm delighted to welcome you all to this event of 3 days, over the next 3 days, the International Conference of Frontiers in Uropathology and Uro-Oncology, jointly organized by the Genitourinary Pathology Society, the AIMS Bhubaneswar, KIMS Hospital, where this is being held right now, IAIO, and OSO, the Orissa Society of Oncology. It's an absolute pleasure to have all of you over here and to begin the day with the blessings of Almighty. Can I please welcome for the lamp lighting ceremony, Dr. Urmila Senapati, Senior Professor at KIMS over here, Dr. Ranjana Giri, Professor Pathology and Head of Department KIMS, and Dr. Anandi Lobo, sorry. I'm very sorry, my bad, sorry. Dr. Anandi Lobo, Senior Consultant Uropathology from Raipur. Can we please have the lamp lighting? Sorry. Can I please request Dr. Ranjana Giri to share a few words and formally welcome the gathering?
Thank you, Romila. So I extend my heartfelt gratitude to all the delegates and faculty members for joining us at Kalinga Institute of Medical Science. And your expertise and valuable time will undoubtedly make it the event meaningful and vibrant. Thank you.
Thank you so much. So keeping the time on track, we would like to proceed towards the first session of the event, Hot Topics in Urologic Pathology. I would like to welcome and call upon Dr. Christina Maggi-Guluzzi to please come up for the first talk of the day, of the session, and of the event. She would speak about multiparametric MRI in prostate cancer diagnosis and management, the role of pathologist. Over to you, ma'am.
Good morning, everyone. Thank you very much for the nice introduction, and thank you for inviting me. It's okay? To this wonderful place. It's a great pleasure to be here with all of you. My name is Christina Maggi-Guluzzi, and I'm the professor and chair of pathology at the University of Alabama at Birmingham. The topic of my presentation is multiparametric MRI in prostate cancer and what's the role of the pathologist. I have no conflict of interests. So prostate cancer, as you well know, it's a very common disease, the most common actually non-skin cancer in men in the Western world, and the second leading cause of cancer death in the United States, with about 300,000 cases actually, new cases that are expected, estimated in in 2024 and about 35,000 deaths. The incidence has increased actually by 3% annually from the 2014 to 2020 due to probably some of the changes in the PSA screening after 2 decades of decline. Genetic is a major contribution of the disease, and family history can increase the risk up to 4 to 7 folds. There's extreme variability in the disease outcome, and this is one of the reasons why there are challenges in trying to actually tailor the treatment for prostate cancer to each individual patient. Screening of PSA is a widely used, of course, serum biomarker, although not perfect, that we use for screening, that typically starts at age 50 to 55, but can go as early as 40 for patients with family history or with high-risk disease, either related to race, ethnicity, family history, or also other inherited factors. Typically now the common screening is based on the fact that if the PSA is elevated or the DRE detects a lesion that is suspicious for prostate cancer, a thrust biopsy is usually done to determine if there is prostate cancer in the lesion. And if there is indeed prostate cancer, then the role of the pathologist is to provide information to distinguish between insignificant prostate cancers versus significant prostate cancer, and so provide information that will determine the treatment for that lesion versus active surveillance versus active treatment. Now, PSA, however, is a low specificity, and thrust biopsy can underestimate prostate cancer extent and also grade. Now, the smart screening, as has been referred to, is a screening where instead of just using the PSA and the prostate biopsy, with the advent now of MRI, they can improve prostate cancer detection and characterization. The MRI will be included in this pathway, so you can see that in addition to the evaluation of patient potential risk like age, family history, PSA, and other markers, the use of multiparametric MRI and MRI-guided biopsy is what has been included more recently in the SMART screening. Now, I'm not an expert on MRI by any means, but I thought that since I was giving a talk on MRI, maybe to mention a few words regarding the multiparametric MRI, some fundamentals. So typically, when an MRI is done for prostate cancer, there are the T2 weighted images that measure the water content that are important for the anatomic evaluation of the prostate. And then there's 2 functional studies that I also headed that will increase specificity and sensitivity. One is the diffusion weighted imaging. The other one is the dynamic contrast enhanced. One of which measured the water diffusion, the other the contrast flow. Now, the PIRADS is what has been used to actually standardize the reporting of finding, and is based on these PIRADS scores that goes from 1 to 5, where lesions that are 1 and 2 are non-visible on MRI, so most likely tend to be benign or probably benign. PIRADS 3, there's a possibility of malignancy. PIRAD 4 and 5, they're likely to be malignant. And you can see on the right side of the screen the correlation actually with the evaluation of the histopathologic examination, showing that most of the lesions, that are actually PIRAD 5 are detected on histopathologic examination. Meanwhile, only 40% of the lesions that were reported as PIRAD 2 are actually visible on histology. There is definitely a correlation between the MRI visualization and the Gleason pattern correlation. As you can see, the higher is the Gleason pattern, the more likely the lesion to be visible on MRI. And usually, in fact, the low-grade lesion may be PIRAD 3s, meanwhile the higher are more likely to be higher grade and so more aggressive disease. Now, typically, once a suspicion of prostate cancer is detected, the patient undergoes a 12-core biopsy. That's the systemic approach. But if the MRI evaluate and detect a potential lesion, then additional target biopsy are usually included. They can be associated with more than 1 core, like 2 or 3 cores, or even additional, depending on the amount of lesion that the MRI evaluates. And then those biopsies, of course, are submitted for pathologic evaluation. And the pathologist will provide Gleason score and other parameters that are useful for management. So what is the role of the pathologist? So in addition to, of course, confirming a diagnosis of prostate cancer or a diagnosis of benign, provide additional information that are important for planning initial therapy. They can help also assessing prognosis. They will estimate the likely benefit of adjuvant therapy in some cases, determine recurrent disease following treatment if the MRI, for example, is done for staging or for follow-up information, and also understand the natural history of disease and provide additional information that correlate with the tumor outcome. So there are some parameters that are essential that need to be included in the reporting of cancer, prostate cancer-bearing biopsy. The histologic type, Gleason score, and the grade groups, tumor quantification, and also other things that may be detected on the report, on the biopsy actually, like perineural invasion, extraprostatic extension, seminal vesicle invasion, that although are not very common, but it's important to include it in the report if indeed they are detected. So the reason why it's important to report the histologic tumor type and distinguish between acinar and ductal adenocarcinoma, those tumors have different characteristic in terms of outcome and also metastatic appearance. So tumors may have different metastatic association depending if they're acinar or ductal. The Gleason, of course, is very important to allow to assess the risk associated with the tumor. 3 different patterns are recognized, pattern 3, pattern 4, and pattern 5. Since my colleague later will talk about Gleason, I'm not going to spend too much time on the Gleason. The other things that we will include in the pathology report is the percentage of pattern 4 for tumors that are in the Gleason score 7 group, so either 3 plus 4 equals 7 or 4 plus 3 equals 7, because there are plenty of data showing that indeed the percentage pattern 4 is a good predictor of the prostate cancer staging on radical prostatectomy, and also an independent predictor for biochemical recurrence. And last, but definitely not least, one of the other parameters that needs to be included in the pathology report is the presence of unfavorable pathologic features, particularly the presence of cribriform morphology and intraductal carcinoma. There are multiple studies that have been actually highlighted in this very nice review published in Urology 2018, showing that indeed the presence of cribriform glands is associated with a lot of adverse features in the tumor, such as extraprostatic extension, upgrading, increased risk for margin positive, biochemical recurrence, and lymph node metastasis. So those are things that needs to be included in the pathology report. As I mentioned, if present, the presence of perineural invasion, they may provide some information, particularly for patients who may be treated with radiation. Extraprostatic extension, of course, on biopsy will be an helpful feature that helps staging. It's not very common, but can be seen in some cases. And seminal vesicle invasion, particularly if the urologist has been targeted the seminal vesicle, but sometimes they may be seen in the biopsy even without targeting these areas. Now, it's very important the pathology correlation with the MRI finding, because these improve actually the understanding of the results and also the understanding of the implication between what we see under the slides and what the radiologist sees in the MRI. And because also there's a learning curves in terms of understanding the different lesion, the pyrite, so it's very important in each institution to try to have a detection rate as a gold standard for each pyrite cohorts. So that's a good feedback between the pathologists in a multidisciplinary effort. It's important to correlate the finding from the MRI with the one from either the radical prostatectomy, so that one can better understand why, for example, a specific target was missed, or why a lesion that is present in the radical prostatectomy was not detected on the MRI. And so this is a learning experience. And this brings us to the point of the fact that not all the lesions that are present in the radical prostatectomy are visible on MRI. So there are some lesions that are visible and some that are labeled as invisible or MRI negative. This is a correlation study that we did when I was at the Cleveland Clinic in correlation with our radiation oncologist. So this is an example where, for example, there's a lesion here highlighted in red that was visible on MRI and also visible on the radical prostatectomy. This was a tumor with a pattern 3 + 4 = 7 with a minor component of Gleason pattern 5. But in the same lesion, there was also another periurethral lesion here that you can see highlighted in light blue that was not visible on the MRI but was actually present in the radical prostatectomy. This was actually a clinical significant tumor with a Gleason score of 3 + 4. But that was completely missed by the MRI. So these are important correlations that will help us better understanding the role of the MRI. Now, what is the role of the MRI in cancer diagnosis? Well, it's twofold. One is actually in the diagnosis and one providing information for management. So let's tackle the diagnosis first. So this will improve detection, biopsy guidance, and also staging. So the challenge with prostate cancer is that this is usually a multifocal disease, and there's also some degree of tumor heterogeneity that may be responsible for undersampling. Sometimes a prostate biopsy may, for example, like in this case, get a lesion that is the low-grade lesion, but miss a high-grade lesion that may have been completely missed by the biopsy. So this heterogeneity has been one of the reasons for the pre-treatment clinical pathologic underperformance. So the MRI, of course, has emerged as a useful tool that may help with the diagnostic modality in detecting some of those lesions, since now we have an imaging that allows us to see the prostate in a more holistic way. Now, the fact that this is a pivotal study that was published a few years ago, showing that MRI-targeted biopsy actually have an opportunity to increase 12% the detection of clinically significant cancer and decreasing 13% of insignificant cancer. That these are not the one where we want, of course, to focus on. A following-up study showed, however, that targeted biopsy per se by themselves may miss about 9% of significant cancer, so that typically in the presence of an MRI lesion, not only there is a systematic, but also systematic plus a targeted biopsy. So the combined approach, it's probably a better approach that identify more likely to identify a higher number of cases that are clinically significant without increasing the detection of clinically insignificant tumors. So MRI diagnostic, what are the patients that will benefit for MRI-targeted biopsy? Well, patient with a clinical suspicion of prostate cancer, despite having had multiple prostate biopsy negative, patients that are biopsy naive, and also patients that are considered for active surveillance. Now, this is an example of MRI in a patient with a prior biopsy negative, and you can see that the MRI identify a lesion in the anterior portion of the prostate. Those tumors are very difficult to detect by biopsy, so the MRI actually highlights the location of the tumor, and you can see that there's associated with a significant tumor. This was a Gleason score 3 + 4 = 6. There's at least a couple of papers showing that indeed there's a lot of value in multiparametric MRI, particularly for tumors that are on the apical portion of the prostate or anterior portion of the prostate. This is an example of a tumor of an MRI done in a patient with a biopsy naive. So this patient has just an elevated PSA. You can see here, although it's, I apologize, it's very low character, but the PSA was 8. So the patient, instead of going directly to the biopsy, the clinician decided to do an MRI. So if the MRI would have been negative, the patient would have not been followed by a biopsy, but the MRI actually identified a periurethral lesion. The lesion was targeted, and the biopsy, you can see, shows a Gleason score 4 + 3 = 7. Particularly for these apical periurethral transition zone lesion, the MRI is actually a very good tool to identify those lesions that may actually have been missed otherwise on a just systematic biopsy. And last but not least, definitely a major role in active surveillance. This is a 65-year-old male that underwent a systemic biopsy, 12-core biopsy. You can see that there's only one biopsy that was positive with Gleason score 3 + 3 = 6, involving only 10% of one of the cores. Now, this will be a good candidate for active surveillance, but the risk stratification here is very important. So the classic definition for a candidate for active surveillance is based on Epstein criteria, where the Gleason score for the tumor is either Gleason score 6 or less. The number of cores involved is less than 3, with less than 50% of involvement in each of the cores, and the PSA density is less than 0.1.5. Although these criteria are the ones that probably are most widely used, different institutions you can see here that have used different criteria to enroll patients on active surveillance. So in some institutions, also patients with Gleason score 7 and a small percentage of pattern 4 may be included in an active surveillance program. So the importance of MRI for the active surveillance is to show that indeed in a patient like the one that I presented, you can go back, do the MRI, and make sure that there is no additional lesion that were missed. And so the biopsy of the lesion that is identified on MRI showed again similar morphology that the one was previously detected by the systematic biopsy, showing Gleason score 3 + 3 = 6, providing some comfort that indeed we did not miss any lesion of higher grade or stage. So this is typically the approach for the use of MRI on active surveillance selection. You can see in addition to the clinical tools like PSA density, of course, and the biopsy, the MRI is important to make sure that these are the right folks that are included in the MRI, in the active surveillance program. And then also the importance of the MRI as a follow-up over time for those patients that are on active surveillance. In terms of staging, the MRI is also a very good tool for staging prostate cancer. Just want to remind you that the staging is based on the JCC 8 edition, where a tumor confined to the prostate is staged as PT2. A tumor that is actually goes beyond the confine of the prostate is staged as PT3A, and a tumor that invades the seminal vesicles is staged as PT3B. And I want to share with you a few examples where the MRI, like in this case, shows a lesion in the right posterior peripheral zone. The lesion is identified on the radical prostatectomy as a tumor with a Gleason score 4 + 3 = 7. This lesion is shown at the radical prostatectomy, extra prostatic extension, and also involvement of the seminal vesicle. Now, these are examples where MRI is used to stage also other tumors. This is a nice tumor on the apical portion of the prostate anteriorly that was considered, of course, extending beyond the confine of the prostate anteriorly, and this is confirmed by the radical prostatectomy, where there is a tumor in the fat in the anterior portion of the prostate represented extraprostatic extension anteriorly. And in the other microphotograph, you can see here in P and Q a tumor that actually has some kind of irregularity at the peripheral zone, so suspicious for extraprostatic extension at the peripheral zone on the left side, that is shown actually confirmed on the radical prostatectomy as a posterior EPE. Here's an example actually of two cases, one with focal extraprostatic extension where there is an area suspicious on MRI, and definitely the case that is here on microphotograph W, where you can see a large tumor involvement and extension beyond the confine of the prostate, corresponding to non-focal extraprostatic extension on the radical prostatectomy. Now, it's important to distinguish between focal and non-focal extraprostatic extension. There are studies showing that indeed this correlates with biochemical free survival. Now, in terms of staging also, the MRI can be helpful in showing tumor that may extend beyond the confine of the prostate to involve another organ. This is an example where the actually plane between the prostate and the rectum seems to be obliterated. So this was considered suspicious for involvement of rectal involvement, and indeed, the biopsy showed rectal involvement that is staged as T4. And on the bottom portion of the microphotograph, there's a large tumor extending on the right side to involve also another organ, the seminal vesicle, corresponding to a T3b. In terms of staging for the MRI can also help to define the possibility of margin positivity. This is a tumor where the contour of the prostate is so irregular and it looks like the tumor is getting close to the plane where the surgeon is going to be able to provide the surgery. So this was indeed proven to be a positive margin. And for lymph node metastasis, although the MRI is probably not the best modality, in some cases can also be helpful to identify these enlarged lymph nodes, as you can see in this example here, that actually were proven to be metastatic lymph nodes with prostate cancer. In terms of management, some of the information that I already shared with you are important to define how the tumor will be managed. So which candidate will be able to be included in an active surveillance program versus the one that will be considered for either surgical or radiation. And now the most important thing that the pathology can provide in terms of information for the management is to exclude the presence of some of these unfavorable pathologic features that I mentioned before, cribriform morphology and intraductal carcinoma. So how is the MRI, how good is the MRI detecting the Gleason pattern 4 and both cribriform and intraductal? There's different studies that have been done in the last few years. Some study from the past showed that actually the visibility of cribriform tumor was lower on MRI. But however, additional studies more recent show that the MRI actually can improve the detection of tumors that have either cribriform or intraductal morphology. And here there's another study showing that the majority of the cases that were MRI visible had also the one that were with either cribriform or intraductal, with the exception of 9 cases in this study where, despite the fact that there was a component of either intraductal or cribriform morphology, they were MRI invisible. Another recent study have shown in a large cohort that actually MRI offers a high sensitivity for the detection of cribriform morphology. Some of these tumors were also larger, so the one with cribriform morphology were larger in volume, and they, as you can see here, they were more likely to be visible. 95% of the tumors were visible, compared to only 65% of tumor without cribriform architecture. So this is a good news, because of course, if the MRI would miss those lesions with unfavorable morphology, this would not be very good. Now, this is another study showing actually the value of the stroma in the detectability on MRI. And you can see that tumors that are detectable on MRI seems to have a higher component of cellular versus stroma, versus tumors that are MRI undetectable, where there is more stroma, like 50% of the tumor is compared by stroma versus the component of cellularity. So in this case, it seems like the higher the level of the stroma, the less likely the visibility on MRI. And the same study showed that most of the tumors that were MRI detectable, they had intraductal carcinoma but with stromal invasion. Meanwhile, tumor with only intraductal carcinoma without stromal invasion tended to be more MRI undetectable. The same study showed also that in addition to the morphologic appearance with the different pattern 4, what really matters is the degree of cellularity. So even if you have cribriform glands, right, not all the cribriform glands were detectable. It depends on the degree of cellularity. And in fact, the ones that were very cellular were detectable. The ones that had a lot of stroma in between, they were not. So the detectability of cancer-specific, the cancer-significant prostate cancer was strongly associated with the amount of cellularity versus stroma versus luminar space. So the higher the stroma and luminar space, the less likely the visibility on MRI. Now, the future is also associated with other information that we can deduct from the MRI. The radiomics is an important analysis that does a quantitative imaging of the feature that the MRI can detect. So the hypothesis is that some of these imaging can capture actually phenotypical things of the tumor. so that you can extract from an image some of the things that are associated with biological diversity of tumor. If this is true, this is of course very powerful. There are studies showing that this is actually a thing that can happen. So if you combine together then the MRI imaging data with the radiomic and also the genomic, and this is called radiogenomics, you can actually combine these things and improve the detectability and also the understanding of tumors that may have a higher degree of, for example, aggressive behavior. And this is just briefly, I can mention one of the studies that I was involved with Anant Madabushi, showing one of these, approach in terms of radiogenomic. This was a study where 200 radiomic features were extracted by multiparametric MRI to develop a risk score, and using that risk score assessment, we were able to identify tumors that were MRI visible and MRI invisible, and to improve actually the detectability of this lesion. So take on point, I think this is my time is up, all the bells are ringing. So in addition to accurate prostate diagnosis, the report actually should include all the elements that are important for estimating malignant potential, such as unfavorable features, cribriform and intraductal architecture, stromogenic tumor, and some of the staging parameters that I mentioned. It's important to correlate the pathologic finding with the MRI findings so that we can keep learning from each other with this type of correlation. Targeted biopsy can improve risk stratification by directing the pathologic and also the genomic tests into the area that are higher risk index lesion. And most likely in the future, integrating different modality may provide a very good benefit for enhancing the individual performance of some of these characteristics, and also for overcome some of the limitation of the MRI and also the other technology. Thank you very much for your attention. And
thank you so much. Can I please request to be you to be on the stage while I call upon the esteemed chairpersons, Dr. Sameer Kumar Behra, Dr. Kamudi Patnaik, Dr. Sudipta Mahakur, Dr. Liti Mohanty, Dr. Lipika Lipi. Can you please come on the stage? Initially, deliberately, we could not call you so that you settle after the breakfast and enjoy the wonderful talk, having seat over there. We can now proceed.
so do you want us to sit?
I'm sorry?
Did you want us to sit?
Yeah, please. Okay. There'll be a picture post the completion of this talk. Now, right now, would like to take upon the question and answer from the audience.
So anybody has any question? Yeah.
Question.
Thank you for such a brilliant, comprehensive talk on multiparametric MRI and now this new era of targeted biopsies. How have these recent studies shaped and changed the clinical practice and the biopsies coming to you on your desk? I'd be really interested to know, because the precision study in 2019 changed EAU guidelines and clinical evidence for practice. And at UCLH, we are actually only looking at targeted biopsies, which is a huge shift from trusses and templates per patient. Being able to see just one or two sites has definitely changed our work inflow.
Thank you very much. Yes, I think it's changed also our workflow. So most of the time, actually, in our institution, we see the systemic plus the targeted biopsy. But there are some clinicians in particular situations where they may take only the targeted, because maybe the patient has been followed up, so or they see a lesion that is very highly, high risk, and so they go just for the target, or they do a limited systemic plus the target. So definitely has changed the way we practice. And you can see that most of the time the target are indeed on target, so they are positive. And so that is a good, I guess, reassurance that maybe in the future one could use and focus more on those. Now, some of the new parameters like the radiogenomics and the new things probably have not impacted yet the field, but I would assume that this will be something that is going to come in the next few years.
I think that will also be reflected with the, correlation with the proteomics and transcriptomics
And that's why I think it's very important in pathology we are involved in this conversation, in this probably multidisciplinary approach, because I think now the genetic tests maybe are not used similarly in different institutions. For example, when I was at the Cleveland Clinic, one of the urologists would use it very much for a specific patient, like if there was considered for active surveillance. At UAB, it doesn't look like we use it very frequently. It depends also on the patient population and also on their, insurance, of course. Yeah. But I would see that there is value now with the targeted, because if you know that you are in a high-risk lesion, it would be more meaningful to send that lesion for genomic and see what the genomic would indeed detect. And a lot of the study done in the past did not include any information regarding the crib reform, the intraductal. There are not things that are coming up and they're very important. So I think we need to do additional studies to see how now, in view of this new discovery of this unfavorable pathology, how that affects both the genomic and the MRI. Thank you for your question.
Next question.
Thank you, Christina, for a very comprehensive talk. I just wanted to make one comment that as a pathologist, it is very important for us to correlate with the MRI findings, but same time not to get biased. That is particularly in active surveillance follow-up biopsies, we often get on MRI, there is a staging reclassification and all that. So they also provide low ADC values, which may indicate a higher Gleason grade, but all that is important for us to correlate, but not same time get biased on that.
Yeah, well, of course. Yeah. Thank you, Raj.
Any question?
There's another question here, I think.
Any question?
Thank you, Dr. Christina. That was wonderful. We in India, I think, I don't know about the other centers. I don't think we're doing too many targeted biopsies. But over the last 2 years, these have been flooding our table. But our experience was that the targeted was actually missing the target, which is contrary to what you said. Is it because we're at the bottom of the learning curve?
Well, that I think there is that learning curve. So that's why it's very important at the beginning to do that correlation, because this is a learning experience. And I can tell you that sitting together with the radiation oncologists, right, doing this MRI and comparing with the mapped prostate radical prostatectomy, you learn a lot. Right. So that's a need for that learning experience so that we can provide information and we can both increase the detectability.
Accuracy.
So yeah. I think you're in a learning curve. I mean, and I'm sure that correlation is important.
Right. Thank you so much.
And I'm sure it's different for each institution. That's why the slides actually regarding that correlation come from my urologist. It's very important to make sure at the beginning that there is some kind of follow-up information and comparison between the MRI, what the urology think, and what the pathology finds, so that you can have that, improved detectability kind of thing.
Right. Thank you so much.
I think there's a comment in the back.
Thank you, Dr. Christina, for a very wonderful talk. We are sometimes fought with a very difficult clinical situation in the sense the patient has come with a TURP biopsy. So patient has obstruction, somebody does a TURP and we get a 3+3 Gleason on TURP. And patient doesn't have an MRI. And doing MRI after TURP becomes a problematic. Dr. Kochikar is here, he may comment on that. And then to put the patient on active surveillance on a TURP becomes a difficult question, because prostate is a peripheral cancer and you need to have peripheral biopsies before you put the patient on surveillance. And doing MRI in such a situation may be fraught with problems. So maybe some clinician can also. This is a situation which we come across not very often, but this does happen in the clinical setting sometimes.
Yeah, I think it's a valid point. But I think the trends are changing. What Santosh is mentioning is probably the good old days where people used to do TURs without doing biopsies and sort of, having PSAs and MRI. But I can tell you now the MRI has progressed so much, there is no problem at all. If you have undergone sort of, TURP, doing an MRI is not a problem. And we do pick up these sort of lesions on an MRI. Agree, we do sort of transrectal biopsies, either MRI guided or transperineal biopsies, to make sure they do have indolent disease before we put them on active surveillance protocol. So that's not an issue.
regarding the yield of genomic testing using multiparametric. When I have like multiple cores and if I have picked up the areas which has the cribriform pattern 4 or the introductory histology, and you get those areas for genomics, you get a very good yield. And so that is something we should look forward to. And secondly, we have a radiologist on the panel, and she does a lot of work on this. We would like to have your comment on this.
Thank you, ma'am, for such a vivid discussion on MP-MRI of prostate. You told everything, like the role of MRI in detection, diagnosing, then staging, and also you threw light on radiomics also, the latest development in this. And you also told about the learning. She also told the learning curve, that is very important. Madam told that like apical region tumors, those may not be amenable for biopsy. We may not get yield. So MRI is better for detecting such tumors. But ma'am, one like some fallacies she highlighted. One more fallacy which we encounter, ma'am. Sometimes the benign hyperplastic nodules, sometimes they enlarge so much and they appear dark also and restrict on diffusion, and they are impinging on this peripheral zone. And sometimes they also, we feel as if it is a cancer. So here also the pathologist has, sometimes we may give it as a Pyrex 4 lesion also. So sometimes that come out to be this benign lesion. Yep. So these are the many fallacies. And one more thing, ma'am, I would like to ask you is like suppose we detect a Pyrex 4 lesion and there is no extra prostatic extension something. So would you recommend for a pre-op targeted biopsy 12 core or direct, because nowadays people are also opting direct surgery?
Well, I don't know if I'm in a position to make a recommendation. Since I'm a pathologist, probably will let the urologist in the room, make that recommendation. I don't know what would be the best approach.
But you told sometimes one tumor is detected on MRI, but other tumors might be missed. So
yeah, and that's why I think it's very important, this correlation with the MRI visible versus invisible. Because if the MRI detects, let's say, the lesion that is the lower grade or the lower stage, but misses the one that is higher grade and higher stage, then of course we cannot have the same reliability. But I mean, from the study that I've seen, it doesn't seem like this happen very commonly. So I think it's a very good, gauge on what to do. But I mean, as you mentioned, I mean, I'm sure there are lesions that were considered like a Pyrex 4, particularly in the transition zone. So I know it's a lesion, it's difficult sometimes to detect, right? So they may be benign instead of being a malignant lesion. So that's why I think the pathologist needs to be involved in this learning curve. But thank you for the comments.
Thank you so much.
Thank you. Okay, we have questions? Yeah.
Yes, go ahead.
Thank you very much for the wonderful talk. And this could be just a curiosity, actually, but I've had 3 cases this year, and I was talking to Sean Williams, and he had similar cases too, where you have all the systematic sampling positive for clinically relevant prostate cancer, and the target is the only area that's negative. I just wanted to see if you had experience with anything like this before, and if there's any theory of why that could happen.
I don't know. I cannot recall of a case where the entire systemic biopsy is positive and the MRI targeted biopsy is negative or as a lower grade. Now, there are times in which you may have cancer in the systematic biopsy, nothing in the target. Yes, definitely that happened. But something of what you experienced, at least I don't recall. But again, I don't know. It depends also. Now, disclaimer. Patient population. The patient population that the Cleveland Clinic is handling, I can tell you, is very different than the patient population that I'm seeing now at UAB, where there's a lot of patients that are probably uninsured with high disease. I see a lot of high-grade disease, like Gleason score 4+4, 4+5, that I probably have not seen when I was in my 15 years at the Cleveland Clinic. So I think the patient population might have also something to do with it.
Thank you.
What was there when you said, was it a Pyrex 4 lesion? 5. And in that particular focus, there was no tumor. At least I have seen couple. And what we saw, either there is extensive fibrosis or the sclerosing adenosis kind of stroma, which comes in MRI and light up as a pyroid 4 lesion. And the second one as a hyperplastic nodule. And it was like a little tiny nodule. So that could be the region we missed it. Hey.
As a center that does a lot of HIFU and focal treatments at UCLH, 1 or 2 cases we have seen, and that always alarms our radiology team, which is very monospecialist in only reporting prostate cancer within the radiology team. And those were cases that you could explain, post-treatment related changes of HIFU, otherwise post-HIFU changes. But other than that, we haven't encountered either in a huge cohort of patients, any that have been missed on the targeted at least.
Maybe our radiology colleagues have some insight into it.
Is that it? Thank you, ma'am, for a wonderful interactive session. And as a pathologist, I'm happy to know we still have the last word. Thank you.
So this conference is different in that sense. We have equal contribution from all the aspects of, and you people are the backbone of the any disease treatment, you can say, radiology, pathologists. Without your inputs, we are blind. So
thank you for appreciating us. We appreciate you guys.
Thank you so much. Can I please request the chairpersons for a picture with Dr. Christina? Thank you. Thank you so much. Now we quickly proceed towards our next session. Thank you, Dr. Christina. It was really, you enriched us with new aspects, the new protocols and guidelines. Thank you. Esteemed chairpersons, I would request you to be on the dais. Ma'am, okay. Yeah, for the next talk, I would request our next speaker, Dr. Ming Zhao, to please come and speak on the contemporary update on prostate cancer grading.
Namaste and good morning. So I'm going to talk about these 3 things. So first of all, I'm going to very briefly talk about the history of prostate cancer grading, that is Gleason grading, and how it has been evolving in the last 6 decades. Then I will focus on the modified Gleason grading criteria, and I'll talk about the recommendations for reporting a Gleason grade. So for this audience, I really don't need to tell you, how Gleason system was developed and how do you do the grading. But I do want to say that Gleason system is the grading system for the prostate cancer worldwide. And let me see. So even we have so many different omics tools like genomics and proteomics and other things. And the Gleason grade still remains as the single most important prognostic factors and is used in all risk stratifications for the patient treatment decision making. But the original Gleason system has evolved and changed significantly since its inception almost 60 years ago, for many different reasons. But in essence, it has been evolving to adapt to the changing clinical practice of prostate cancer diagnosis and treatment. So if you look at these changes, they can fall into 2 broad categories. First one is definition, right? So each Gleason pattern, it has been more precisely defined, and how do you grade the cribriform cancer glands, and how do you grade these new entities and subtypes. Other changes are considered operational. For example, how do you report the Gleason grade in a specific clinical settings? But most important changes they include, first, the eliminations of Gleason pattern 1 and 2 for practically any type of specimens, biopsy, TURP, and the radicals. So Gleason pattern 3 is the lowest grade. And also, another important change is a strict definition of the Gleason pattern 3. So only those well-formed, discrete glands are now graded as a pattern 3. So this results to a more restricted and homogeneous pattern for grade the Gleason pattern 3. And the other patterns that were considered the Gleason pattern 3 in the past, including poorly formed glands, small cribriform glands, are now reclassified as pattern 4. As a result, the pattern 4 has expanded and becomes a more heterogeneous pattern. Another important the change is in the biopsy. In the highest pattern, which is Gleason pattern 5, it should be included in the final Gleason score as a secondary pattern, regardless of its the amount. One example is here. This biopsy contains 68 pattern 3, the 30% pattern 4, and the 2% pattern 5. So the final Gleason score should be 3 plus 5 equals 8, not 3 plus the 4 equals 7. All these changes have led to the upward Gleason grade migrations. So if you compare the before and after this modified Gleason the system that was implemented, so definitely 2 and 4 has disappeared, and Gleason score 6 has the decrease by almost 10 percentage point, and then 7 has increased by almost 10 percentage point. 8, 9, 10 remains relatively the same. And this modified Gleason system has certainly improved inter-observer reproducibility, biopsy radical grade correlation, and also has improved the prognostic predictions by Gleason grade. Another important change for the Gleason grade is converting the Gleason scores, which ranges from 6 to 10, to a grade group, which is from 1 to 5. This was first proposed by Dr. Jonathan Epstein, but I want to emphasize that the grade group is not fundamentally different from the Gleason the system. And it is actually based on the Gleason system and represents a normal way to group Gleason grades. So when the Gleason score is 6, you have a grade group 1, 3 plus 4 is 2, and so on and so forth. But it does simplify and clarify the risk categories and improve the communications with the patients regarding their risk, the cancer diagnosis and management. For example, for the grade group 1 cancer, it is a low clinical risk, and these patients are recommended to undergo active surveillance. And on the other hand, for the grade group 2 cancer, it is a favorable intermediate clinical risk, and some of these patients can undergo active surveillance or others, depending on other clinical and radiological findings, can receive the definitive treatment. One of the very important consequences of the modified Gleason system is now Gleason score 6 or grade group 1 cancer has become a disease of exceptionally excellent prognosis. The pathological outcomes after the radical prostatectomy is excellent. The local, the invasion is rare, including extraprostatic extension, seminal vascular invasion. And these, the Gleason score 6 cancer detected in the radical prostatectomy is incapable of the regional lymph node metastases. And also they have really good clinical outcomes. The cure rate for the grade group 1 cancer after the radical prostatectomy is almost 100%. And if these patients are put on the active surveillance, then the 15-year likelihood of metastases or die of the cancer is very low, 0.1%. because of these findings, starting more than a decade ago, many clinicians, mainly urologists, they have proposed to remove the cancer label from the grade group 1 cancer, call it non-cancer. As the expedient way to tackle this overdiagnosis and overtreatment of grade group 1 cancer, because it is likely to be indolent prostate cancer, right? And so there is a recent the survey of the clinicians and also the pathologists. So almost 50% of the clinicians, they actually are in favor of renaming grade group 1 cancer as non-cancer, right? So, but for pathologists, right, they take an entirely different stand. So recently, GUPS and ISUP conducted a separate surveys of their members. Both surveys yielded very similar results. The 80% of the pathologists are against such a name change. Their arguments include the grade group 1 is a cancer biologically and genetically. And also grade group 1 cancer, the may be aggressive cancer, but misclassified due to biopsy undersampling, grading error by pathologists, and discrepant morphology and biology. So I have to have this disclosure that I actually support the name change. So, but I would encourage the pathologists to consider and adopt a patient-centered approach to the diagnosis of grade group 1 cancer, because we need to understand the impact of the cancer diagnosis on patients' overall well-being and how they make their treatment decisions. All right, now let's shift the gear. They talk about these Gleason patterns. So the Gleason pattern 4, we know, has 4 subpatterns: polyform glands, fused glands, cribriform glands, and glomeruloid glands. And the polyform glands, according to Dr. Shah's study, is the most common subpatterns in the contemporary biopsy in the series. It also happens to be the most difficult, the pattern 4, to diagnose. So in order to they find out what the pathologists use, the morphological the features they use to grade the polyform glands at pattern 4. So Dr. Shah and I did the studies, and we found that pathologists actually rely on 2 features, right? The locations of the polyformed glands, whether they are right at the immediate adjacent to other well-formed glands, or they are sort of intermixed with well-formed glands, or they're clustered and away from other well-formed glands. And also, the second feature is a number of these polyformed glands, whether you see less than 5, 6 to 10, or more than 10 glands in a focus. So if you see the few of them, 5 these polyformed glands, regardless of their locations, you should not grade them as pattern 4. If these polyformed glands are immediately adjacent to other well-formed glands, you should not grade them as the pattern 4, because they most likely represent tangential sectionings. It's only when you see more than 6 of these polyformed glands, right? And they are not immediately adjacent to other well-formed glands, and then you can grade them as a pattern 4. Here's one example. These are polyformed glands, but you only see a few than 5 polyformed glands. You shouldn't call them pattern 4, and grade them as 3 plus 3 equals 6. And in these 3 pictures, you see different numbers of these polyformed glands, less than 5, 6 to 10, and no more than 10. But all these polyformed glands are immediately adjacent to other well-formed glands. Then they shouldn't be graded as pattern 4, because they really represent the tangential sectioning of these well-formed glands. So Dr. Margie Gleason talked about the importance of the cribriform, the cancer glands. So the diagnostic criteria is quite simple, right? You want to see the confluent sheets with multiple glandular lumens that are easily visible at the X magnifications. And you shouldn't see any intervening stroma or mucin within the cribriform glands. And it is probably one of the most important the diagnosis in the prostate pathology. So Dr. Margie Gleason has talked about why it is important, so I'm not going to go through the reason. And I just want to say that it is very important to be able to correctly diagnose cribriform the cancer glands. And there are good news and bad news about the cribriform cancer diagnosis. The good news is it has the best inter-observer reproducibility of all the Gleason pattern 4 subpatterns. But the bad news is the inter-observer reproducibility is still pretty, is only fair with a kappa value 0.4, 0.4. So the reason, I believe, is the lack of a precise definition what should be considered in the cribriform cancer glands. So in order to improve our diagnostic consistency, Dr. Shah and I did another study. We looked at the inter-observer reproducibility amongst the urologic pathologists, and we made recommendations. There's several recommendations how to improve the diagnosis of cribriform cribriform cancer glands. So first of all, our studies have found that these are the features that are diagnostic for cribriform cancer glands. You need to see that there's cribriform proliferation that form these transluminal bridging, or you see these cell cords, the cords of the cells that span from one end to the other end of the glands, spanning the entire diameters of the gland. Shouldn't see the stroma or vessels within the mass, and you should not see the interglandular lumen, the mucin. And if you do see some clear space at the periphery of the cancer glands, this clear space should be less than 50% of the perimeter. So here's a typical example of the cribriform cancer glands. I think everyone would agree, this is a cribriform the cancer because it has a dense proliferation and transluminal bridging. And in this case, you do see several large sort of glands with expansile growth, right? But you do see these clear space at the periphery, and but this clear space is less than 50% of the perimeter of these large glands. Therefore, it can be graded as can be called cribriform cancer glands. We also identified some of the morphological features that the pathologists actually would use to argue against the diagnosis of cribriform cancer glands, including the partial bridging, stromal vessels in the glands, presence of the mucin, the glomeruloid-like pattern, and also these clear space that's more than 50% of the periphery of the cancer glands. I'm going to show you several examples of these glands that superficially resemble the cribriform cancer glands, but they shouldn't be called the cribriform cancer glands. This one, large glands with expansile growth, but you see these stroma or vessels within the glands shouldn't be called the cribriform cancer glands. In this case, you see a mucin in the cancer glands. Shouldn't call it the cribriform cancer glands. In this the picture, you see quite a few large glands, with these partial bridging, meaning that in its cores of the cells, that only extend into the lumen, but that does not span the entire lumen. Therefore, its partial bridging shouldn't be called the cribriform. And this is an example of the glomeruloid the cancer glands, so it's not cribriform. And this is difficult, the case. In this center of the large gland, you see this cribriform architecture, right? But at the periphery of this gland, you see this clear space, right? Certainly more than 50% of the parameter. So there is no consensus on whether you can call it equipiform or you don't want to call it equipiform. So I probably would not call it equipiform. So hopefully our recommendations will help improve the diagnostic, the consistency of the equipiform cancer glands. But there's still some significant issues with the equipiform cancer grading. One of the issues is the quantitative threshold. How many of the equipiform cancer glands or number of the cores, biopsy cores, involved with the equipiform the cancer glands should you see before you associate this equipiform glands with the adverse clinical outcomes? The second issue, the size threshold, because the studies have shown only large the equipiform glands are independent predictors for the clinical outcomes. But there are several definitions of the large equipiform glands. For example, the bigger than 2 times of the adjacent benign glands, or the glands with more than 12 lumens, or most recently, the half of the 40x field, or 0.25 millimeters. Nobody knows which other criteria we need to use for calling the equipiform the cancer, large equipiform cancer glands. And most of the studies actually do not distinguish between large and small. There's another issue, right? Do you need to distinguish the equipiform carcinoma and the intraductal carcinoma? Well, because both show the equipiform morphology, and not always the two distinguish based on morphology if you don't do the immunostains for basal cells. But the good thing is both are associated with the increased, so share the same genomic alterations, and both have the significant negative impact on the prognosis. It's really not critical to distinguish the equipiform carcinoma and the intraductal carcinoma. As a matter of fact, this proof of concept study by the Van Linders et al., they actually show that if you incorporate these equipiform morphology, both the equipiform carcinoma and intraductal carcinoma, in the Gleason grading system to derive at so-called equipiform Gleason grading, right? This actually provides a better discriminative power for the clinical outcome, and this is a simple modification of Gleason grading and really important for the decision making for the patients with the current grade group 2 prostate cancer. So let's talk about the Gleason pattern 5 again. It has several these subpatterns: solid sheets, core, single cells, communal necrosis. And again, in order to improve the diagnostic consistency and the reproducibility, Dr. Shah and I also did a study of the observed reproducibilities amongst urological pathologists. We also put out some recommendations. So I'm going to run through some slides to show you the major conclusions of this study. First of all, if you see these large nests and with more than 2 the nuclei in the nest, and they have this uniformly distributed nuclei, it should be graded as a pattern 5. I'm not saying that you should count how many nuclei in these nests, but if you eyeball it, these nests are large enough, it's pattern 5, right? These large nests, even if they have non-uniformly distributed nuclei and with these vague luminal formation, it's still pattern 5. But for these small to medium-sized nests, less than 20 cells per nest, they should not be called the pattern 5. This is the pattern 4. For the single cells, cores of cells, if you see more than 10, they are clustered or intermixed with other polyformed glands, you can grade it as a pattern 5. On the other hand, if you see just a small focus of the single cells, cores of cells, and there are fewer than 5 in this focus, shouldn't grade it as pattern 5. It's a pattern 4. In terms of the the intraluminal necrosis, coagulate necrosis with the ghost cells, you can grade it as pattern 5, whether or not you see the chiropractic debris. But if you only see this chiropractic debris without coagulate necrosis, there's no consensus whether it should be graded as pattern 4 or 5. And I would not grade it as pattern 5, or just call it pattern 4. And if you see these amorphous material, definitely you don't want to call it necrosis, you don't want to grade it at pattern 5. So the modified Gleason the system also provides the precise the better definitions for how to grade these the subtypes, right? First of all, for the gland-forming subtypes, right, including mucinous foamy gland, signaling-alike cells, pseudoplastic, and ductal, right? The grading should be using the same rule for the usual adenocarcinoma, and based on the underlying architectural pattern, should ignore those subtypes features like mucinous or foamy. Here's one example. This is cancer with the mucinous the features. You can see these cancer glands are all well formed, so therefore this is 3 plus 3 equals 6 with the mucinous differentiation. Another example of these are well formed glands with signaling cell-like cells, and this is a pattern 3. For the non-forming the subtypes are like small cell, pleomorphic giant cell, and the sarcomatoid, right? You definitely don't want to grade these subtypes. And if you see a mixed the gland forming and a non-gland forming, you can certainly the grade gland forming component, but do not the grade non-gland forming component, right? But I think that it's really a moot point here because all these cancers are high grade. So grading post the treatment, right, and the prostate cancer may show significant morphological changes, right, following the treatment. And these the morphological changes are unrelated to the biology that drive the Gleason morphology. Therefore, if the cancer has a significant the treatment change, you definitely don't want to grade them, but you may want to provide a degree of the treatment effect. For the cancer without treatment effect, you can grade them, but you also want to note lack of the significant treatment effect. So let's talk about the recommendations and how do you report these the Gleason grading. These are the most updated recommendations are actually summarized in these 2 publications by GUPS and the ISUP. So first of all, how do you report the Gleason pattern, percentage pattern 4 in the grade group 2 and 3 the cancer? I think Dr. Majigrucci has talked about the scenario, why we need to do that. I'm going to skip this. And instead, I just want to say that we need to report the Gleason pattern in the biopsies on the parts with the grade group 2 and 3, even if other parts in the same the case contains grade group 4 cancer, right? The preferred method of reporting is you start with 5% or 10%, then 10% increment afterwards, so 20%, 30%. But I want to encourage you to focus on the clinically important cutoff, right? Such as 10%, because 10%, 347 with a 10% Gleason pattern 4 may still be eligible for active surveillance. Then 40% or 60%, these could be like 347, but it could be a 437, or 437, but that could be a 347 as well, in 90%, right? 90%, 437 with 90% pattern 4 could be a 448 by some pathologists. And I also want to mention that if the pattern 4 is found in a small focus of cancer, usually less than 1 millimeter in its linear length, right? I don't report a percentage of pattern 4 in these cases. Instead, I will top line my diagnosis as Gleason pattern 4 is present, but not the quantified due to the small the size. And if the pattern 4 is less than 5%, definitely you want to double check to see if the pattern 4 is diagnostic. Right. let's talk about the reporting the tertiary pattern, or the third most common, the grade pattern. So we know prostate cancer is usually heterogeneous, right? They often have more than 2 patterns in the same lesion. One example is shown here. So the rule for reporting gleason patterns, they're summarized here. So most common patterns should always be included in your final Gleason score as a primary pattern. And the highest grade of the pattern of less amount should always be included in the Gleason score, either as a secondary pattern or the tertiary pattern, depending on the amounts and a specimen type, right? So if the Gleason pattern 3 is a tertiary pattern, you just ignore it. And then biopsy and the radical prostatectomies may have a different rule in reporting these Gleason patterns. So first of all, let's look at the biopsy and the TURP specimens. If the tertiary pattern is higher than primary and secondary pattern, so which is a pattern 5, then it should be always included in the final Gleason score as a tertiary pattern. One example is shown here. On the other hand, if the tertiary pattern is lower than the primary and the secondary pattern, then it should be ignored. But the reporting of the tertiary pattern in the radical prostatectomy is very different from the biopsies, because the limited amount of the Gleason pattern, 5 in the 3-4 or 4-3 cancer, they may impact the prognosis to some degree, but not as significant as when it is a primary or secondary pattern. Therefore, a tertiary pattern may not be included as the secondary pattern in the radical prostatectomy specimens. But some genius have figured out that if the pattern 5 is more than 5%, even though when it is a tertiary pattern, it should be considered significant. Therefore, it should be included as the secondary pattern. On the other hand, if the pattern 5 is less than 5%, it should be considered as a tertiary pattern, right? But I have to say that there's really no solid study to validate such the division, right? The 5% versus the less than 5%. Okay. So when you see a minor tertiary pattern in radical prostatectomies, right? That's where the GUPS and ISUP puts out these different recommendations. For the GUPS, it recommends that it should be included as a secondary pattern in the final Gleason score. So if the radical has 98% pattern 3, 4%, or the 2% pattern 4, the final score will be 3, 4, 7. If if the radical has 98% 4 and 2% 5, it should be graded as a pattern of 4 plus 5 equals 9. And ISUP, on the other hand, recommends this tertiary pattern be included as tertiary pattern. So for the first example, it should be 336 with the tertiary pattern 4. Second example, 448 with the tertiary pattern 5. So when the biopsies has a multiple cause and a positive for cancer, they also have different the Gleason scores. The question is, do you need to provide a case level biopsy of the scores, right? And there are 2 potential ways to then you can provide the highest of all the biopsy scores at the case level biopsy scores, or you can do provide a global the score as the case level biopsies, right? But there's really no consensus of what will be the optimal methods. So Gleason, the score really works well right now in the clinical practice for the patient prognosis and management, but there are some shortcomings. And first of all, as Dr. Morphological mentioned, prostate cancer is frequently multifocal, so whether the biopsy will detect this so-called dominant nodule, so index nodule, or biopsy the Gleason score be representative of the entire tumor. We don't know. The answer is, or the hope is, these MRI imaging will be able to help us with the identifying these dominant nodules that we can the biopsy and treat. The Gleason score is the morphology-based, so it's inherently imprecise, and the morphology grade may or may not always correlate precisely with the biological behavior. And also there is the individual the variabilities, right, in terms of the grading. So that will affect the grading consistency and it causes undergrading and overgradings. So the answers to the last two questions will be, so we need to use some sort of objective tools to the grade the prostate cancer. I think Dr. Ming is going to talk about the AI in the prostate cancer diagnosis and the grading. So I'm going to just skip this by saying that the AI can really do a good job because it correlates with the pathologist's grading, and it matches the geopathologist's grading, and certainly in some studies it has surpassed the general pathologist's grading, right? Also correlates with the clinical outcomes and improves the grading consistency and reduce the individual variabilities. And very important, it also reduce the diagnostic times of a pathologist by almost like 2/3 in some studies. So this table lists some of these AI algorithms and they have been approved by the FDA in US and cleared by the Europe for the clinical use as well. So definitely the AI will have a huge impact on our the work as we move forward. So I just want to say that the AI-enabled diagnostic tools can really transform the way we work, and we really need to embrace them now. So this is the summary slides. The Gleason assistant remains as one of the most powerful parameters for the prognosis prediction and the clinical management of the prostate cancer patients. Obviously, it has undergone a lot of significant revisions and will continue to evolve in the future. And modifications have had a significant impact on the prognosis prediction and the clinical management of the prostate cancer patients. So I briefly touch upon that the AI can serve as a variable supporting tool, and the Dr. Majiguchi has elaborated on the multiparametric MRI can certainly identify clinically significant tumor to diagnose and treat, right? I didn't mention that, but hopefully someone will talk about the molecular tests will further refine the risk stratifications and identify potential therapeutic targets. So if we combine, integrate clinical, pathological, molecular markers in IMI, well, that will certainly allow personalized prostate cancer diagnosis and treatment. Thank you.
Thank you. Thank you so much for the lovely presentation. I would request only 3 questions as we are running short of time. Sorry for that. Questions, please.
I have a few questions.
Yeah.
Which grading would you recommend, GUPS or ISUP? Since there's a little variation in both.
So, I would say this. Yes,
or do we write what we have used after we have graded?
There are some variations, right? Those variations are really minor. I think for our the work, right, it's not going to impact our work. So only in very small sort of select areas, like in terms of the whether you should include IDCP in the Gleason grading, right? So now that's one of the areas that generates a lot of controversies. Fortunately, ISUP and the GUPS are coming together, and we are gonna put together the consensus statement. So if you come to the USCAP meeting next year this year in Boston, right? We're gonna have a meeting to discuss this issue. And the after meeting will put out a consensus statement.
Would you want everyone to report the percentage of pattern 4 or pattern 5 in individual course
Yes.
in a 12 core or 15 core?
Yes, every course that has the grade group 2 or 3, I will include the percentage of pattern 4 or 5.
Thank you.
Thank you. Questions?
One question from this side, sir.
Thank you. It was a very nice presentation and elaborate presentation. My query is this, cribriform pattern and IDCP. If both presents the same clinical prognosis kind of thing, if there is no change in management diagnosing either cribriform pattern or IDCP, then why should we go into that pain to differentiate on a pathological slide? Why we cannot club both the things?
I agree with you. And again, we're going to have this in the consensus conference, on this particular topic at the USCAP meeting. And so if you can come, and please join us at that meeting. And you're going to hear a lot of the pros and the cons on these different approaches.
Thank you.
Yeah.
Thank you. Yeah.
May I? Okay. Thanks, Ming. Excellent coverage of a very challenging, complex topic. But I think it's unfortunate that it has become so challenging and complex, especially in grading in radical prostatectomies, where actually the clinicians don't need much from us, from radical prostatectomies, because they have got PSA for monitoring. So they hardly use the Gleason score in radical prostatectomy to make clinical decisions. But unfortunately, GUPS and ISOP, I think we have made this extremely complex and probably unnecessarily complex.
Yeah, so I agree with you in large part, but I think there are some the scenarios where the Gleason score does make a difference for them to do the adjuvant therapies, right? For example, if the high grade and a high stage tumor with the positive margins and all those things, they may, right? They may give the patients hormone or the radiate the surgical pads. I think that's the only time I can think of the Gleason score may make a difference.
Ming, in fact, quickly, I know you're short of time, so I don't want to go on this. But usually, it's PSA monitoring. Because patients who've got aggressive disease, the PSA is going to rise. Adjuvant therapy has significant side effect. The concern here is like when we talk about the 3+3, the less than 5% pattern 4, whether we should call it 3+4 or 3+3, nobody cares.
Yeah, I agree with you, yeah.
So the final question from one of our chairpersons, ma'am, please.
Sir, here, sir. Thank you for the elaborate presentation, sir. Thing is that the cribriform pattern and intraductal carcinoma prostate, they have to be defined better and validated because they're
yeah, you're not audible, ma'am.
the cribriform pattern and the intraductal carcinoma prostate, they have to validate it for the betterment of the clarity of the grading, because they are emerging as a suspicious role they are playing it. So whether they are included will be included in the grading pattern or in the scoring pattern or not, especially the intraductal carcinoma prostate.
Yeah. So again, the question is about when you see this cribriform the architecture, right? It could be intraductal carcinoma or it could be the cribriform, right? The cancer, right? Whether you want to make you want to distinguish between the two, because right now there's some sort of the conflicting recommendations from the two organizations, right? I would say this
you so much.
Thank you.
Can I please request you to stay back on the stage for a group picture with the chairpersons, which will be followed by felicitation. Ma'am, please come. Chairpersons, you're requested to please come up for a group picture. Thank you. Thank you, chairpersons. Thank you. I would request Dr. Ming to please stay back on the stage for the felicitation. We are doing this today because you'll be leaving tomorrow before the formal inauguration. So can I please call upon Dr. Urmila Senapati, Dr. Sambit Kumar Mohanty, Saurav, and Dr. Ranjana Giri to kindly felicitate. For the felicitation, please. So, it's a beautiful attire. I'm so glad to see all the international delegates and faculties in this lovely Indian attire. I'm sure you would be enjoying it too.
So that's why I was a little bit concerned why nobody actually commented on my the outfit.
Okay. You're looking very good. I think that was the first statement I gave you when I met you this morning. Thank you so much. Thank you. We are sorry and we are running late by 15 minutes. Now we quickly proceed towards our next session. Can I please request our esteemed chairpersons, Dr. Sangeeta Desai, Dr. Nusrat Hussain, Dr. Liti Mohanty, Dr. Niharika Panda, Dr. Matthew O. Livet to chair the session, while I request our speaker, Dr. Mahul B. Amin sir. He is a professor, Urology and Pathology at Keck School of Medicine, California. We are extremely delighted to have you, sir.
Thank you.
All yours.
So, Sangeeta's giving me 45 minutes. I know it's not.
So 40 minutes is the talk, 5 minutes.
I'll try.
Absolutely.
All right. Good morning. I see a lot of enthusiasm in the audience. Keep it up. It's just the first of 3 days, and I'm really looking forward on behalf of all the international faculty for a very good interaction and collaborative conversation. My talk today is on, just one thing, can I progress the slides here?
Yeah, pointer. We do have a pointer.
Is there a progress? If I want to progress the slides?
Yeah.
No, how do I progress slides?
Next slide. Progression of the slide. Pointer. Slide change.
Okay, so let me just start. First of all, Dr. Mishra, Sambit, Mohanty, Dr. Giri, all my esteemed co-faculty. It's just really a great pleasure to be here. I must say that I didn't get the memo to wear the Indian outfit. Otherwise, right now, since I'm international faculty, I would have proudly worn the Indian attire. So my task here is, in the next 40-45 minutes, to talk about the applications of digital pathology and AI. And I'd like to present it in such a way that it is not scary to the pathologist, but it is an eye-opener and I'd like you to look at it with optimism. You know, it is said that the history is in the past. The future is a mystery, we don't know. But today is a present. And the present here is not today is because we are present here, because we have this amazing opportunity once in a lifetime. We were presented that with morphology, we were presented that with precision medicine, and now with AI, as to how it can really transform the outcome for patients. I see radiation oncologists, urologists, pathologists in the audience. I have been looking at prostate cancer for 40 years, and I am amazed each day at the power of morphology. At the same time, I'm frustrated with the limitations we have. And so that has always driven us to be better. And I do think that there is an opportunity here with how we can improve our role as multidisciplinary clinicians to solve and make prostate cancer diagnosis better. So with that, do I have the, I'll use this in the meantime. So we all as clinicians love classifications. So I just wanted to outline the role of diagnostic pathology as it has evolved, and this is sort of a pseudo classification, but hopefully will put some sense in terms of technology. This is a talk on technology, on pathology. It's fun, it's light, it's not heavy, hopefully. And so in order to understand technology and pathology, perfect. We need to understand how our field evolved. So pathology started in the Germanic area in the 1900s, first looking at autopsies. Of course, it was an art of looking and studying disease since 3000 BC. Surgical pathology, histopathology as we know it, really came into being in the mid-1900s, a lot driven by the American school of thinking where surgeons, gynecologists, they all became and evolved into pathologists. We are now, as we are in this global arena, in the era of theranostic pathology, where we really integrate molecular and clinical data along with our anatomic impressions to render a diagnosis. And what has really ushered with all the AI and the computational capabilities is this era of computational pathology, integrated digital pathology with artificial information, informatics, etc. So whether you are 40 years in this field or 40 seconds or 40 days, I see some young residents, definitely the latter. This is an opportunity for us. And today's presentation is to show you what can really happen today. Now, it may not touch your lives today, but if you know what it is and you can harness those capabilities, then you can use it as you practice your medicine. So with that, how does this fit with technology? And so if one looks at the industrial revolutions, there's a very nice book by Klaus Schwab, and he talks about the fourth industrial revolution. So there are what he calls 4 industrial revolutions. And basically, he starts talking about industrial revolution since the agrarian. So there was man who was hunting wild animals to starting to do farming. We're not talking about that. But the first industrial revolution, as you know, began in the 1760s to up to 1840, where man is probably not the right, humans. Humans harnessed mechanical power and over the human muscle. So we started spinning yarns, steam engines, railroads, electric bulb, etc. And during this time, Virchow and all the pathologists in Germany were advocating the role of microscopy. We had the first photomicroscope that was almost half the stage to just take a picture, right? So that's sort of where we were in the 1840s. Moving forward, the second industrial revolution occurred in the late 1900s, the first half of this past century. And this is when we transformed from human muscle to mass production, assembly lines, electric power, cars, motor cars, etc. And so this was matching with that previous aspect that I mentioned, the era of surgical pathology, where we started using electron microscopy, IHC, and many other such tools. The third industrial revolution is sort of where many of us are, and as we are going to the fourth one, which the world is moving to, and that is using digital and computer revolution, semiconductors, internet, etc. And this was matched with developments in pathology, where we started as pathologists integrating molecular data and omics into our clinical practice. We are now firmly entrenched in the fourth industrial revolution, which is the early part of this century, the mobile internet, machine learning, AI, and nanotechnology. And this, of course, has given us this very unique opportunity to integrate all this information into the field of computational pathology. Now, one difference between everything that I said between the first three and the fourth industrial revolution is the scale. It is unprecedented speed, scale, and impact. How many of you watch Netflix? Everybody, right? How many years did it take Netflix to get 1 million users? 3.5 years. How many use ChatGPT? How many years did it take for ChatGPT to get 1 million users? 5 days, right? So the scale is what I'm asking you to look at. So everything that I'm going to mention, you have to think about it in the mind as to what incredible power we have as we go along. Now, coming back to the reality of practice, the current determination of prognosis and therapy in prostate cancer is still done by the digital rectal exam, the serum PSA, the amount in the tumor in the biopsy. Is it little or a lot? We as pathologists, can we tell whether the glands are fused or single, pattern 3 or 4? So really still relatively basic information, though of course serum biomarkers and molecular markers and MRI has clearly progressed the field. But at the end of the day, the vast majority of patients, depending on who they talk to and how they talk to, and sometimes just their wives or their priests or the internet, are choosing relatively randomly surgery, radiation, and active surveillance, though of course the great grouping has played an important role, as well as the surgeons advocating for active surveillance. So now, that was sort of the history of where we were. In order to develop the theme of computational pathology, one has to go back. The first precision medicine oncology development, which we all know is obviously what we practice in many areas today, actually began in prostate cancer. In 1941, Professor Huggins showed that prostate cancer is hormone dependent and advocated the role of androgen ablation, and he got a Nobel Prize for this. Now, it took not almost 60 years to get to HER2 and BCR-ABL. So really a long period of time to get there. Now, what changed from this 2001 HER2 and BCR-ABL was the convergence of advanced technology. So we had molecular biology, we had bioinformatics, and really high throughput ability to sequence. And this was the Nature Medicine paper that showed that the Human Genome Project was completed. And that really ushered and catapulted a lot of the changes that we had, which led to precision medicine, which at the highest level fosters a new paradigm for us to bring in and think about multi-omics and combine it with health information technology. And at the end of the day, this is not a simple task. The paradigm is simple, but we have to really understand how the 3 billion base pairs, the 25,000 genes, and the 500,000 proteins in the human body interact in this complex ecosystem, and how can we diagnose and target diseases based on this. So moving forward from BCR-ABL and the Human Genome Project, we're here where we have just amazing technologies that one cannot even keep up with in clinical practice. And just not only are the diagnostics better, but the therapeutics and targeted therapies, just looking at just one drug, Keytruda, a PD-1 inhibitor, it resulted in the sales of $25 billion. I'm not trying to market the drug, but just the impact of what was just a $2 billion industry worldwide to just one drug, which is 25. So again, scale is really an important aspect of what we're talking about. Now we're going to, along this journey, see how our paradigms of thinking have changed. So we as pathologists would look at a lung cancer and say that's a lung adenocarcinoma, and we learned that the molecular makeup, whether it is EGFR activated or ALK rearranged, although they may look relatively similar under the microscope, would have different molecular signatures and hence different treatment. We also know that you could have just completely different cancers, but having very similar molecular alterations that allowed us to treat with the same drug. And so the first sort of basic paradigm alteration was, and it's important for us as pathologists, we got so focused on differentiation. Is it rhabdomyosarcoma? Is it leiomyosarcoma? Very important, but really what really drove the field in advanced malignancies is that we came into the era of diagnostic, diagnosis agnostic therapy. Really, your diagnosis mattered, but really the molecular signature was very critical. So, with that sort of introduction, are we at the point where we can take some very objective testing, omics, digital pathology, computational biology, to really help stratify patients into these different therapeutic modalities based on some much more objective criteria? And I'm going to show you it can be done. Obviously, it is not widely aimed. The aim is democratization, but we are today in a digital divide. So I will exceed that as optimistic as I am, we are still in a big digital divide in offering that. So now, how do we as pathologists make diagnoses, right? We are taught, you look at the architecture, the cytology, the adjunctive features, and then we look at it under the microscope, and then our brain, if you have seen this image and thought about it, use human cognition and provide a diagnosis. We know there's a high level of subjectivity with this, and that diagnosis is based on your impression at that unique point in time, and it is actually precisely irreproducible at times because it's just like what you thought about. Now, and I'm not saying it for the majority, but that's sort of how the basic weakness of surgical pathology has been. So come in digital pathology, which is not new, 10, 15 years, we've been able to scan slides. But what digital pathology does is it takes that image, it breaks down into small patches, as you can see here, and then it stitches those patches together to create an image that is a data set forever that you can mine using multiple software algorithms, right? So getting from cognition to digital pathology has been a big step, but it has been frustratingly slow because we've looked at it just to capture images for recuts, for getting second opinions, for quantitating IHC, for educating of residents, research, etc. But the progress was slow. Almost 15 to 20 years, not everybody still has digital pathology. But what is happening together, right, when we're looking into the future, is we have this amazing power of multiple high throughput technologies that can come together and understanding in context of targeted diseases to bring in theranostic pathology as a reality. We also now have not only the digital pathology that's scanning the slides, but cloud-based storage, image analysis, AI algorithms. And when we take this digital pathology, we transform into computational pathology. And when we bring all of this together, we can truly enhance patient care. So now let's look at how we can do it and what are the steps in this process. So we'll 15 minutes of 5 minutes, 10 minutes of computer stuff, very high level. I myself am not a big computer geek, but just enough to understand and be dangerous. But as you know, the grand goal of computer scientists right since the 1960s is to build artificial intelligence, or AI. And that is to teach machines to build human-like intelligence, learn, infer, and reason. Now, along the way came the entire concept of machine learning. Like when you actually even start your Netflix, and it already gives you the programs that you've watched before. That's basic machine learning, simple tasks that it takes without really much mathematical observation, but the machine does that for you, right? That's sort of machine learning. What we are now leveraging at just an amazing pace is deep learning, which is machine learning, but using just brain-like capacity of neural networks. So the more you learn, the more you undo your mistakes, and the better this output is. And we'll talk about deep learning in just a second. But what is very fascinating, I think for those who said, oh, I can still sit back and enjoy my cup of tea, here's sort of one way to look at knowledge. When we take the Renaissance period to the industrial age, so I'm compressing the first two industrial revolutions, it took about 50 to 100 years to double what we know as human beings. When one takes, at the turn of the century to now, it's 1 to 10 years, but I already told you with ChatGPT and in many of these computer-based AI algorithms, it is 3 to 4 times doubling each year. So the scale of knowledge is increasing. And now why is it increasing? Because let's look at when man landed in the moon in 1966, believe it or not, it had 6 kilobytes of memory, 1 megahertz processor, less than what you have on a pen drive. But we landed on moon as humans, right? We get to today, everybody's got cell phones. We have now 4 gigabytes to 12 gigabytes RAM, and we have about 1 billion instructions per second capability from 85,000 instructions per second. So the speed has gone up tremendously. And just taking at a laptop, we're taking it to 30 billion calculations per second. So the ability to do this has increased tremendously, coming to the sort of the latest craze, semiconductors, and we won't talk about all the exciting companies here. 500 billion calculations per second. And so what has happened is that there is a 75 quadrillion, if you can even imagine the power of these numbers, increase in computation, right? And it just happened within our lifespan for most of us. So, well, you may say, how does it affect me in pathology? Well, just let's take a sequencing, right? We talked about human cancer genome. 1 billion years, 6 to 8 $1 billion, 6 to 8 years, and a factory of sequencers, right? What do we do now? We have it on a desktop in most of our labs in the US, and of course, I know it's coming up a lot in the US, in India. For less than $1,000 in about 5 to 7 days, in an actionable period of time, you can sequence cancers. And of course, where we are getting to, and people are talking about it, so this is at the cusp of current reality and science fiction, is point-of-care devices, and also doing things that we can't do, long reads, methylations, et cetera. So the scale of computation and the scale of sequencing and technologies, just to take an example, has improved. So now, well, we are pathologists, right? So we are taught about, when we take the lectures, these are the diagnostic criteria. Please avoid these pitfalls. These are very important. And therefore, in doing all these, which we still are doing, the role of the needle biopsy has changed from diagnosis to prognosis to patient management. And so the information we give is tremendously powerful, as has been explained by Christina and Ming. And so, at the end of the day, Gleason score, how much cancer and what percentage of cancer is really important. So now, this is the baseline AI that is capabilities. What is available today, right? Not with everybody. I still say on the path to democratization, there's always a digital divide. So we're in the digital divide where some people will have this. But many countries, including in India, AI in prostate is available. So the role, let's look at how it can impact the role, right? So if you take the role of the pathologist, we want to diagnose prostate cancer accurately, and then give all that information in each core, because it's important for active surveillance. We want to provide a Gleason score. We want to quantitate the amount of tumor and put it all succinctly in a report that the clinicians can use rapidly. So the challenge is there's still the underdiagnosis of cancer, overdiagnosis of cancer occurs too, as Ming ended his talk, from a human perspective, there's inter and inter-observer reproducibility issues. We eyeball the amount of tumor, and we are still struggling with the technical challenges of taking all that report into an LIS and an EMR system. There are other hindrances that we have. Our clinicians generate a lot of biopsies, and not only 8, but 15, and sometimes 20. And depending on the number of cases one has, a pathologist, and if you're doing mainly GU pathology, as some people have started to do, you can be seeing 100 cores and multiple levels each day. We also know that the prostate foci are getting smaller. And so while we are all very good as pathologists, you know, if you land into a medical legal situation in the United States, the cost of defending a prostate cancer misdiagnosis, of course this is old data, is about $500,000 US. And not infrequently, you're looking at 20 slides, and the last slide is a small focus of cancer. You wish you had a digital fellow or a fellow who could screen the cases so that you could go directly to the most abnormal focus. Also, clinicians want greater subspecialization. Quality assurance is important. There's a shortage of well-trained pathologists. So these are all the issues that we as pathologists struggle with. And of course, not to forget that flexible work schedule. Many of the young pathologists are taking pictures outside rather than taking Ming's and Christina's lecture, but that's the modern generation. And I'll tell you that they won't be disturbed because of some of the things that are happening here. So can all these issues be addressed by digital pathology and AI? And that's what I would like to show you. They're all possible. So this is work 6 years ago we did with Google, the company Google, and we were asked to look at about 1,000 slides, and someone had painstakingly annotated each focus. This is a 3, this is a 4, and they taught the machine how to grade pattern 3, 4, and 5. And what was shown in that study is that the general pathologists, when they compared to a machine learning, deep learning algorithm, their reproducibility was 0.61 versus experts who were very close to the deep learning system. So experts did well. This is a very, even though, as I said, it's 5 or 6 years old, in this day and age when human knowledge is doubling so fast, this is an old study, right? So one concept to understand at a high level when you are looking at is this a good algorithm or not is to understand what's called area under the curve. Area under the curve is used in statistics and machine learning, and it predicts when there are two classes, which class is likely to be positive or negative. So if you flip the coin, it's 50-50. If you had 1, you're perfect, right? So you want to be area under the curve near 1 if you want a good AI model to work. Now, here's a whole set of studies, 2022, look at the area under the curve. 0.98. None of us have 0.98. Now, of course, it's got the bias of that learning system, but it is incredibly powerful. Not one study, multiple study. This is published here. And many years ago, again, 3 or 4 years ago, we took part in this challenge, which is called Panda Challenge. 1,000 teams around the world. This is the largest histopathologic study that was ever performed. 1,000 teams were asked to make their own AI algorithms. And really the high level, that's what PANDA stands for, prostate cancer grade. And the AI algorithms, from wherever you produce them, they were successful in detecting grade and stage, which has been shown by multiple studies. AI algorithms miss fewer cancers than pathologists. And therefore, AI allows democratization of this expertise. A very nice review by Anil and Sambit, where they showed that there are multiple systems here, so I won't go into details. I think Ming also showed these. What is very interesting is this is an FDA submission by one of the companies. False negative rate for cancer detection was reduced by 70% by the AI algorithm, and false positive rate was reduced by 24%. So just a lot of efficiency gains, and most importantly, from a patient perspective, a better accurate diagnosis. Here is another company. Look at the area under the curve, 0.9%. Cancer detection, Gleason grade, very high. area under the curves for these methods. So what can prostate cancer be achieved with in diagnosis in AI today? Can you screen, are there benign, atypical, and cancer glands? Can you triage? So let me just show you this rather than going through this list. Okay? And let me show you how you can improve quality, efficiency, consistency in detecting cancer. Now here's a lab in Puerto Rico. I think they have over 10,000 cases that they have done. In France, with one of the companies, they have again 10, 20,000. So people have looked at this. I mean, it's been quite rampantly used in a very select group of people. So this is Dr. Santos, who gave me permission to share slides. He comes in, he actually does a lot of it at home before he goes to work. This is his screen, it's a pretty large screen. He brings up the case, and he puts a heat map, and it is red, that's very likely cancer, and so he can kind of look at these. And so when he's looking at his screen for the day, this is my screen, he comes in, okay, today what do I have? I have 20 cases. There are 379 cores in this 20 cases. This is not even without even looking at the microscope. He knows that there are 8 cases with cancer, 8 cases without cancer, and 8 are atypical, so let's start working them up. So then he goes to work. He orders everything, he's gone, right? So when you take an individual case, let's take this case, right? 3 are cancer, and 7 are benign, 3 are atypical. So we're already beyond active surveillance, so you can even think about it in a much different way rather than trying to find, is this inflammation, is this cancer? He's really, and he starts looking and applying heat maps and identifying different areas of cancer. And as he looks at first, is it cancer or not? Then he confirms it, he diagnoses it, once he puts the grade, and all of that is simultaneously then put into the pathology report. And so, it's generated at the end of his review of what the case does. And again, this is not something he's been doing last 2 years, he's been doing it for the last 3 to 5 years. Here's a case, small focus. He applies the cancer detection map. Here the cancer is too small, wanted to do immunohistochemistry, went in and ordered it. It was cancer, he was able to do it. So that's the efficiency of time that we talked about. You can also just measure it rather than trying to figure out and estimate, very objectively measure the cancer. So the value proposition for pathologists, as we start thinking about these and these are available, reduce anxiety related to screening, that's our biggest, right? Like, I don't want to miss the focus of cancer. Increase diagnostic confidence, real-time QA, efficiency in gains, and now we can really focus on what information is important to the clinicians. For the physicians, there's a greater diagnostic confidence, faster turnaround time. This has also been shown. Anxious patients, you can get them this information. For pathologists, it's standardization and hopefully democratization. You don't need to be an expert in everything. And for the patients, there's accuracy and health equity in the future. We're still not there, but we have the capability today. I'm not going to get into this, but there's also 3D pathology. Just want to kind of give you, this is the future. What I showed you is being done. But we all know that as you look at the depth of cancer, of benign glands and cancer, there's difference. And they have shown studies that if you look at a 3D grade, it's better than the grade that you can get by looking at it at a 2-dimensional way. So now we're going to take a little pivot, right? Is that all we can do? Like, look at things faster? I mean, we all can do it. Maybe if you had the machine, it's better. But I want to break that the first paradigm we broke is we're in a cancer agnostic mode, right? We just want to do therapy in advanced cancers based on molecular. We teach our residents, if you don't see this, if your mind doesn't know, you will never diagnose it, right? So this is something we always teach, and this is, of course, fundamental to most things that we do. At the same time, the question is, can AI models break this paradigm and reveal information that our human cognition cannot do, right? What does the computer see? Because we believe in the power of light microscopy, some of it, though, we can't catch. So there's more. So in the more story, let's just look at patients with advanced prostate cancer, right? NCCN guidelines will recommend testing for BRCA and mismatch repair proteins, because depending on the alterations, not only is the risk, but also the type of therapy in metastatic cancer. Now, expensive stuff, not very common genetic alterations. So this whole field has emerged. People have different names. I like the term histomics. That means predicting the genomics through histology. And why is this exciting for India? We didn't have to build landlines in every city and town and village. We went from landlines somewhere to the most digitally advanced country in many areas. And I think, as I strongly believe this is a conversation for some wine or drinks in the afternoon, how India can actually be a reverse innovator. That means do the innovation and the rest of the world follow. But we can talk about that on another point. But what is histomics? So you take the histology slides and you can feed in the molecular information or the genomic or the mutational significance, put it through digital learning AI models. And for example, you can take 100 lung cancers and say this is KRAS or EGFR and NTRK, and then just show in a slide, and the algorithm can recognize with a high degree of accuracy. Now, it may not be area under the curve 1, but it may be area under the curve 0.9 or 0.8, and then at least you know whether you want to. And if you don't have it, at least you could go with that information. Rather than us who try to predict PDL and PDL1 like semi-quantitatively, and you give millions of dollars of therapy and really, really toxic therapies, right? So this has a lot of potential. Let's dig in, therefore, in prostate. Again, different genomic markers have been looked at, and they have shown PTEN detection 0.81, ETS 0.91. So just looking at H&E, passed through a digital algorithm that's been trained with molecular data, you can get some amazing results. And this is the start, okay? But you're going to ask me more questions, and I hope I can proactively answer them. So here's a study with Tamara Lotan, and they showed with P10 and ERG, they were able to, again, get area under the curve 0.91. Well, can we apply this level of information to patients? And I want to show you in the next 5 minutes we can. So we talked about AI and machine learning and deep learning. And deep learning, this is all computer mumbo jumbo, but there are some terms that you might see in the next 5 minutes. Generative adversarial networks, which came in 2014, transformers, chat GPT, right? Generative pre-trained transformers, right? But the ability to chat like a human, chat GPT, is one of them. There are many others. So these are all forms of deep learning, right? And this gave the concept of generative AI. That means you can generate new information based on old. You can create poetry, you can write a movie script, you can write a song, you can create a picture, right? That's all Gen AI. So, some of it got cut, but basically, Gen AI is create new knowledge. And the data that is put in Gen AI is what is called foundation models. So these are large data sets and domains. And from that, you develop large language models. That means the models that can speak to us like human beings. Chatbots like ChatGPT. Vision language models, multimodal models. I'm going to show you how these models can be used in prostate, and have been shown. So this is very fascinating. Original H&E slides were run through what is called this GAN, the generative, whatever the previous slide was. And it can synthetically create images. You just say, these are all Gleason 3, 4, 5, and tell the machine to create data. It's creating images. You can create a whole cohort of 5,000 chromophobe carcinomas based on all the aggregate literature. It's called synthetic data, right? I'm not going to go into details, but at least you get the concept. So ability to synthetically generate new patches is amazing. Now this one blew my socks off. Faisal Mahmood is an amazing, Anil, some great thought leaders from Harvard, came up with multimodal generative AI. So what is multimodal? You take large language model, but you add video to it, right? Now, let's take an example. This is on his website. You just show an image. Now just close your eyes for a second. You throw the image, and you press enter. As you press enter, the computer is typing this. The morphologic features reveal tibial, cribriform patterns, characteristic of adenoid cystic carcinoma. So just as you, as an experienced pathologist, can say, oh, this is adenoid cystic carcinoma, this multimodal generative AI has been trained with about 1 million slides plus. It's in the paper. So it's going to start analyzing the features and telling you this is the cancer. Okay? You throw in this picture, assess the tissue morphology, what Gleason patterns this is. 2 words to know, prompt. Ask the right questions to avoid hallucinations. These computers are not perfect. They're like us. There are hallucinations. You have to know when it is garbage. But as you are thinking about it, it's typing, right? So press. The tissue morphology is a Gleason, 2 distinct Gleason patterns, 3 plus 4 suggests 3 plus 4, right? This is shown, and they're developing it as a commercial model. A lung cancer needle biopsy, when the patient with lungs, what IHC would you do? And they'll say, well, if you do TTF1 napsin, it's a lung adenocarcinoma. If it's this, it's a squamous carcinoma. I did this, but these were negative. What should I do next? So also saying, okay, and literally you have to see these presentations. As you're pressing, these things are coming. So it's not going to replace us. It's going to make us very powerful. Because what we want to do in the end is we want to take this clinical data, mix it with the pathology images, do the radiomics that Christina was talking about, and radiology images, and put all of this together to make better decision support. So I want to end with 2 studies that are real. And one is used for treatment. So just so that you're saying, okay, he's just made this nice story, it's good science fiction, good before a break. Study from Mount Sinai, Ash Tiwari's group, looking at prognosis and outcome data. Cutting edge communication, 2024, not yet in print, but here's the essence. So what they took is they took patients with known outcome at radical prostatectomy, of patients who had intermediate risk cancer, right? And they developed an algorithm of those patients who had biochemical recurrence and those patients that had distant metastases. So they took 176 patients, 46% had distant metastases, and they asked to look at, so they had a low risk score and a high risk score for progression. So we asked, is grade important? What do we do after prostatectomy? They also compared with clinical benchmarks and genomic scores. This one is still sort of an evolution, but this is a product that is commercially being talked about. But you can see that biochemical recurrence, p-values, just the machine telling you what's the difference in prognosis based on another cancer that is intermediate risk, and also distant metastasis. So it's good, prognosis. But can this guide therapy, right? That's the question that really be cool. And this is again done, NCCN endorsed. So this is not, again, something that's happening. This is a study that I can talk about an hour on, but let me get to the highlight. So this is prediction. Can I take an H&E slide and say, should this patient receive radiation therapy or not, right? So what they did, and these are really cool studies because they took 5,000 patients from 3 randomized NRG, that's the former RTOG clinical trials, and 1 trial they used to validate, and they showed that, of course, if you give ADT with radiation therapy, it significantly improved distant metastasis, right? Then they developed an AI algorithm based on those H&E images, clinical data, PSA, other information and outcome that would determine who is likely to develop distant metastasis. So they took, not biochemical research is good in our immuno papers, but for outcome, you want to see distant metastasis, et cetera. So they had 34% were model positive. That means the model said you have an abnormal reading. And in those patients, androgen deprivation therapy significantly reduced the risk of distant metastasis versus radiation therapy. So it said, here's a patient you should give them. And 1,000 patients who were model negative, ADT did not provide benefit. So in those patients, if you just give ADT-RT to everybody, you're going to have all the risks of ADT. Now you can tell which patients get this therapy or not. So an AI-based predictive model was able to identify patients who had intermediate risk to benefit from short term. And this is approved by the NCCN and it's a commercially available product. I took this from a brilliant talk. Anybody who's motivated by this talk, go to Eric Walk's talk on YouTube. He's the real computer guy. And what we are struggling with as we end this conversation, right, is we have to take in patient data, imaging data, anatomic path, lab data, molecular data, all these guidelines, FDA, medical literature, papers exploding every year. How do we really get this going, right? So the value in getting all this done, at the end of the day, hopefully Sambit gave me only 45 minutes, so I can't help it, but hopefully this is a good glimpse. For pathologists, we can get these diagnostic, prognostic, predictive algorithms. It can improve, like looking at the charts and get a summary. You just tell them, give me the summary of this patient. As you're pressing, you'll say this patient had prostate cancer, father had prostate cancer, BRCA was done at this institution, right? Everything will be available. You can generate a report, you can do QA, reflex testing, etc., generate educational content, synthetic data. I haven't even talked about virtual staining. That means you don't even have to stain the slide. It just says, tell me the ER/PR results of this, and there's sort of whole biochemistry around this. For clinicians, what we are going to start seeing, and we are starting to see, is decision support algorithms, which I showed you. Better clinical trial selection, of course, synthetic data. And most importantly, for patients, you have these I have a friend who's developing one of these, and his patients talk to that chat box forever. I have a high blood sugar level. What should I do? And then the chat box says, I have a high. I'm not saying, no, this all has to get validated, so I'll go through that. But just basically, even patients, they want to know, and we clinicians have very limited time to talk to them. But most importantly, all of this will result in better outcomes and less adverse side effects. So I have to leave you with some limitations, because I'm still an H&E morphologist, and we have digital pathology that is available, but you need an image management system, you need clinical grade AI software that are validated by others, endorsed by organizations, and then integration to LIS. Most importantly, we are relying on data. This is data, it all goes in a black box. We don't know what it is. Largely, it's going to remain in a black box. But you want unbiased data, better quality, standardization. There's, of course, legal and ethical considerations. So with that, this is a Gleason cribriform pattern. I hope that I've shown you that AI is amazingly smart, but also till we teach it well, and it'll never get, but even we as humans can exhibit this behavior occasionally. It can be shockingly stupid. At the end of the day, the diagnostic power of an AI algorithm is no greater than the knowledge and the wisdom of the pathologist and the clinician interpreting it at the patient care level. But all I can say is that as AI becomes more entrenched in clinical medicine, a pathologist and a clinician with AI is likely to be much more capable than one without. Thank you very much.
Thank you. Thank you so much for your time, sir, and a thought-provoking talk indeed. Can we have questions, please?
I don't have my chat GPT to answer, but I'll try.
No AI in answering right now.
No, we're all good here.
As always, Dr. Amin, it's always a pleasure having a great experience through your journey and your talk on various topics. So my question is a little philosophical one. Is it a threat or opportunity for the young generation?
So I am a student of the Bhagavad Gita. Of course, we have people from different religions, but when in chapter 11, Krishna gets the vision of God and is always almighty, and I'm not equating AI to that higher power, but it's a higher power potentially than us. He has 3 forms of reactions, which is summarized in chapter 11. First is, oh, wow, that's great. The second was fear. And I think most pathologists go through this awe and fear. But the third thing that Arjun does, which Krishna says, is surrender. What I'm saying here is surrender with your wisdom. And if you look at the Bhagavad Gita, I'm just using that as an example, it's all about free will. It doesn't prescribe what you do. So at the end of the day, we would love for us humans to be in control, but to use these in that right fashion. So it's fine to be in awe, but at some point, accept it. Yes, Makrant.
Mehul, excellent. Breathtaking, as usual. I think, as Sambit has asked, are we going to make the pathologists, clinicians redundant as such? But as you rightly said, we're going to use this tool to compound our knowledge and sort of give more information. And I will just give you a quote just last week we had. Nowadays, the patients come in the clinic they Google you, they find out, they have all the information, and they come right in front of you. A guy came and said, I looked at the chat GPT, looked at your profile, but when I interacted with you for 15 minutes, you are entirely different than what's in chat GPT. So what it means, I think today, whatever information we are putting through AI into the machine and deep machine learning and everything, I think what's going to come out with what we are fed inside. Now, ultimately, I think it's we as a patients, we as doctors, I think we really have to put everything together, and still we will have a last word, which may be a laughing word or I don't know, but last word would be the human being and the clinicians.
And it is always going to be, because it's what you feed. So at the end of the day, what the mind doesn't know, the eye doesn't see, what the computer and the data doesn't have, it's not going to reproduce, right? So I think at that we can go back, and that's the reversal of that. But well said. So here's an important word, prompt engineering. If you don't ask the right questions, you don't have, well, if you ask, what is Dr. Makran Kochekar really like? Oh, he's this, he's a gardener, he's religious, he's a philanthropist, he's opened this hospital. Then you say, gee, this is a really cool guy. So of course there might be, if you looked up your Wikipedia page, probably you'd get it. But asking the right questions is a really essential point in when you're dealing with these modalities.
Just a small additional comment. It was an excellent talk and also an eye-opener that the future of pathology is first a digital pathology, right? For AI to become a tool, as it is now, helping the pathologist to arrive at those things where there is an element of doubt. It gives you with this red hot spots what you showed. Hey, this is malignant. Okay, instead of going for a second opinion to another pathologist, he gets the second opinion from the computer itself. So we have come to a stage where people who use digital pathology will realize you can make a much more faster diagnosis on core biopsies of the prostate, where exactly are the suspicious lesions when compared to the conventional microscope. Do you agree to that?
The question is, do you agree to that? Is that
yes, because I think that's the reason I'm saying is there are still a lot of people mindset that digital pathology cannot replace the conventional pathology microscope because it is still artificial. I mean, they have that concept. Yeah. So first our mindset has to change to accept digital pathology and also accept, as you rightly pointed out with the extreme, very good examples, as to how AI can help us to arrive at the correct diagnosis and also predict the outcome and the modality of treatment for the individual patient.
So I think I'll answer it just very shortly at both levels. Personally, having done this journey for 5 to 6 years, I'm completely in awe in what it can do. At the same time, I also know the hallucinations, right? And that's what we have to fix. The second thing is, if we didn't have that PANDA study and the multiple published literature of area under the curves that are 0.9 that are better than humans, I doubt it. So I think at both levels, this is a fact that we should surrender to, that it can do better. Question is now, can we afford it, and all those other questions. But I do think we are on that journey, for sure.
Okay, just a small note. I'm not into artificial intelligence, but for the past 5 to 6 years, with the COVID set in, we have been doing digital pathology reporting on all core biopsies of the prostate. And I find it very useful, accurate, and with the MRI imaging, what was pointed out in the first talk, it becomes more accurate and enable it.
Yeah. No, thank you for coming from Malaysia all the way. We appreciate that.
Thank you. More questions? Yeah,
Can I?
One from the chair.
Dr. Amin, I loved the talk. Thank you very much. I enjoyed the analogy to the Industrial Revolution because this really does feel like we are in an accelerated revolution. And but in revolutions, that changes the practice model. Farming changed dramatically when industrialization came in, and the cottage industry, cottage industries end up getting consolidated, and that's very scary for a lot of people that are thinking about that. It reminds me of the discussion. Reminds me of something I heard, which is when you see inevitable change coming, you have three choices. You can avoid it, and it'll probably overwhelm you, and you'll, if you accept it, you'll maybe survive, or you can lead it and prosper. And I think this is one of those moments. I'd love to hear your thoughts on how can we in this room, how can India take advantage of that opportunity to lead?
So, I mean, India has had, as I said, we bypassed the landlines to one of the largest consumers of cell phones and electronic data. We have every citizen in this country recorded that no other country has done with the Aadhaar card and Digital India. The US is bogged down by profit mode and regulation, and lost a lot of the West. Innovation of technology is a natural for India. And we have a whole listserv of like 100 entrepreneurs on health industry. And every day I get about 80 WhatsApp on what the Indian entrepreneurs, and most of them were in the West, they're now coming here. So I do think that this is an opportunity for India. And I think that part of this kind of conversation is hopefully it can stimulate the people that this is a reverse innovation. We believe that can occur here, and it's actually occurring even in molecular pathology. So just one point is, I started with morphology and its power and got very fascinated by precision medicine, and now I'm very fascinated with this. Not that I alone can solve it, I'll just be a drop in it, but if we all collectively work towards it, as clinicians and pathologists, I think we can make the change.
Thank you. Can I have one question?
Just a comment.
Okay, Dr. Amin.
So we are actually looking now at a future, and maybe the societies in the GUPS, the ISUP, as well as societies in various countries could actually look into the change in practice that would come in with the introduction of the new technology, and maybe we need to change the methodology of training that we are doing for the residents, and also the methodology of work in the departments. And also we would have to look for, if you are implying this worldwide, to a cheaper technology, because it would not be affordable for most places to have, and also a standardization across different softwares that have come in.
Yeah.
So this might be a future, where standardization, we could say, would be required. Yeah.
No doubt. I think this is a journey, right? So even in departments, and I know Tata has looked at it, I know many countries, many departments in the country, there is resident implications, there's workflow implications. All of these are definitely going to come, right? But people ask, like, I can't get my computer to work sometimes, I don't have connectivity. When the cars first came out with Henry Ford, the villager in India could not think about a car. But now, everybody in India has a car, and around the world. Now that took from 1914 to today. But what I hope I showed you is the scale. It's not going to take another 110 years for everybody to get this technology. Now, the rate limiting steps are there, but I believe in that optimism that there will be a tipping point. So there is a digital divide, and we will get there. And it's going to be, therefore, an important role for organizations, ISUP, GUFS, FDA, NCCA, and Indian Cancer Research, ICCMR, and some of the standard-bearing organizations to bear the drum. Because otherwise, the risk is we can get inundated with stuff that is not also helpful.
So I have
Sandy.
a quick question. It was such an stimulating talk, but talking about heterogeneity, right? So for a test like this, it's what information is fed in is what you're going to get out. So how do you see this globally? I mean, even within the US, African American men have a different biology in some ways compared to the Caucasians. So if your machine learning has 99% Caucasian, how does that relate? And how do countries like, we know that even in cancer, Japanese men had different pharmacogenetics in terms of drug, the way they respond. How does the global community react to something like that? And Artera is not going to be the test that you would use in India. How does one
So we as humans will never solve this. But I think when you look at Ash Tiwari's study from Mount Sinai, they took African American men and this. When we have a lot of data, we will actually see, one of the clinical data is what's your race, what's your BRCA status, etc. So something that we may never be able to do, we can do. One of the things we are working with the Indian government and the Modi government with their ministers of science and stuff, and we have been advocating, we meaning there's a group of us, who have been saying that we need Indian-specific genomic data. So again, we are in the infancy. It took 360 years for the light microscope to get to where we are. We are in that first 10 years of the 360-year journey, but we are going to do it in the next 10 years. So I believe, to answer your question, it's going to be more data, globalization, and then WHO, AJCC, UICC, etc. will step in.
Thank you.
I know you're having a tough time keeping us on track, but thank you very much.
Okay. Thank you so much, sir. I would request you to stay back on the stage. I would request the chairpersons to please join for a group picture. I'll just hand it over. Thank you. Thank you. Thank you so much. Thank you. Can I please request the judges for the oral presentation to proceed towards Hall B? And without delaying, we now move to our next session on prostate cancer. I would like to request the chairpersons, Dr. T.S. Ganeshan, Dr. Debahuti Mahapatra, Dr. Dipti Rani Samanta, Dr. Saroj Majumdar, and Dr. Ayman Haider to chair the session. Please come up to the dais. And our speaker for the next session is esteemed Dr. Makarand Kochikar. Can I please request you to come on the dais for your talk? He would speak on prostate surgery without histopathology proof in era of modern and molecular images.
Good morning, everyone. At the outset, I would like to thank the organizers, Dr. Sambhaj especially, for inviting me into this August audience. The reason I'm saying August audience, I'm really odd amongst all you pathologists. I'm the only, perhaps, the clinician, and there are a lot. Okay, so thank you very much. And it's always a pleasure to interact with the pathologist. My career started with very good sort of my seniors and colleagues as a pathologist who has taught me clinical medicine, both in India and UK. So my fascination towards the pathology has always remained very close to my heart. And thanks to Dr. Amin, I think we've been interacting for a lot many years in urological oncology. The task which is given to me is about treatment of prostate cancer without histopathological proof. And is it really a reality or is it hype? Greetings from both the hospitals where I'm working. We started this hospital about 28 years ago. We established the Urological Oncology department first time. And it was very fascinating to work with the team of pathologists, the radiologists, and the anesthetists to set up a department, take the uro-oncology as a specialty. Over the period of time, we built this new hospital, which is a multi-speciality. We have, again, expansion to the pathology department, and we are excited to work the last 2 to 3 years in this new institution. Now, as a clinician, as a urological oncologist, I think we were all sort of criticized as we are doing excessive work in terms of doing radical prostatectomies. So this was something you see on the internet. There were sort of reports where people saying that you see PSA of 3 and 4, you are doing more biopsies, and you are actually sort of invasion into the prostatic disease, and you are called as a prostate snatchers. The urological oncologist is called as prostate snatchers. So here we go, we had a PSA at our bay, We did the PSA testing, then we had sort of an MRI, we had PSMA PET scan, and here's a surgeon which walks out of the theater doing an excellent radical prostatectomy. But when we started looking backwards, a lot of people said that you were doing unnecessary surgeries, and that was many, many years ago. Over the period of time, the pathologists have told us, which is the indolent disease, which is an aggressive disease, where we should do surgery, where we should not do surgery. But why we are talking today, why we are saying that can we do this sort of a radical prostatectomy without a histopathological proof? Is it a trend? Or is it the progress in imaging, as we heard in the morning? Or is there really scientific evidence to say that we cannot sort of, we can do radical prostatectomy without the help of the biopsy or a histopathologist? So let us look at the evolution in the progress in the cancer diagnosis. What we do is, when we have elevated PSA, then we basically would have had an ultrasound scan. The next one is the patient gets MP-MRI, usually sort of 3 Tesla, and periods more than 3, then we actually sort of subject the patient to prostate biopsy, either a transrectal, transperineal, or various different ways of doing the biopsy. And once we establish a diagnosis, we do a PSMA PET scan, and depending on that stage of the disease, we actually go for treatment. Now, what we are now contemplating is, yes, you would have had as an MP-MRI to detect the disease or find out the disease, and then the MRI has to be so good that you do bypass the biopsy, you are so convinced, you do straight away PSMA PET scan, and then straight away surgery. That's a contemplation a lot of people are talking about. Now, one aspect of this, are we really worried about the complications of the biopsy? See, if you give a benefit of doubt to people who are aggressive in marketing and saying, yes, we want to do radical prostatectomy because I have evidence that the MRI shows the disease, the PSMA PET scan shows the disease, so why do you need a biopsy? It's organ-confined disease, non-metastatic, go ahead and do it. So, is that a way, or are we really worried about the complications of the prostate biopsy? Worldwide, there are a lot of complications of the prostate biopsy. Sepsis, death, ICU admissions are very well known, but not so sort of to the extent that would jeopardize the life of the people. Now, there are various ways and means of doing these biopsies, and we talked about these targeted biopsy, transrectal biopsies, perineal biopsies, MR fusion biopsies. So there are many ways of doing it. A lot of people said, don't do 12-core biopsies, do only targeted biopsies. The completion rate is less, but you must have a biopsy. Now, this is a paper which was mentioned in the morning. MRI targeted or a standard sort of a biopsy for the prostate cancer diagnosis is a precision study. And what this said was the MRI compared with the 12-core transrectal ultrasound guided biopsy actually had significant detection rate from 26% to 38%. But the MRI also misses significant cancer, is about 13% of the cases. So we moved from doing transrectal biopsies to MR-guided biopsies. So are we convinced that clinical, biochemical, and imaging tools have such a strong evidence that malignancy that we do not need the biopsy? Like in renal cell carcinoma, we see renal cell carcinoma, do we need a biopsy? No, go ahead and do surgery. Typically, the picture which I have shown, it correlates exactly what the PSMA scan and the MRI shows. So the surgeon does the surgery, the pathologist tells you, this is exactly what the images have told us. So why unnecessarily this patient underwent a biopsy? So where did it all start with? The first paper came way back in 2022 when clinically significant prostate cancer without histopathology proof, is it a possibility in PSMA membrane antigen sort of an era? This was the first paper which came in. And this was a paper which looked at about 25 consecutive cases, retrospectively looked at, and radical prostatectomy without prior biopsy following MP-MRI and PSMA PET scan. This was a report which came from the Germany itself. So let us look at these two tests, MP-MRI and PSMA PET scan, which are so good that we can avoid a biopsy. Let us look at positive predictive value, sensitivity, and specificity. Now, looking at MP-MRI, you look at more than PIRAS 3, the positive predictive value of MRI is low. It can miss about 13% of the cancers, and 17% of PIRAS 5, benign or clinically insignificant disease can be seen. And this was a paper in New England Journal of Medicine. While in PSMA PET scan, it's more sensitive when ACU is more than 4. Now, what about this PSMA PET scan? The PSMA PET scan is also very good. It shows systematic review and meta-analysis, and I would say it would reach a specificity of something like 0.66, but sensitivity of 0.97, pretty good at it. This goes a table which will tell you with the different studies how this sort of PSMA PET scan should have a sensitivity, and this is a specificity or a positive predictive value. And here you look at, if you have a Gleason score of more than 3 plus 4, you have significant sensitivity of nearly 100% and a good negative predictive value. So in terms of sensitivity and specificity, both the tests are pretty good. I think the PSMA PET scan is much, much better than sort of an MP-MRI. And obviously, needless to say, if you have higher levels of PSA, the sensitivity of PSMA PET scan goes to nearly 97% or 100%. And that was the basis. People said we combine MP-MRI with PSMA PET scan before the biopsy. So again, it was to avoid the unnecessary biopsies or to pick up clinically significant prostate cancer. This was a primary study which we sort of briefly touched upon. And this actually looked at the sensitivity and specificity when you combine both PSMA PET scan and MRI, and you will see the sensitivity, specificity here, and sort of a negative predictive value much better when you have these two tools combined together in clinical practice as such. And this was the first prospective multicentric trial combining this PSMA PET scan and MRI, and it improved the sensitivity of negative predictive value for clinically significant prostate cancer. So look at the journey. We had a precision trial first when we thought MRI targeted biopsy was better than systematic biopsy to avoid unnecessary biopsies. Then we had this primary trial which combined these two modalities together to improve the sensitivity and pick up the clinically significant cancer. Now this is another paper which also raised a sort of, made a statement, can we have this possibility? Can we do this surgery without histopathological proof? And what they looked at the pyrite score here, look at the pyrite score here, and if you have sort of these two modalities combined together, then chance that these patients would have definitely disease within the prostate, I think is pretty high, and you may get away by not doing a biopsy. And this was another paper which was actually suggesting that you can do this surgery without doing a biopsy as such. And this was a paper which showed all the different images on MRI, PSMA PET scan, and correlating with the histopathological pictures, and it would tell us that this is something, a very good study, which will tell you combining these two modalities will certainly be helpful without doing the biopsies. Now, there would be sort of arguments for and arguments against. If you have high SUV, there are more chances of clinically significant prostate cancer, agreed. Complications can be avoided by not doing a biopsy. There are times when the patients are not ready for a biopsy at all. They said, we don't want to have a biopsy. You have enough proof, go ahead and do a surgery. And combination of MP-MRI and PSMA PET scan, you have both anatomy as well as we have a functional study. Cost of the biopsy can be an argument because still it can be an expensive affair. Anxiety. Post-biopsy, we don't do surgery straight away. We have to wait for something 4 to 6 weeks because if you do 12-core biopsies, I think there is significant amount of inflammation between the back wall of the rectum and the prostate, and usually I wait about 4 to 6 weeks before I advise radical prostatectomy for these patients. Having said that, if you do transperineal biopsies, these sort of limitations are not much there. There are many studies supporting the higher sensitivity and specificity of combined imaging, and there will be an argument saying that we do it for RCC, upper tract TCC, testicular cancer, and few other malignancies. Why not for a prostate cancer? However, the downside is, what if final pathology has no cancer? Because these two tests are not really sort of foolproof. Medical-legal issues, ethical issues. Radical prostatectomy is not a simple operation with no morbidity and mortality. You do the surgery, patient doesn't have a disease, I don't think we've done the right thing. The cost, psychological trauma after unindicated surgery, and again, inter-observed variability in radiology department. We looked at a study in UK, and we asked the radiologists to look at pyrite score on MRI. It takes about nearly 2 years to achieve the perfection. So we're relying on a tool which may not be perfect as such. We are assuming that the patient will not be sort of, will be opting for radical prostatectomy. But there will be people who would say, I wouldn't have radiation. I want to have focal therapy. I want to have HIFU. I want active surveillance. And no one will accept it without a biopsy. The baseline biopsy is essential for active surveillance and HIFU. And we are talking today about genetics, somatic testing, future course of therapy. So the baseline biopsy is must. So you all pathologists, I'm pretty sure you are sitting pretty, you would still get the tissue diagnosis before we actually put a knife on these patients. There was a wonderful sort of an editorial on the same article here. So friends, we are not there as yet. Shakespeare said to be or not to be, so I would say to biopsy or not to biopsy. Do not say bye to the biopsy. We say be to be, bench to bedside, and I think we still have to rely on a biopsy itself. Lastly, what about treating locally advanced and metastatic prostate cancer without a biopsy? Because that is many times a clinical situation. We get patients, you would have sort of PSA of more than 2,000, clinically rock hard prostate. Even PSMA PET scan is not needed. The X-ray showed extensive skeletal metastasis. And many times people ask me, why do we need a biopsy? Go ahead and do hormonal therapy on these patients. So what's the role of pathologist here? I will just sort of give you sort of a classical case. Usually, one of the arguments which is given is patient is not willing for a biopsy, relative is not willing for a biopsy. Why not have a treatment as such? I'll give an example and stop there. This was a 77-year-old guy. He was treated in UK and NHS. He had a retention, diabetic, hypertensive, PSA of 77, bilateral hydronephrosis, retroperitoneal lymph nodes, bony metastasis. His bladder was drained with catheter. And looking at that picture, clinical, radiological, they put him on LHRH analogs and bicalutamide. He had no biopsy done. 3 months of persistent retention, PSA 17. He was advised TURP was to wait for about 6 months in NHS. So he came along to get the surgery done. So here he comes. He had to have a TURP done. I really don't understand anything about it, but I'm going to run through all those pictures for you. I'm sure you will diagnose it very, very quickly without sort of having to look at it. And these were all the pictures. And our pathological team said, there is something different in this. It was chromogranin A positive, chromogranin positive, synaptophysin positive, NIX 3.1 positive, and it was reported as carcinosarcoma of a prostate with neuroendocrine differentiation within 3 months of ADT. And I think this patient did not have a good response. Had it have a sort of biopsy done, even in sort of well-established clinical diagnosis, radiological, I think you need a tissue diagnosis to prognosticate, to tailor the treatment properly. So you all guys are pretty safe. I don't think we are going to bypass you. We need a biopsy before we put a knife. Thank you very much.
Thank you so much. Can we have questions, please? I'm sure you'd be having many for this topic. Mike.
Very nice talk. I'm Rohit Mehra from University of Michigan. So actually, I think it's a very interesting concept, and I think the studies you have mentioned, I think Christina also mentioned some in the morning. So actually, there are some, and you might have heard, and I think folks probably have also heard, there are some non-invasive urine-based molecular assays now available, which can actually predict which can predict with relatively good AUC the possibility of detecting prostate cancer just via urine without any invasive biopsy. Also, there are assays which can detect or possibly detect the possibility of high-grade prostate cancer. One of these assays is called MIPS test, which is a Michigan prostate score urine test. Yep. Also, some methylation assays are also essentially which are upcoming. So I think it's a novel concept, and I think you had also mentioned with the possibility of combining more molecular, non-invasive testing. I feel like kidney cancer, there might be a subset of patients which can actually fit ideally for this kind of strategy. Thank you.
Yeah, I agree. I think these markers which have come, all the sort of tests which are seen even on the internet, a lot of people keep on coming and asking, can we do this test? I think all those tests were used to sort of use an adjective rather than adjective. I think it's more of an additional tool to confirm your diagnosis or prognosticate, but they were never a substitute, for a primary diagnosis. See, we have seen all that era of, all that PSA dynamics. You look at the PSA, free to total PSA, then have different scores, 4K scores, so many. So it was an improvisation into sort of, to get the better at a diagnosis. But I think it's extremely important to have one tissue diagnosis to actually have a horoscope of this patient where we're heading to.
Yeah, I think that's absolutely correct. I think the way field is moving, at least in terms of some biomarkers, for example, ERG is detected only in prostate cancer. We have never found it anywhere else. So I think, of course, I think that's true. It is going to be a multi-modality decision for sure, but I feel there is still possibly going to be some more movement in this field.
Yeah.
Thank you.
Thank you very much for the enlightening talk. And I'm happy that we'll all be in job, because I'm a pathologist. So thank you very much. My question, that was the comment. My question actually, it's for the panel also and for the pathologist. Actually, when the PSA is not high, like sometimes in Gleason pattern 5, we have a single gland pattern in which we don't see neuroendocrine cells. So my question is open to everybody. Do everybody do synaptophysin and chromogranin on them? Because the treatment modality changes. Because as you pointed out in this one, if the biopsy is not done, and my view is even if the biopsy is done in prostate cancer Gleason 5, for me I'm routinely doing synapto and chromo even if I don't see neuroendocrine cells. So I think if Dr. Rajal can have a...
That's a great question, and I think actually I have a case later in the afternoon, and it would be great if we can discuss on this more on this. But personally, I would never recommend doing a neuroendocrine markers unless there is a morphologic evidence of neuroendocrine features. Because if you stain conventional acinar adenocarcinoma, there is very likely probability that you will see some neuroendocrine markers expression. So neuroendocrine markers expression does not equate to a clinically significant neuroendocrine differentiation. Yeah, I think same thing, but I think if you may end up getting a lot of, false reads. And I think that confuses a whole lot. So I think our traditional kind of really important point is that do not use neuroendocrine markers unless there is a morphologic evidence of
So no penetrable differentiation, we don't do it.
Yeah.
Thank you.
Yeah, it's many times with the patients who have been treated and the patients are not responding or patients who have relapsed. That we are thinking of something, why is not responding. I think that's the time. Yeah.
It's very educative talk. Actually, from my experience, I'm from a tertiary healthcare center and hospital. So there, actually, I've encountered a difficulty. They gave a biopsy, which was treatment related. The patient was the prostate acinar adenocarcinoma completely subsided for 1 year with treatment, androgen deprived therapy they did. After that, the patient has a very small lesion, again recurrence, and PSA level was not high. And we found that it is treatment-related small cell neuroendocrine carcinoma. And by the time we diagnosed, within 1 month the patient died because of the bone metastasis. Sir, my question is, in this case, the biopsy is mandatory or not? Because the PSA level is not increased.
See, it's not only one parameter we actually look at. When the patient presented initially with sort of, a metastatic disease has been treated, we just not looked at sort of, PSA of these patients, Patients are clinically seen, patients are regularly followed up, they do get imaging, they do good clinical examination. So you don't miss out on those. And especially when the patient gets symptomatic or image shows some sort of lesion, they usually get a biopsy. So second biopsy is usually to find out these kind of sort of, de-differentiations or something neuroendocrine manifestations where they're treated with chemotherapy. So we just don't rely on PSA.
Sir, in these cases, the biopsy is mandatory.
Yeah, I think so.
And molecular studies also.
Yeah, I think so.
Yeah.
I think
and
so.
very indolent cancers like 3+3 Gleason score and all. Sometimes can it, without biopsy, it can do?
No, I don't think so. I don't think. See, medically is also not very right. And because we have seen so much different wide spectrum of prostate cancer tissue diagnosis, we have seen different grading, different subtypes and everything. I like the case which I showed, I think it was a carcinosarcoma. Yes, at the end, who would have thought of carcinosarcoma in a patient within 3 months of ADT? So we need a tissue diagnosis.
Okay, thank you. Thank you, sir.
Thank you. Next.
Thank you, Dr. Makran. I am radiation oncologist. PIRATS 3 and 4 is SUV on PSMA PET. Going to surgery means avoiding radical radiotherapy. So it's like misleading. Options of radical RT is not given to the patient. What do you think about that?
Yeah, so that's what I mean. So if you don't have a tissue diagnosis, you can't really counsel these patients for different treatment options. And that's what I mentioned in my slide. So even though test may be foolproof, even tomorrow you would say the MP-MRI improves its sensitivity to 100%, PSMA scan to 100%. I would like to give an option, treatment option, based on what the patient has, So unless we have a tissue diagnosis, active surveillance cannot be done, radiation cannot be done, focal therapy cannot be done. So for that matter, the biopsy is mandatory.
Thank you, sir, for nice presentation. Again, what you discussed, like neuroendocrine carcinoma, because the treatment modality is quite different in this case, and a very aggressive chemotherapy we plan for. And in our opinion and your opinion also, biopsy is a must before giving any treatment modality. As he told about the radiotherapy option also. And so we face this type of, sometimes young oncologists nowadays, they plan it. But you have to very much realize the fact before going to that. And we should not put the patient in dilematic situation. Thank you, sir.
Thank you, sir, for such a lovely talk. I really enjoyed it as a pathologist. First of all, because we're all part of collaborative, multidisciplinary teams in this new era of personalized medicine where one size doesn't fit all, and we're all working collaboratively on a patient-centered approach. And secondly, I really enjoyed your reference to the precision trial because this trial funded my entry into GU pathology, and pathologists were part of the whole trial design of this multi-center trial, which took into, I think, cohorts from all over the world. And from 2019 till now, even the center where this trial was performed and centrally reviewed for all the radiology and pathology, we have come into more collaborative working. And like Dr. Mahul Amin said, things are so rapid in the era of personalized medicine and computational pathology that the new trials are focusing on these mixed imaging techniques on greater precision and personalized approach.
I think it's Dr. Moore, Dr. Catherine Moore, I think she was involved in that. So it's pretty good, that the information we have, and then we take it further.
Thank you. Thank you so much. So I would like you to please be seated on the stage. We have a debate on which we would need your expert comments. Can I please call upon Dr. Girish K. Parida to speak for the motion, topic being PSMA PET-CT is the imaging of choice in prostate cancer. Dr. Girish, please. And against the speaker against the topic would be Dr. Biswajit Sahu. I hope you're around. Yeah. Over to you. Yeah.
A very good morning to all. And first of all, I thank the organizing committee, especially Dr. Saurav, for giving this opportunity. And
sorry? हाँ PPT PPT we will call.
So Girish is the assistant professor in the Department of Nuclear Medicine at AIIMS Bhubaneswar. He will be speaking for the topic. And Biswajit is assistant professor in the Department of Radio Diagnosis. He will be speaking against the topic.
Yeah. Slides are ready. You can start. Time starts now.
So I'll be talking in favor of PSMA PET-CT in prostate cancer. So like in general, any malignancy or any tumor, there is a diagnostic algorithm, and the basic aim of the diagnostic algorithm is to accurately diagnose the significant disease, or in this case significant prostate cancer when it's curable, and specifically avoid the clinically insignificant disease, and also avoid non-cancerous condition, the patients without cancer. So in this kind of journey to find a diagnostic algorithm or diagnostic modality which will help us to non-invasively diagnose a malignancy versus non-malignant condition MPMRI is the first modality or kind of a significant milestone in this journey to find a diagnostic modality. So that will be discussed by Dr. Biswajit. However, it has some limitations, like the negative predictive value of MPMRI is 80 to 85% and positive predictive value similarly 80 to 90%. So with MPMRI, there will be proportion of men who will be reassured not to have a cancer but will having a cancer, and also patients will undergo biopsy who will be not be cancerous. So we have, in this journey, the PSMA PET-CT comes as a significant marker. So this is the landmark study which forced the FDA to approve PSMA PET-CT in the diagnostic algorithm of prostate cancer. I'll be discussing this later. It is just the study which made the FDA to approve PSMA PET-CT in prostate cancer. And before going to staging, I will state the role of PSMA in T-staging or prostate diagnosis of prostate cancer, especially intraprostatic lesion. So in this, the most important study was the primary study. In this study, they just added PSMA PET-CT in already suspicious patients of prostate cancer to MPMRI, and of course the patient underwent biopsy. So what they did was around 300 patients who had recent MRI and underwent biopsy also had PSMA PET-CT. So interestingly, what they found is the sensitivity of MPMRI only is around 80%, and the sensitivity of PSMA PET is around also 90%. However, if we add both of them, the sensitivity shoot up to 97% or almost 100%. So we can almost, in a reasonable accuracy, we can tell the patient non-invasively whether it's going to come as a prostate cancer or not. So that's a significant addition to this diagnostic algorithm. And also to the other side, like if we add the MPMRI criteria like PIRADS 4 and 5 with PSMA PET SUV max more than 9, 100% patients came out to be prostate cancer. And irrespective of MPMRI result, if the SUV max more than 12, it's 100% coming out to be prostate cancer. So that's a significant finding they mentioned in their study. And also as a prognostic marker with SUV max rising, the prognosis is getting worse. Now this is the primary scoring they established, like PIRADS 1, 2, benign. So here also primary scoring 1, 2, it's considered benign, and 3, 4, 5, it's malignant. Now they also compared the diagnostic accuracy of both the modality, and it's found to be PSMA PET-CT is superior, and this led to like primary 2 study, which will be published later. And there are studies which compare directly PSMA PET-CT and MPMRI for staging of locoregional staging of prostate cancer, and PSMA PET found to be better. And this is a study I was talking about for staging. PSMA PET is 27% more accurate than conventional imaging, which is CT and bone scan. So, and also these are the 3 landmark studies for specifically lymph node detection, because that's where PSMA PET-CT has a limited role as per publications. Like the sensitivity a little bit low for lymph nodes, 40 to 60% around. However, it's still higher sensitive than MPMRI. So I think my previous speaker already told about whether we can really, skip the extended pelvic lobe dissection if PSMA PET-CT is negative. So there is an interesting study which showed that in intermediate prostate cancer, negative PET-CT can avoid unnecessary pelvic dissection with a reasonable accuracy. And also they also compare the biochemical recurrence progression-free survival, which is similar in both the cases, whether patient followed up on PET-CT or the extended pelvic lymph node dissection.
Time up, actually.
Okay. And this is just another, my last slide will be. In hormone-sensitive patients, The chatted score is used as a significant tool to differentiate high volume and low volume disease, and a recent study which showed that there are significant stage migration if you add PSMA PET-CT to the chatted score of conventional imaging. Although there is no long-term, they have not published a long-term clinical outcome of that. So we are still waiting for the result. And so coming to just the current guideline, and which says that PSMA PET-CT for staging should be used in unfavorable intermediate risk and high risk patients, and kind of patients with low risk, we don't need PSMA PET-CT. So coming to the challenges I already mentioned, and to conclude, PSMA PET-CT currently being the most sensitive and accurate imaging, and currently it is increasingly being recommended, and as I already told, the question remains the long-term clinical outcomes of the patients, and there are still RCTs undergoing to address this issue. Thank you.
Thank you. Now we have Dr. Biswajit Sahu to speak against the motion. You can please speak.
Thank you, Dr. Girish. You have said so many positive things about the PSMA PET-CT, but I am here to add some negativity into it. So, thank you, Dr. Girish. We all agree that it is PSMA PET-CT is one of the most sensitive and specific tests for the diagnosis as well as for staging and restaging of a prostate cancer. But there are some loopholes we can say is there are some situations where the role of PSMA PET-CT is limited. Like around 10 to 15% of cases of prostate adenocarcinoma, they don't express PSMA, so they are PSMA negative. And so for these kind of patients, we have to go for some other modality like FDG PET or fluociclovin scans. And there is another subset of prostate cancer that is with neuroendocrine differentiation that also doesn't show any PSMA uptake. So again, for these kind of patients, we have to go for other modalities. Then apart from this, we come across multiple situations where we get false positive and false negative results in PSMA, especially due to the modulation of the PSMA on the tumor cells, secondary to some treatment changes, like in post-RT patients, there is suppression of the PSMA expression on the tumor cells. So we might get PSMA negative results, or we can say false negative results. Similarly, we get false positive results in patients which undergo ADT, that is androgen deprivation therapy, because there is upregulation of the PSMA receptors on the tumor cells. So we might get false positive results in these kind of patients. Also, the sensitivities of the PSMA PET in detecting pelvic nodes, metastatic nodes in BCR patients, that is biochemical recurrence patients, is around 80%. But still, we are missing around 20% of cases in PSMA PET. And finally, we come across situations like there is a prostate cancer with a single single solitary lesion in the bone, and it's very challenging for us to confirm it, whether it is a benign lesion or is a malignant. But in most of the cases, come to be benign, because so before saying that before saying that PSMA PET is a modality of choice and is highly sensitive and specific, but we have to consider those cases also, and where it shows false positive or false negative results. So to conclude my findings, my topic is, yes, we do agree that PSMA PET-CT is quite sensitive and specific, but you have to consider the other things also before giving a report or managing a patient. Thank you.
Thank you. So can we please have the expert?
Thank you. Both the presentations were excellent. I think Dr. Biswajit was so vehemently against using PSMA PET scan. He refused to show the slides also. He didn't believe that he is in a PSMA PET scan, just a joke apart. I think let us look at the pragmatic and a practical point of view. Any new technology which comes in, we keep on thinking that is the sort of a best sort of a modality to treat the patients. See, before PSMA PET scan came, what did we have? We have a CT scan, we have an MRI, we have a bone scan. Now first, let us be very clear, nobody does a bone scan now, it's almost out of fashion. CA prostate, I don't think there is a role of a bone scan. We have a better molecular imaging in forms of PSMA PET scan. But are we overusing it or are we relying in too much on it? That is the big question. Now if you get a clinical scenario where a patient has a PSA of more than 100, he already has a bony metastasis on an X-ray, he has lymph nodes on imaging and ultrasound, I don't think there is any role of doing PSMA PET scan in these kind of patients. You already have a diagnosis. Similarly, if you have a patient who has PSA of something like 4, his MP-MRI shows a lesion of PIRAS 3 or 4, and you have done a diagnosis on a tissue diagnosis of carcinoma prostate, the chance that it would have a negative PSMA PET scan is almost nearly 100%. You may not see any metastasis. So like we talked about bone scan in the past, PSA more than 100, you don't need a bone scan. PSA less than 20, you need a bone scan to stage the disease. So as far as the urological oncologist is concerned, a clinician is concerned, I think don't overuse it. Use it only when you want to make a clinical decision whether you want to operate, radiation, active surveillance. The point you made is of pelvic lymph nodes, whether you can get away by not doing lymph node dissection in patients who have negative PSMA PET scan. So what we are doing it is now, we are not doing extended pelvic lymph node dissection, but we are still doing standard pelvic lymph node dissection because you still need to know the disease, and is about 10 to 12% of the patient, negative PSMA PET scan, we still found the patient of disease in level 1 into the pelvic lymph nodes. Third is a cost. Cost is an important issue. And last but not the least, as an expert, I would say, as a surgeon, if I want to operate a patient for a radical prostatectomy, I need to know the anatomy very well. And mind you, PSMA PET scan with the CT does not give you that kind of anatomy. What anatomy is given to me is by an MP-MRI, which is done just before the biopsy. So I think PSMA PET scan is good for a staging of the disease. It's good for a follow-up of the disease, and it can be avoided in clinically obvious disease and patients who have very, very low volume disease. And I think MP-MRI can be an adjunct, but it cannot be completely replacement for a PSMA PET scan. And I think that's what I have to say.
Thank you. Thank you so much. We have something from the
patient, and I suspect for involvement of seminal vesicles and capsule of the prostate. So which modality I'll choose?
Yeah, I basically usually, these patients would have had MP-MRI before they would have gone to PSMA PET scan. See, nowadays there is a trend, when they have elevated PSA, many of the physicians would straight away send them for a PET scan. That may be a PET investigation of that doctor, but it's not something in a PET investigation for the patient. So for anatomical delineation, MP-MRI score really sort of high as compared to PSMA CT. So I think I would prefer MRI before I put a knife on this patient. I'm sure same applies to you for a radiation. Yes. You require a CT planning, so that's why you require a CT. But if I have to decide whether I don't want to put a knife on this patient when there is obvious infiltration of bladder neck, apex and seminal vesicle, I think this information is given to me much more than sort of by MP-MRI than PSMA PET scan. And lastly, you have a PSMA PET scan after a biopsy, but no MRI done. I think you would get sort of false interpretations. They will be picked up into sort of peripheral zones and pouch of Douglas. So doing sort of just relying on a PSMA PET is not useful. We need to really wait and do MP-MRI and then take a decision.
Thank you.
I just have a question. I think some patients with prostate cancer, diagnosed prostate cancer, can be followed without management, either with surgery or radiation. The Scandinavian studies are there. So in those sort of situations, does your PSMA PET or MRI give it with sufficient accuracy without the need for a biopsy? So in that situation, of course, other than histological types, when you're going to follow a patient, you would need a biopsy, I suspect, with low Gleason score and so on.
Yeah, I think that's an excellent question. If you look at the sensitivity related to the PSA value of PSMA PET scan, if PSA is less than 2, I think the sensitivity is nearly 80 to 90%. The moment PSA goes above 2, it's nearly 100%. So when you have biochemical failure in the past, we always used to rely on sort of doing transrectal ultrasound scan again, or MRI, or CT, or do a biopsy, or even do liquid biopsy, or look at ctDNAs. So we're not doing any more of that. So if you have a biochemical failure, run the PSMA PET scan. It shows a local recurrence, they go for radiotherapy. If they show pelvic lymph nodes, they may need salvage lymphadenectomy. If they have sort of metastatic disease, your answer is there. But if you have elevated PSA, PSMA PET scan negative, then perhaps it's a big question, where do you find the disease? And maybe if you have any suspicion on imaging, then we probably do a biopsy of the anastomotic site or wherever suspicious area. So it's useful in follow-up very much.
Thank you. Thank you so much. Can I request all of you please come down on the stage for a group picture? Thank you, debaters. Thank you for the expert comments, sir. Thank you. Thank you. It was a wonderful, wonderful session. We are now moving to our next session, a panel discussion on localized prostate cancer multimodality management. I would like to welcome our chairpersons, Dr. Anita Ramesh and Dr. Amit Joshi. To moderate the session, we have extremely well-known researcher and clinician, Dr. Surendra N. Senapati, to guide us through this complicated topic. Panelists of the session are, I request them all to please come on the stage, Dr. Sandy Srinivas, Dr. Prashant Parida, Dr. Christina Maji, Dr. Lucy Patnaik, Dr. Amit Sehrawat, Dr. Animesh Saha, Dr. Shailendra Parida, and Dr. Lalatendu Moharana. Can I have all of you on the stage, please?
It's not visible.
Over to you, sir. Yeah.
It's not working. No. Good morning, ladies and gentlemen. So, the topic of discussion now, should I subject the patient of carcinoma prostate for biopsy before we start the treatment or not? Based on this, let us go with our presentation, Localized prostate cancer multimodal treatment. With me, the eminent panelist, Dr. Sandy from Stanford Cancer Center, Dr. Amit from AIIMS Rishikesh, Dr. Lalatendu from IMS SOM. So they are our medical oncologists. And the key of this today's presentation, that Dr. Christina, she is the oncopathologist, and with me, the radiation oncologist, Dr. Animesh from Apollo, Kolkata, Dr. Lucy from HPGIC Cuttack, and Dr. Shailendra, Dr. Shailendra from HPGIC Cuttack, sorry, this is by mistake. So this is the story. 65 years male, clinically presented with the form like frequency, urgency and nocturia of 4 months duration. He is a non-hypertensive on medication, and on DRE there is a palpable hard nodule felt on both the lobes of prostate and mucosa over it was free. His serum PSA, it is 12, sorry, it's in capital, okay, 12 nanogram per ml, but MRI, multiparametric MRI shows there is a hypointense lesion on T2-weighted imaging involving both the right and left lobe of the peripheral zone. The lesion also demonstrates restricted diffusion on DWI, and also there is no involvement of the prostatic capsule, seminal vesicle or neurovascular bundle, and there is no lymph node involvement. So the patient was subjected for biopsy. Biopsy suggests adenocarcinoma, Gleason score 7 and grade 3. With this background, the patient was diagnosed as a case of carcinoma prostate CT2, CN0 and CM0. Now question arises, should we subject this patient for biopsy or not? Over to Dr. Sandy, please. What is the indication of biopsy? Because what we are discussing just now. So a case of carcinoma prostate, what are the indications to go for the biopsy?
I think I would say first one, what will we do with the results, right? So based on his age, I think life expectancy is important. Comorbidities are important as to whether we would consider any treatment for this patient. So as I think about a patient coming in, the single most important one would be, what do we think the life expectancy is? If this is a patient who's in their 80s and who has significant coronary artery disease, cardiovascular complications, that you're not going to offer that patient any therapy, I don't think a biopsy is even warranted.
This is a patient of 62 years old and also on antihypertensive. Okay, fine. So the indications of biopsy are mostly if there is elevated PSA level, abnormal DR finding, and also imaging, that multiparametric MRI, and particularly pyrites more than 3. So we have to subject this patient for the biopsy. Now over to Dr. Krishna. How to report the prostate biopsy?
How to report the biopsy? So typically the 12 cores, we will report each core separately. So because they're submitted in a different container, so they're with a specific location. So there are places where they will submit also an absolute prostate biopsy, no absolute prostate biopsy guidelines. I'm not sure what, now in some places there are also the possibility to report a global score. So of course in each case you will report the Gleason score, the location is already submitted in the containers, the grade group that is associated with the Gleason score, the extent of the tumor in the biopsy, and I also report the percentage, if there's lymphovascular invasion and other factors like intraductal carcinoma, cribriform, and percentage of pattern 4 for tumors that are on the Gleason score 7, either 3-4 and 4-3. That would be the right answer. So the 12-core biopsy is usually performed.
Okay, fine. So now question arises, earlier concept was for the 6 cores, but now we are thinking for 12 cores. So what is the philosophy behind it? Why will opt for the 12-core biopsy? Dr. Krishna, please. 12-core biopsy. Why?
So, well, I don't know. The philosophy, I think, is that, typically the 12-course biopsy covers a better range of the entire prostate. So this is what is the preferred methodology. So that typically is done in sextant, and you have 2 biopsy on each side. So will be the apex, mid, base, right and left, and then you have the lateral lobes too that have been added so that there's a better coverage of the entire prostate and a higher chance, of course, to detect cancer.
Okay.
Can I ask a question to her?
Yeah.
So I think with the use of the shifting from truss-guided to the perineal biopsy, do you see that, is there any difference in going to be yield of the tumor while the truss versus the perineal biopsy? Is there any concern for that? Because we have been trained for truss-guided biopsy and pathologists have been trained to see from that aspect. Do the biopsy in another way, which is I think coming in a big way, and in next few years we will also be shift to the perineal biopsy. So do you think the challenge in that interpreting the perineal biopsy?
I don't think from a morphologic standpoint, there's no challenge. I think there are actually situations where the perineal biopsy may give more information, but I don't think in morphology it's anything that is affected, at least not in my experience. I've seen both type of biopsy. If it's a good biopsy, there's no impact on the pathology reading.
Fine. So let us come to the concept of the grade. Earlier we were considering for the Gleason score. Now it is the Gleason's grade. So what's your comment on this, Dr. Krishna?
Well, I think the Gleason grade actually is, and as was mentioned previously, right? So we report both the Gleason score and the grade group. And this is important because now the Gleason start with 6. Gleason score 3 plus 3 equals 6. And you're telling a patient that you have the limit, the lower you can get that is 6. That of course is a little bit, counterintuitive, because one would think that 6 is actually more than a half, so probably that cancer would be more aggressive. So the fact that now we report also the grade group and tells you that a Gleason score 3 plus 3 is a grade group 1, I think is easier for a patient to understand it is the lowest you can get in that grading system. And also the advantage is the fact that for the 3, 4, 7 in the past, those tumors were considered intermediate, but there is actually a lot of studies showing that there's a difference between a 3, 4, 7 and a 4, 3, 7. So these are two different categories. And so the grade group that allows you to distinguish between 2 and 3, I think has a lot of impact in terms of predicting outcome for those patients. Of course, now when you go to the 4, 4, 8 and or 4, 5, 9, those are when you reach to the grade group 5, these are very high tumors, and there's no distinction between 4 plus 5 or 5 plus 4 or 5 plus 5, because also we don't have probably enough data. These are not very, population limited. So.
Okay, fine. So there is an interesting question. These are funny questions and very silly questions, because it was asked from my postgraduates. Sir, what about up to 5? Because the score started with 6 and pattern 3 plus 3. What about up to 5? What's your comment on this?
So we're talking about subtypes of pattern 4?
No, this score it starts with 6.
Yes.
3 plus 3.
Yes.
But what out from 1 to 5?
What happened from 1 to 5?
Still report the 2 plus 3, so 3 plus 3 is 6. So whether it's still the relevance of 2 reporting as a Gleason score 2 in this scenario? Scoring.
If you have less than 6.
Yes.
Well, the score starts with 3 plus 3 equals 6, so there's no less than 6. So most of those tumors in the past were not really probably prostate cancer. They may have been adenosis, they were misclassified. And now with the use of immunostains, we have a better way to recognize. So probably the lowest you can go is a 3 plus 2 on a transureter resection if there is a well-confined lesion. But we don't use anything less than 6. So that's why the grading started with 6 or less, because there's nothing less than 6.
There is a concept there whether really to call 3 plus 3 as a cancer or not. So that is also a debate going on, whether 3 plus 3 is really a cancer or not.
Well, that I think is up for debate. Dr. Zhao mentioned that he would be one in favor of eliminating the cancer diagnosis. I will be actually against. So I think that 3 plus 3, if you use the criteria to make a diagnosis of cancer, I don't think we should change the criteria. I think we should educate individuals that if you have a grade group 1 tumor, you are a good candidate for active surveillance. I don't think we should change the diagnosis. I can see advantages or disadvantages of both ways, but I don't know if we want to go into that.
Okay, thank you. So let us move to the technology. We have discussed already the routes, whether we have to opt for the transperineal or the transrectal. Over to Dr. Lalatendo.
Whether we should go for transperineal or transrectal, I would prefer transrectal only, because transperineal is more invasive, more painful. Transrectal, transgender biopsy is still preferable for me for a suspected prostate cancer.
Any of our panelists like to differ?
Hello. Yeah. So what I personally feel in the perineum, you have that important structure, the perineal node, and quite the point
and it may be quite painful, and the post-operative pain recovery after a perineal biopsy is more traumatic than a transrectal biopsy.
I think with me, the surgical oncologist, sir, what is your practice?
Meanwhile, I think till sir reply, I think now in overall infection, so the question of transrectal versus perineal, so the rate of infection, whatever the data says that the overall chances of infection and the need of the prophylaxis for doing, from that point of view, now there is a shift towards the although it's little bit more painful, but still now word is gradually shifting towards the transperineal biopsy compared to the, we have to train ourselves to get it done. So it's the ease, I think in due course of time, as more and more IR people will get trained to do a biopsy or surgical. So I think we are in transition time. Dr. Makran can further elucidate.
So let us listen from the urologist.
I don't think there is any much problem in terms of pain or infection. I think the infection rate is slightly less in the transperineal as compared to transrectal. Transperineal has come mainly with a new imaging where we are trying to do more of a targeted biopsies rather than doing 12-core biopsies. You don't do 12-core biopsies at transperineal. Oh, good old days we used to do that. But again, transperineal is not so easy. You need to have a template. You need to spend a lot of time in the theater. It has to be done under epidural anesthesia many times because it's very painful, but transrectal can be done on an outpatient basis. So it all depends on sort of what you're looking at. If you have somebody who has a T4 disease, I don't think you require sort of transperineal biopsy. You just take one sort of core, that's good enough. They don't even require 12-core biopsies. So if you ask me transperineal versus transrectal, very precise targeted biopsy, you have expertise, you have good imaging in hand, do transperineal. If you have a sort of disease, you don't have an expertise, you do a transrectal biopsies with a good antibiotic cover. And the little difference I said to you as a surgeon, it makes a difference to me. If I do transrectal 12-core biopsies, for 6 weeks I can't do a radical prostatectomy on him because it's very plastered and inflamed sort of area in the pouch of Douglas. If you do transperineal, I still can go ahead and do a quick radical prostatectomy.
Okay. So these are the 3 trials, and also that has highlighted that.
Who does the transperineal and who does the uterus? Will the same surgeon do, or the transperineal can be done by an intervention radiologist?
That's always a debate. As a urological oncologist, we would like to do it ourselves because you know what you are dealing with, where you are heading with. And so I think it's a urologist who does it.
So this is the 3 trials, and they have mentioned that there is no much difference whether it is in transperineal or the transrectal. The question of infection counts, but that is of not much concern. It's only 1.4%. So the guideline is that perform prostate biopsy using the transperineal approach due to the low risk of infection. That is EAU recommendation is a strong recommendation. But the other 2 associations, they also don't agree with this statement. Now, question is whether we have to go for a multiparametric MRI first or the biopsy first. Over to Dr. Sandy, please.
I think it depends upon different institution. I think for us, patients end up, that's part of the work process. I personally think, you should do the MRI first. Yes. It allows you, we heard a lot about it from the morning, in terms of the benefits of MRI. It helps them even be able to do focal biopsies. So if you have access to a multiparametric MRI, I think that should be the workflow where you do it, and it'll also allow you to make some decisions about treatment options, but ultimately, the patient is going to need both. What would be the right order, I think ends up being what your availability is as well.
So what the recommendation said that let us go for the multiparametric MRI first, followed by the, we have to advise for biopsy, because the philosophy that the prostate biopsy can cause hemorrhage and inflammation which obscure MRI finding for up to 4 to 6 weeks. MRI prior to biopsy provides a clearer view of the prostate structure and lesion, and personalized treatment, particularly it guides whether a biopsy is even necessary or not, particularly in pirates 1 or 2. Now comes, these are the few parameters MRI findings, and mostly the sequence that we have to take, the T2 weighted imaging, DWI, and DC, and also MRS. So usually this MRI finding in T2 weighted image, it is mostly hypo-intense. And also if you go for MRS, mostly in normal prostate there is less choline peak and mostly the citrate peak, but just opposite to that in malignancy there is the choline peak. And here few examples I can show you here. This patient had undergone the biopsy first, followed by the MRI, and there we can get a picture that is called hemorrhage exclusion sign, where we can see here the red arrow, that is the hypo-intense area, and surrounding area is the hemorrhagic area. And that particularly hypo-intense area has not taken in any contrast, so that is hemorrhage exclusion sign. And also the erased charcoal sign, particularly if the lesion is present at the periphery. And if there is seminal vesicle is involved, that this spoiled grape sign. Now comes the usual practical workflow.
Sir, one comment, sir.
Yes.
Sir, this is Dr. Animesha. Sir, I'm sure in our practice, all of our oncology colleagues have come across this situation where patient has been evaluated outside by an urologist with an USG and in a suspected BHP patient, symptomatic BHP patient, they have done a TURP, and that has come positive as prostate cancer. So whether we should delay the MRI after that TURP procedure for 4 to 6 weeks, or whether we should do it immediately to stage the patient and start treatment.
What's the comment of her urooncologist?
I think I made a comment when Dr. Santosh asked the same question in the morning. It all depends on sort of what was his PSA like, what was the clinical situation like. If somebody who had a retention PSA 50, had a TUR done, Gleason score 9, I'm not going to do sort of MRI or anything. Straight away go for a PSMA PET scan for a staging and then take it further. But if it was PSA which was normal, incidentally picked up carcinoma prostate on a transitional zone of the prostate, I need to make sure it's just an organ confined, and for that matter, he needs an MRI. Once MRI has been done, subsequently do peripheral zone biopsies to stage the disease. The timing, 4 to 6 weeks after TUR.
Okay. So let us move to that. The practical workflow. First we have to, if the patient has elevated PSA or abdominal DRE, then subject that patient for the multiparametric MRI. If multiparametric MRI pyrites 3 to 5, then performs the targeted biopsy. But if multiparametric MRI 1 to 2, consider for surveillance or repeat PSA monitoring. Now, our diagnosis based on this, let us discuss about the staging. So in staging, we had, in this case, this patient had the lesion present on both the lobes of the prostate, and in this situation, it is T2C. Now, this is question to Dr. Amit.
Sir.
So, what will be the stage in this patient? Because prostate cancer is staging not only based on the TNM, it also has been added the PSA value and also the Gleason's grade. So in this patient had the TNM, it is T2C.
T2C.
And PSA
was
12 and Gleason grade 3.
Yes, sir. So this fits into intermediate risk category of the patients, and this is a kind of group that there is a kind of still darkness, how the prognosis is going to be there. So these group of the patient are more informed by additional genetic testing, molecular profiling. So there will be going to be better prognostication for this group of the patients.
Okay, fine. So that will also, there are some slides are there. So it is stage 2C. Now with this background, let us stratify the grouping. So it is easy to remember the GPS, that is the Gleason grade, PSA value and the stage, but the first is stage. So in our patient, we had the finding that MRI finding show that it is C2C, PSA level 12 and also Gleason's grade 3. So to Dr. Animes.
So yeah, sir, as you have shown, it's intermediate risk, and there is unfavorable risk group criteria like Gleason's grade group 3 is there. So it should be unfavorable risk category.
Fine. So ultimately we came to a conclusion that yes, this is a patient of carcinoma prostate of stage 2C, unfavorable intermediate histology. Now comes, should I subject this patient for the PSMA PET? To Dr. Amit.
Sir, so actually this decision based on two main factors. Number one, what is going to be our overall treatment plan, performance score of the patient, whether we are going for a kind of radical approach or our approach is going to be more in terms of supportive care, best supportive care and limited treatment intervention, number one. Number two, local logistics, availability of PSMA PET. So these are probably most important determinant in my practice whether I am going to offer PSMA PET or not. Coming to the academic question, yes, there is evolving, growing evidence. So more and more studies, like there was one publication on 3rd of Jan this year only, that is saying in non-metastatic patients, if you are going PSMA PET, up to 49% of the patients, they will have metastatic disease. And up to 24% of the patients, they are going to have polymetastatic disease. That means more than 5 metastatic lesions. So academic answer is yes. Practical answer depends on local logistics and patient's treatment plan.
So very good. So the recommendation like this for the intermediate risk disease for patient with International Society of Urological Pathological grade group 3 includes at least cross-sectional abdominal pelvic imaging, that is, we have already done MRI and a bone scan for metastatic screening. But this is a weak recommendation. Perform PSMA PET CT if available to increase the accuracy. So it's not mandatory. But in case of high risk disease or locally advanced disease, yes, we have to advise for PSMA, which is a strong recommendation. Now, over to Dr. Sandy. So this is a case of carcinoma prostate, stage 2C, and it is a unfavorable intermediate risk. So what should be your treatment policy?
I mean, I think we would have the patient meet with the surgeon as well as a radiation oncologist. And a big part of this is patient shared decision making, about what they would want. But I think for a patient with unfavorable intermediate risk, they truly have a choice of either having a radical prostatectomy or have radiation as well. The question for unfavorable will become, if we were to use radiation, what the duration of hormonal therapy would be and whether they need additional ADT for unfavorable intermediate. Typically, if they are doing radiation, we would recommend a short course, maybe about 4 to 6 months for unfavorable intermediate.
That we'll discuss. So, question arises. So, this is the recommendation. Active surveillance, it's because this is a intermediate unfavorable. So, there is no scope of active surveillance here. Either we can go for radical prostatectomy or radiotherapy options. Is there any scope of active surveillance? Dr. Lucy, what's your comment?
This patient, no.
No. Okay. Because these are the different trials, and that has also highlighted that yes, there is no scope of active surveillance. But for the information that, what do you mean by Dr. Sailendra? What is the difference between observation versus active surveillance?
The intent mostly for active surveillance or observation is the quality of life of the patient. And the difference mainly in active surveillance, the intent is cure. And in this observation, the intent is mostly palliation. So we defer the treatment in active surveillance till progression. And in observation, we defer the treatment till the patient develops the symptoms, and mostly it is palliation only. We direct the treatment toward palliation.
Fine, thank you. So let us note that we are discussing about this survival, whether the patient will survive for more than 10 years or less than 10 years. So how to decide that? So over to Dr. Lalatendu, what's your comment? What you do in your practice? How you assess that, yes, more than 10 years, less than 10 years?
We have to take into account many factors like comorbidities and the age of the patient. Taking into account everything, we have to decide whether the patient is going to live more or more than 10 years or less.
Yes. Any learning panelists can add anything?
Sir, geriatric assessment. So that should be part of standard of care as of now. Like every patient in a geriatric age group must be subjected to at least limited geriatric assessment before deciding on any kind of further treatment course.
Do you use any live tables, particularly what Any one of you using any tables?
WHO,
Ma'am,
we have
Sandy
used
ma'am?
WHO table.
I think the NCCN guidelines does get you to the Social Security Index page. I find it a little challenging to use that honestly. I think a lot of it is our performance status, comorbidities, the patient's overall, how long his father lived. We take all of this into consideration, but the NCCN page does get you to the Social Security Index. It sort of gives you, for a 65-year-old, what their life expectancy is going to be, and then you minus some 2.5 if they have other comorbidities. If there's none, you actually add a few more years. So it gives you a rough ballpark, and I find it somewhat helpful.
Okay.
We also do what, like doctor has said, that is a geriatric scoring. There are 10 points which tells you how far you can walk, whether you need help at home, the activity of daily living. So all patients we do. So that also gives you, and what you similarly said, we do. And we do it in what Dr. Amit said exactly. It's very easy to do. It's not difficult. Couple of points, we can do it in the OPD, and we do for not only prostate cancer, all patients with
Okay, it
tumors.
can be well taken care of. Right. So Dr. Animesh, what's your comment? Both the options are available. Radical prostatectomy as well as the AD2 with radiation. If you are the treating person or the treating physician, what's your option?
Yeah, so we need to discuss both the options with the patient, and patient should be given a fair chance to meet radiation oncologist and a surgical oncologist or urosurgical oncologist, and we should taking into account of the various factors like patient's factor, age, performance status, comorbidities, life expectancy, tumor factor. What is it favorable or unfavorable? Whether there is any, it's organ confined, whether there is extracapsular extension, seminal vesicle invasion, what's the level of PSA, and patient's choice also play an important part. And apart from that, now genomic information is coming into picture, who is low decipher versus high decipher. So I think all this we should take into account, but patient should be given both the options.
Okay. So this is the data particularly comparing the toxicity profile, radical prostatectomy versus that of the radiotherapy, and this is the 12 years risk relation between prostatectomy versus radiotherapy, the toxicity profile. If we'll compare here, the urinary or sexual complication, erectile complication and also urinary incontinence are mostly higher in radical prostatectomy group, and also in radiation group, there is more incidence of radiation cystitis. But with the advent of the newer technology like IGRT, we can also, SBRT also, we can also reduce this mortality. So, this is the analysis that we have made, that whether the radical prostatectomy is expensive or the radiotherapy is expensive. Sir, any comment? I know you are ready, sir.
I think basically before we talk about the diaper cost or the complications of, or problems of both the modalities, the counseling of the patient should be taken along with the radiation oncologist and medical oncologist and a surgical oncologist together. In the past, the experience used to be, we used to say to the patient, go to the radiation department and have a sort of an idea of what the radiation means to you as such. He comes back completely impressed with the radiotherapy and said, you people don't do a good job. You will have sort of incontinence. You have to use the diapers and other things. The reverse experience is they go to the radiation oncologist first and come back to the surgeon. They will go back to the radiation oncologist and say, you didn't tell me that you have got radiation cystitis, proctitis and all those things. So I think the best way to iron out this is to get the patient and have a simultaneously counseling and give them all the details as such. And mind you, I think if you are doing a good surgery, I think that diaper is not much required. And I think for the radiation itself, I think the radiation treatment has become so good, I think you can minimize the side effects. So this is perhaps not an issue for the patients.
Sir, it's very good. So there is no I in a team. So it needs the effort of both the surgical oncologist, radiation oncologist, medical oncologist. So it's a joint effort. Good.
Can I have just one question?
Now,
what is the role of the molecule? So, do you use the decipher and Polaris in this scenario, and how relevant? You are
sir, there is a slide in there because we are running sort of time. I think organizers would not allow any time. So this patient was opted for the ADT with radiotherapy. And what are the different type of ADT that we can practice? Dr. Lalatendu.
We have got surgical and we have got medical. And in those patients, in a T2C, non-metastatic disease, we usually prefer medical ADT. And in medical ADT also, we have got option of GnRH agonist and GnRH antagonist. And,
okay.
So GnRH agonist, like antagonist, like both can be used. Particularly in this case, there is nothing much to choose from agonist and antagonist. Both can be used in this case.
So my other medical oncologist panel, what you practice?
So if in a non-metastatic setting, primary ADT remains systemic ADT only.
No, in this case?
In this case, we are having an option of injectable versus oral. So oral comes with additional pill burden, although there are theoretical advantages of it, but that comes with the cost. That cost is still at par. So there is no cost advantage as such, but there is additional pill burden.
No, what you practice?
We are practicing injectable antagonists.
Okay, fine.
Those who are referred.
Madam.
We again can either use an oral drug, LHRH antagonist versus the injectable. I think there is advantage to using the oral drug where your recovery of testosterone is much faster. I think that's a huge issue for these patients who are getting, whether it's 4 months, 6 months, 18 months, you know, their recovery of testosterone is a big deal.
Okay.
So I prefer oral LHRH antagonist. The second one is also issue of cardiac comorbidities. There's some data that suggests that for patients who are like cardiac cripples, that maybe LHRH antagonist would be better than the agonist.
Okay, fine. So that this is data, that's a survey, and also it has been found that majority of the oncologists, they usually opt for the LHRH agonist. Now question raises to Dr. Lalatendu, what will be the duration of the hormonal treatment, particularly in this case?
In this patient, at least 1 year of ADT I would like to continue. And it's intermediate risk, 1 year is fine, sir.
1 year?
High risk patients I would like to continue for 3 years of ADT.
This is intermediate unfavorable. So what is your option? How many days that you want to give ADT?
In this patient, at least 2 to 3, in unfavorable disease, I would like to continue for 2 to 3 years.
2 to 3 years?
2 to 3 years of ADT.
Any other panelist, medical oncologist?
Up to 6 months usually.
Up to 6 months, madam?
I mean, I think I would do 4 to 6 months, but we do have the option to do decipher testing where...
Yeah. That is there, that slide there. And Dr. Anita, what's your comment?
Stick to
so
6 and 36.
That we can go up to 6 months. Now comes, what is the choice of radiation technique? Dr. Salendra.
Sir, we'll go for IG image guided radiotherapy so that it will decrease the toxicity.
5 minutes there? Okay.
Radiation toxicity like radiation cystitis, prostatitis, it is less with IGRT with image guided.
So you'll opt for the IGRT technology. Yes. Okay. And what about the fractionation? Dr. Lucy, which fractionation that you want to opt for?
In our institution also, we are opting for moderate hypofractionation. So these are all phase 3 randomized control trials which have compared conventional versus hypofractionation. So we are finishing in 60 gray, 20 fractions using image guided radiotherapy.
So it's common practice that we have to go for moderate hypofractionation.
And they are all non-inferior trials.
Not ultra hypofractionation.
Not ultra.
Very good. So now comes, what is your comment on the SBRT? Dr. Animesh.
So, sir, we have started using SBRT for some of our patients, like low risk and intermediate risk patient. And as per the PACE trial, following the PACE B trial protocol, that is 36.25 in 5 fractions. And we do maintain strict image guidance, daily preparation of bowel and bladder, daily enema before we take the patient for treatment. And so far the experience has been good, but there is a learning curve. But as Madam told, moderate hypofractionation is standard. Yeah.
But so till now, we all are practicing with moderate hypofractionation.
Yeah, for low risk, intermediate risk, there is option of doing SBRT, and some of our institutions are adopting that.
Fine. Yeah. Now over to
Just
Dr. Krishna.
One quickly. If things are available, is there any role of proton in prostate?
Yeah, this has come out in a very big way. And also,
Proton is in a big way in C prostate, especially in United States and now
Yes.
also in India. So
But there is,
proton in
I
a
think,
very big- because you can escalate the dose to a much higher, to 70 gray and beyond without affecting the surrounding tissues.
But I think there is a good data that it has not shown in terms of the efficacy and safety. So just to say that it is, yeah, so I think still pushing proton in a prostate cancer in India, I think we should take a backseat at this point of time.
No,
Whatever
it's a-
data available, proton has not shown superiority in terms of the efficacy or safety. And there is one randomized, I am not able to recall the name, that has just published about that. So it's not that much beneficial. But
so I am running short of time. So over to Dr. Krishna. What is your comment on molecular testing in carcinoma prostate?
Well, I think there's a lot of variability depending different institutions, but now specific to this patient, of course, I will leave it to other experts, but I would think that the decipher that was mentioned previously would have a big, value in predicting the metastatic disease, and maybe may have an impact in how the patient will be, evaluated. Now, the other two tests, can be used a different way. So, I don't know. This is the decipher scores that you will get now. I don't know how the clinician then will use it, but in general, depending on the risk, right, you have either a low risk of metastasis and death, or a higher risk, and this will be what will make the clinician decide how to pursue in terms of the treatment.
So this is the clinical importance of the genomic testing, the risk stratification. Particularly, it helps to distinguish between indolent versus the aggressive cancer, active surveillance versus definitive treatment. It identifies the candidate for active surveillance by confirming the low-risk disease. Post-prospective decision making, it guides the need for adjuvant radiation or systemic therapy. Also guides the treatment for high-risk disease where there is established treatment intensification is essential. But beside that also, it also acts a prognostic marker, particularly metastatic risk or biochemical recurrence or disease-free or disease-specific mortality. With this background, friends, so this is a 62 years male, diagnosed as a case of carcinoma, prostate, stage 2C, unfavorable, intermediate risk factor, and the patient was, I think all my panelists will agree that this patient should undergo the ADT for 6 months with moderate hypofractionation radiotherapy. I think all will agree with this. Yes. Okay. Thank you, the panelists and ladies and gentlemen.
Thank you.
So I am 56 seconds earlier.
Sir, I had one question for the
Yes.
molecular thing. Which are the stages or in which category do you advise for molecular testing? Leaving the recurrent metastatic high risk, what do you do for low and intermediate? Do you really need it? We know there are good points.
Yeah, even for this patient, I'm not sure whether I would do it, because if you've made a decision to do 4 to 6 months, what is it going to tell you, right? So I think I find the value of this more in patients who are getting radiation in the salvage setting. There it's really helpful, and there have been validated tests that tell you how you should be able to use it more for advising the patient and also for duration of hormonal therapy.
Yeah. So in our practice, low, intermediate, we don't do. Yes, high risk, yes. Metastatic, recurrent, relapse, first line, second line, yes, we repeat it. Yes, thank you.
Thank you for that wonderful discussion, sir. Can we please have a group picture? I would request the moderator and the panelists to please come at the center. Slides. Panel discussion slides. Thank you so much. We now proceed towards our next session, which would be a keynote address by Dr. Sandy Srinivas. Can I please call upon the chairpersons, Dr. Surendra Senapati, Dr. Anita Ramesh, Dr. Sushma Sharma, Dr. Anurag Mishra, Dr. Amit Joshi, Dr. Soumya Panda, and Dr. Makaran Kochikar, sir, please. Please come on the stage. Over to you, ma'am.
Thank you so much for this, sorry, is the mic on? Good afternoon, and I know I'm somewhere between you and the lunch hour, so really appreciate you guys staying in, and want to really extend my gratitude for this invitation. It's really a pleasure to be here in this beautiful city of Bhubaneswar. So I'm going to shift a little bit and talk from a clinical perspective, and my focus of my talk is going to be on oligometastatic prostate cancer. Let's just start off with the definition, right? What is oligometastatic disease? This is sort of a new clinical state that's been thrown upon us based on our current imaging, but most guidelines and focus have been with a definition of having less than 5 metastases as being considered oligometastatic. What is the clinical implication of this? The idea here is that if you were to find fewer metastases, could we be directing some local therapy to this patient, be it surgery or be it different forms of radiation? And I think the bottom line in all of this is there is something, a biologic behavior that defines oligometastatic disease. And that's where I think the focus is. This field in prostate cancer is more in its infancy, and I think we have a lot to learn about this. So this was one of the papers which I found really interesting, where there's a very complex pattern of metastasis. We have always thought in the past that it's very orderly. It starts from the primary organ, then it goes to lymph nodes, and after that there is systemic spread. But what this paper really showed us was that you can have metastasis from the primary tumor, but you can also have metastatic spread from a metastatic site. So I think this is a concept of why you would want to treat oligometastatic disease. The other message that came out from this paper is that, as a cancer stays in your body, there is clonal evolution and there's more development of molecular changes. So is there a benefit in treating sooner rather than waiting for a patient to develop 10 or 15 metastases? All of this has changed based on our imaging. Today, as we have discussed PSMA imaging, it's really changed the way we see it. You can see a picture up here of a traditional bone scan showing about 3 sites of metastasis, and in that same patient, a PSMA scan showing pretty widespread disease. So what has PSMA imaging done to us in this field? It's converted patients who had no metastasis by conventional imaging to now having this oligometastatic site. Those patients who had low volume disease, now by PSMA imaging, we are finding that they have multiple metastasis and high volume. Before I get into the treatment for prostate cancer, this whole concept of oligometastatic disease is not new. In colorectal cancer, for instance, they've been doing this for decades, where patients with liver metastasis, by having chemotherapy first and then having surgical resection, have resulted in a cure for a large number of patients. But I think to the pathologists in the crowd, it's really helpful to know that there's so much heterogeneity, right? So this paper in 2018 took patients with liver metastasis, and they came up with a genomic profile, and you can see it falls into 3 different categories. The patients in blue have the stromal signature, and you can see a tail at the end of the curve where with long-term follow-up, these patients are actually cured. On the other hand, if you look at the column in red, there are a fraction of patients where localized therapy has not resulted in long-term outcome, and these patients have needed systemic treatment. Now, this is not limited just to colon cancer. As was mentioned earlier, I mean, 3 decades ago, we didn't have great therapies for kidney cancer that we have today. So in the early 2000s, if a patient with kidney cancer had a lung metastasis, metastatectomy was done. So I'm sorry, I lost my voice. Sorry about that. So coming to prostate cancer, this is a very heterogeneous group. You have patients who have heterogeneity in terms of sites of metastasis, so it could be bone, it could be lymph nodes, or it could be the viscera. I have water, I don't know. Thank you. But more important, I think prostate cancer is so unique in that you have different clinical states. So for instance, you can have patients with de novo metastatic disease, and your PSMA PET identifies 2 sites of metastasis. That's de novo oligometastatic disease. And then you have patients who we define as oligorecurrent. So these are patients who have had a primary therapy for prostate, either a radical prostatectomy or radiation, and they now have a few sites of disease. And then finally, patients who we as medical oncologists see a lot is patients who have castrate-resistant disease. They're on a systemic therapy, but they have progression in just a few sites. Clearly, these 3 groups are very, very different, and the goal of treatment in these groups are also different. So let me just highlight for a patient with oligometastatic de novo disease, by finding the disease early, could we cure these patients? I don't know whether that's an answer today, but that's the hope for tomorrow. For a patient with oligorecurrent disease, hormonal therapy is fraught with so much problems. Patients have a hard time tolerating it. Low testosterone has short-term implications, long-term implications. So could the goal of that patient getting localized therapy be to delay systemic therapy? And then finally, for the oligoprogressive patient with CRPC, adding more drugs comes with a higher toxicity, whether it's drug toxicity or financial toxicity. There are different goals for these different set of patients. So let me start off with a case. So this is a typical patient, 64 years old. His PSA goes from 1.4 to 6 in less than 1 year. He has an abnormal DRE. His MRI reveals a PIRADS 5 lesion. He gets a biopsy, and you can see the grade up there. And his PSMA scan does show disease which is locally advanced, in addition to a small number of metastases bilaterally. So what should the therapy be for this patient? And I'd like to address his systemic therapy. I'd like to address what should be done to his prostate, and I'd also like to address the metastatic directed therapy. So what do we know so far? Systemic therapy is the key, there's no question about it, and I've listed up for you here more than 9 randomized trials that have looked at ADT alone versus ADT intensification. And the intensification can be done either with chemotherapy, as shown in the first 2 trials, or with our androgen receptor pathway inhibitors. So you have the choice to use abiraterone, enzalutamide, or apalutamide. So all of these trials have shown us that it's superior compared to ADT alone. And This is pretty significant with improvement in overall survival. Now, all of these trials included patients who also had low volume disease. And I want to just say that the definition of low volume disease in the field of advanced prostate cancer is fairly standard. It involves having more than 4 metastases, or having visceral disease would be considered high risk. So in all of these trials, what data do we have for a patient such as the patient who I presented with oligometastatic disease? You can see from these trials that they did have patients with low volume disease, and in all of those patients, there is an improvement in overall survival. So for this patient, I would say the minimum should be systemic therapy, and it should be with a doublet, whether you choose any of those drugs, whether it's ABI, ENZA, APA, any of those for your choice. What about chemotherapy? Chemotherapy, similar to the ARSIs, have shown to have a benefit, but it's a little controversial because the benefit appears to be more for patients who have high volume disease. As you can see up here, there is a separation of the survival curves for patients with high volume, but you can see that the curve to the right for patients with low volume disease, there doesn't seem to be a benefit. And this is a meta-analysis that took all of these trials. And if a patient with advanced prostate cancer is sitting in front of me today, we think about 2 things. Was it de novo metastatic disease, or was it a patient who had prior local therapy and then developed metastatic disease? So synchronous versus metachronous. And the second one would be, what's the volume of disease? Do they have low volume disease, or do they have high volume disease? And once you do this, the patients separate out into these 4 curves, and it looks like patients who have had a prior therapy for prostate, to their prostate, the metachronous person with low volume disease does not appear to benefit from chemotherapy. So certainly that's something that's clear. The rest of the patients, I think it has to do with what's available to us in terms of treatments. So there are many unanswered questions with what I've presented so far, because all of these trials that we have done to date have been with conventional imaging. Now that we use PSMA PET imaging, how does that relate to the current data that we have? The second point is, today for metastatic disease, patients are treated continuously till progression. Is there an option where we now have such good imaging that if we were to treat somebody with oligometastatic disease, could you stop their hormonal therapy and sort of help them with quality of life? Can we use genomic selection to determine duration of therapy, etc.? These are some of the unanswered questions. Now, moving on to what is the role of treating the prostate in somebody with oligometastatic disease. We have 2 large trials that have actually addressed this. One is the HORAD study, the larger STAMPEDE study, and then there is a meta-analysis combining these 2 trials together. And here is the message from all of these 3 trials, that for patients with low volume disease, there was an improvement in longevity by treating the prostate in patients with metastatic disease. So let me just dive a little bit into each of these trials. So the HORAD trial was somewhat 430 patients. Again, you can see up here that in the forest plot, for all comers, there was no benefit in terms of treating the prostate. But for those patients who had less than 5 metastases, there was an improvement in overall survival. You can see that the hazard ratio was 0.68. And this, around that same time, the Stampede trial, which is the UK-based trial, which had multiple arms. So they looked at the standard of care versus adding radiation to the prostate. And again, this trial met all of its endpoints, again having almost identical hazard ratio like the HORAD study. So again, favoring that patients with low volume disease have an improvement in overall survival by radiating the prostate. Quickly, this got adopted into standard of care, and most guidelines had the inclusion of radiation to the primary for patients with metastatic disease, became a standard. Then came the PEACE 1 study. So this is a French study that now that we have hormone intensification, this study had patients who had ADT. They also got drugs such as docetaxel and abiraterone and asked the exact same question. So is there a benefit when you're doing hormone intensification by radiating the prostate? It came as quite a surprise that there was no survival benefit for patients with low volume when they got the prostate radiated when you intensify your systemic therapy. So maybe because our systemic therapy is so good that the value added for local radiation was lost. But interestingly, what the group showed was even though there was no survival benefit, for these patients there was significant improvement in GU symptoms. So not needing catheterization, not going into urinary retention, all this matters to patients. So even if you don't have a longevity, for patients with low volume disease, there may be some benefit in radiating the prostate. So what about the role of prostatectomy? Much of what I've said is using radiation to the primary. We don't have a lot of prospective data about the role of prostatectomy in patients with oligometastatic disease, and we await some of these trials that are ongoing. Finally, I want to talk about metastatic directed therapy. So for my patient who just had those 2 sites of metastasis picked by a PSMA PET scan, is there any benefit in doing SBRT to those metastatic sites? The data is somewhat, I find it very surprising because in medical oncology, drugs get approved when you have thousands of patients. So you can see up here, this is a randomized trial. It's a highly quoted trial called Sabre Comet, where they took patients, it's a phase 2 study, it's randomized. It didn't have patients with just prostate cancer, they had lung cancer, breast cancer, so many metastatic patients were included, either to get standard of care therapy or standard of care plus SBRT to these limited sites. And prostate cancer only had 16% of patients in this study. And you can see that compared to standard of care, when you do SBRT, there is actually an improvement in longevity, which really came as a surprise that, again, today this has become quickly adopted into clinical practice without really having level 1 evidence. So the next question that have also been asked is, now could we do a shorter course of hormonal therapy? As I mentioned earlier, the standard for metastatic disease is to get androgen deprivation therapy lifelong till they develop castrate-resistant disease. So this group from MD Anderson went on to ask, if we were to do 6 months of therapy, would we be able to shorten the duration of therapy? And I think the answer is yes. So they did SBRT to these oligometastatic sites and gave them ADT plus abiraterone, and you can see that the group who had the SBRT had an improvement in outcomes compared to hormonal therapy alone. So I want to move on next to the oligorecurrent state. So again, to remind you the definition, these are patients who have had prior radical prostatectomy or prior radiation and who now have biochemical recurrence with PSA as their marker of disease. For this group of patients, it's standard to go on and get a PSMA PET imaging, and we now identify oligometastatic sites. So 2 trials that have really addressed this group of patients. The first one is the Oriole trial. This came actually from Baltimore, where it's a phase 2 study looking at SABR versus observation. Again, small number of patients, it's only 54 patients, but they were randomized to either getting SBRT versus observation. And you can see what the primary endpoints that I've listed up in this study were. You can see nice from the bottom, from the end of the room, that there is a separation of the curves favoring SBRT compared to observation. So this is good news. It was also interesting that this trial, they had patients who had PET imaging, and the radiation oncologists were blinded to whether they had PSMA PET or not. And if you see up here, those were the lesions that didn't get radiated, whereas where you see the relapse. So the second trial in the same space is called the STOMP, and again, this had a slightly different endpoint. They looked at how long can we keep patients from androgen deprivation therapy. And again, here they showed that patients who got SBRT with a 5-year follow-up, that 5-year ADT survival again was 8% versus 34% for the group who actually got SBRT. So certainly there is value add for using local therapy in these patients with oligometastatic disease. Now I want to focus the rest of my talk really on, how can we improve these outcomes, right? So there is a significant heterogeneity, and can we use genomics to help us identify who's going to benefit from this approach? So they were able to collect genomic data from the patients in the STOMP and Oriole trial, and were able to separate out that those patients who had bad genomics, such as BRCA, PTEN loss, RB, that those patients had different outcomes compared to those who didn't have these mutations. So just like was said previously, these are prognostic, but are they predictive? So in the bottom curves, you can see that those who had the abnormal mutation plus those who didn't, both benefited from these metastatic directed therapy, but those who had the mutation probably had a higher magnitude of benefit. So just like these, there are other biomarkers that I think are promising. One such is looking at PSMA extravesicles. So these are basically blood markers that you can find like ctDNA. And at least in this small study, they showed that if you have a low PSMA extravesicle, you can see that you benefit from SBRT, whereas if you had a very high score, SBRT wasn't of any benefit. So my hope for the future is that such tests may help us pick who benefits from a treatment rather than just give everybody these treatments. Finally, I think, to bring in AI, so this is the AI, multimodal AI model where they include clinical characteristics. So it includes pathology, age, PSA, and T-stage. They take your digital pathology and then come up with an MMAI score. And as was said earlier, this is definitely prognostic and also predictive, where you can see that whether there is a benefit with ADT or not. So the same test was conducted in the STOMP and Oriole patients as well, and they came up with those who have a high MMAI. You can see that it is prognostic. So the curve up here shows you that if you were MMAI low score, you have a longer life expectancy compared to those who have a high MMAI. And similarly, it appears to be in this small cohort that it might also be predictive. So you can see the first curve up there. If you were MMAI high, you had a benefit with MDT, whereas if your MMAI score was low, you didn't have a benefit from MDT. So small numbers, hard to make a lot out of it, but my hope is that genomics will help guide patient selection in the future. So interesting for the pathologists in the room that I think these sort of tests help us also give some idea about prognosis. So in this group, they also reported that there was higher frequency of SPOP mutations, which sort of gives a good response to hormonal therapy. Patients who had a low MMAI had a higher frequency of these SPOP mutation, and I think the reverse was also true. So if you had a high MMAI, you had a lot of bad genomic markers such as the DDR, BRCA mutations, Wnt pathway mutations, etc. I found this paper, what happens to patients who have these oligometastatic disease? Let's say you have a patient with 2 bone metastases and you do SBRT. What happens to them a year from now, 6 months from now? So this group looked at the pattern of metastasis, and if you had a bone met, the next event typically ends up being another bone disease. Similarly, if you have a nodal disease and that gets radiated, that patient has a very high chance of developing another nodal metastasis. So these are helpful for us when we are talking to the patient in front of us about what they can expect. There are multiple trials. I'm not going to go through each of this. It's just promising that we will have more data with larger number of patients, which will help guide this field. Finally, I'll just spend a few minutes talking about oligoprogressive disease. So these are patients who now have metastatic CRPC. They are on all of either ADT plus one of our ARPIs, and they are now progressing in just isolated sites. So this is a patient of mine, just to go over his case history. He's an older gentleman, has had a radical prostatectomy in 2003, and then gets biochemical recurrence. He's been treated with androgen deprivation therapy, develops metastatic CRPC, goes on to getting enzalutamide, was actually on enzalutamide. This was a patient who's been on it for the longest time in my experience, and ultimately had a rise in PSA. We did a PSMA scan for him, and he now has just pelvic lymph nodes alone. We sent him to our radiation oncologist. They radiated the pelvis, and you can see his PSA come down from 2.4 to 0.8. And we've been able to keep this patient on ADT and enzalutamide and not have to intensify his therapy with either docetaxel or even lutetium PSMA, right? So we were able to keep this patient on the same treatment. So what is the clinical evidence that we have that there is some benefit for these patients? The only randomized trial in this space is called the ARTO trial, where they took patients with CRPC and randomized them to either adding abiraterone, which is our first line choice, or doing ABI plus SBRT. And they did show, 5 minutes, right? They did show a benefit. We have 19 trials, all retrospective, again showing that there is some benefit in delaying the time to next therapy. The Stampede 2 is a trial that's ongoing, and I think this would be the definitive trial that's going to, thank you so much. that's going to give us an answer in the future about the role of SBRT for patients with oligometastatic disease. So I think I'm going to conclude that oligometastatic disease, especially in prostate, is such a heterogeneous state. We need better endpoints, and that has to be better defined. We need validation studies. I showed you all of the data that we have, and it's such small numbers. So having a category 1 recommendation at this time is very weak evidence, but it's certainly promising. I think today we select based on number of mets, right? That feels so archaic, right? It feels like we should be doing better. So I am really hopeful that in the future it will be based on biology and maybe genomic selection. And of course it has to be a shared decision making with the patient. So this is where we are today. We certainly take into consideration what the patient's PSA is. PSA doubling time is used a lot to determine, again, biology. Time to metastasis. All of these trials have excluded patients with liver metastasis. We look at Gleason score, we look at PSMA imaging, performance status. All of these are taken into consideration for that patient in front of us to determine if they would be appropriate for metastatic directed therapy. But I think where we are headed would be using the MMAI model, artificial intelligence, using individual biomarkers and patients' genomics to sort of personalize their care. Ultimately, in both, whether it's today or in the future, I think patients' goals are really important. You know, I think I've never met a single patient who has loved going on testosterone-lowering therapy. It's just the worst thing we can do for our patients, and I think the short-term as well as the long-term morbidity of testosterone-lowering agents cannot be undermined. So listening to the patient and what they want within what ability we can do, I think is a really important goal. And I think I'm going to stop there. And I think I finished ahead of time.
Thank you so much. Thank you. That's a wonderful presentation. I think you touched almost all the aspects. Any questions? Yeah.
I think it's an excellent overview. I mean, we couldn't have asked anything more than that. It's a very simplified done. There are two questions. The first scenario, what you showed, is a guy who has sort of, prostatic disease T2 or T3 with 3 metastases or 3 or 3 plus metastases. He gets either doublet therapy or triplet therapy plus sort of, primary treatment for the prostate. Is there a need of giving him metastatic directed therapy? The question comes to my mind is if he had his ADT, doublet or triplet therapy, it is going to take care of the metastasis itself. Because many times we have seen the PSMA PET scan or sort of, MRI, disappearance of this lesion. We are talking about non-visceral metastasis. So the question is whether we can give metastatic directed therapy in this patient, number one. And second thing, I'm sure you must have also seen in your practice, you get a lot of lutetium-based therapy, PSMA-based therapy, and some of the patients who have extensive metastasis, I think they really sort of do very well. So maybe I think they may have a place in patients who have even oligometastasis. So we may have to cut down on ADT and chemo, perhaps use those to avoid side effects and long-term complications.
I think you're bringing up a point that we just don't have the data. You know, this is completely uncharted territory as far as prostate cancer goes, where again, the use of PSMA PET imaging and how it's going to change the natural history, I think remains unknown. I think the hope is that for that patient who has PSMA-based detection, are we stupid to even mention the C word with a cure? And I think that's where the hope is, and we don't know the answer. So I think it's completely reasonable to just consider systemic therapy. That's why I put patient choice up there, because that really matters. And the hope is that by rather keeping patients on hormonal therapy endlessly, For this patient, I might consider stopping everything after 2 years. You know, if the PSA becomes undetectable, stop the ADT, stop Zytiga, and just see what the patient does.
Yeah, I have one question. Is there any role of ctDNA? Because it's an oligometastatic disease, and we want to know what's going to happen in future. What is the role of ctDNA in oligometastasis?
I mean, I don't know. I think ctDNA is done so well in urothelial cancer. It's hard to have something cheaper than PSA. Right? I think cost becomes a big issue, and ctDNA, I feel, is very experimental in prostate cancer compared to some of the other cancers that we have today.
I have one question, madam. This is Dr. Animesh Shah from Apollo, Kolkata. Excellent presentation, madam. So my question is about oligometastatic or low volume metastatic prostate cancer. So you have shown that in HORA trial, Stampede and StopCap, there is a benefit of adding local prostate directed therapy. And now with PEACE-1, with intensification of the systemic treatment, the benefit of RT is coming down. My first question is whether there is any difference in inclusion criteria of this group of trial, whether the metastasis detected therapy was given to the trial which showed benefit of RT, which showed no benefit of RT. Because that could be one of the game changer, because in any cancer, when we treat oligometastatic disease or low volume metastatic disease with curative intent, it is important to treat the metastatic site with ablative dose of radiation or surgery or any form of ablative local therapy. So this is important that we understand the difference between this trial, whether there is a difference in treating the metastatic directed therapy.
Thank you for that question. I think, you know, in PEACE-1 only addressed radiating the primary. None of the patients had metastatic directed therapy. So these are just separate questions. Is there a role for prostate radiation, you know, now that we have intensified therapy? I think that's the reason why they didn't show an overall survival, because our medical therapy is just so good. We can see that we are prolonging life, and the benefit of local therapy definitely has become less. The earlier trials that I showed you, the HORAD and the Stampede, were with single agent ADT. So it was just LHRH agonist alone, and we know today that that's inferior compared to our intensified treatment.
Thank you. Thank you so much. Can we have you on the stage for some time? We now proceed towards our next talk by Dr. Krishna Kumar Ratnam from Madurai. He would deliver a talk on the topic metastatic hormone-sensitive prostate cancer, choosing wisely. Over to you.
Thank you to the organizers, one and all. I am between you and your lunch. I promise to keep it short. And Dr. Sandy has made my job easy because she's run through most of what I have to talk. I was cutting short my slides and I was wondering if I would be too fast. But thank you, Dr. Sandy. I think it would be a recap of what she did because she's covered a part of my patients. So the topic given to me, choosing wisely. I didn't want to change the heading. In the end, I will say choosing wisely in India, okay? Because we're talking about data that's predominantly come from the West, and how are we going to extrapolate the same for our own patients? I think that's what this conference has to take home for most of us. So the outline of this talk would be mainly a touch on the burden that we are having and the available choices, the evidence-based medicine, which we cannot ignore, a real-world possibility in day-to-day practice, and we will conclude what I do in my practice. I don't have that kind of an experience, but that's all I have to say if I am called in as a speaker. So it's the second most common cancer in men in India, and definitely with boomeranging, you know, the incidence because of wider availability of imaging techniques. So I think we are diagnosing more and more prostate cancers mainly because of, the rampant health checkups and so many quick imagings which are available at the touch of a button. So yes, prostate cancer is on the rise, but what do we have from the Globocan and also from the smaller registry studies from across India is we do have a younger age of diagnosis, aggressive histology, more visceral metastasis. Are we looking at a lead time bias in the Western world because of early diagnosis, or are we looking at more locally advanced or a metastatic patient in India because of late diagnosis? Well, that depends on the kind of center in which we are practicing. A quick recap, we know that the word castrate or castration naive is for those who haven't received androgen depriving therapy, either at the time of diagnosis or progression. And the factors clearly which determine the kind of therapy is going to be first patient-centric. What does the patient want? Where does he stand? Including life expectancy, what was discussed earlier. Obviously, the disease factors, starting from the subgrade to the stage to the volume of disease, the evidence-based medicine which is applicable in our country, and not the least about ethical practices which prevail in most of our centers. So, the patient factors in a hormone-naive patient is going to revolve around the biological age of the patient. Please remember, age is just a number. You may have a 60-year-old bedbound and you may have an 80-year-old walk-in with full physical fitness. So it's the biological age of the patient, the comorbid conditions that he carries with him, the availability of resources in our practice at that particular center, the affordability factors for the patient, and the disease factors, what was beautifully shown to us, whether it is a de novo metastatic patient or a patient who has a metachronous disease, meaning the patient has already received treatment for the primary and now is progressing, these people do better. The site and the volume of the disease. So the most common, which I think each one of us, when we go back after this conference, should know, should be about the criteria with the charted and the latitude trials used, which are quite easily reproducible in our clinics today. And where did all this start? With Charles Higgins showing us that orchidectomy and availability of estrogen for patients with prostate cancer was able to bring in some longevity. For refractory patients, he said adrenalectomy can help. So I think this is where the thought for hormone treatment was sown long ago in the early 40s. And we haven't actually progressed much beyond that until 2015. And until now, in about 5-6 years, there has been a horrendous group of trials from across the world, whether it's the French or the British or from the United States, giving their evidence that something more than just orchidectomy can help patients. So, I think most of the urologists will agree. How many of us use bicalutamide in clinical practice? Bicalutamide, Indian urologists. I'm sorry, I'm having all of you behind me. Please I apologize for that. I think I'm showing my back to all of you. So I think most of the clinicians are using bicalutamide. If you go in, I think it is off all global guidelines. Forget the legal part, but at least for the medical part, it looks like we are using an outdated treatment, but including myself, we are using bicalutamide. And if you want to go back for evidence for a combined androgen blockade, still, I think right from my student days, it was debated and now it is forgotten. It doesn't mean we still have evidence, but most of us are using it. But now, since 2015 onwards, we had more therapy. It tends to tell us it is criminal if you are only going to use androgen-deprived deprivation therapy alone in certain groups of patients, which we'll be looking at shortly. So it's time for us to revamp our medical practices. So I will be briefly touching on what was the evidence and what do we take home today in India. So these are the doublets, and in addition, if you're going to use chemo and a hormone blockade, we call it triplet. So these are the variety of drugs that are thrown at us like a buffet. But what we really need to see is this going to translate to survival, leave alone the quality of life of some of the patients? The GETUK study was a negative study to start with, but we had two wonderful studies, the CHARTED and the STAMPEDE, which Dr. Sandy touched briefly on, and these clearly showed in the overall cohort that by adding docetaxel chemotherapy in the hormone-naive patient, improved survival. But in the subset analysis, this was mainly for the high volume disease or the more aggressive patients, not for the low volume disease. So this does take one take home point to your clinic, that when you have an aggressive looking disease with high volume or disease burden and the fit patient, docetaxel improves survival. And yes, when you go back to the STAMPEDE study, once again it's a multi-arm study, and these arms in most of these trials were adapted and were evolving as from 2015 onwards. There were many standard of cares that were coming up, so there were newer arms that were being enrolled, and that's the reason. And that also proved that docetaxel improves survival. And what about the androgen receptor blockades? Are they better than the conventional bicalutamide which we are using right now? Well, yes, we have the ENZAMET study which met its primary endpoint, and we were definitely able to show that enzalutamide is much better than most of the non-steroidal anti-androgen agents. Now, if a patient, in most of the studies, the first progression starts kicking in by 14 to 16 months, which means the patient has to spend about 3 lakh Indian rupees to get that progression-free survival. So if somebody is really not going to, it looks high risk but is not able to afford the newer androgen receptor blockade, you can add docetaxel, because in the previous trial, those who received docetaxel didn't seem to get the same benefit by addition of enzalutamide. So probably an addition of 50,000 rupees to the patient early on in the course of disease can produce the same kind of a overall survival later. This is what we can extrapolate for Indian practice. The ARCHES study was once again a study which showed very clearly that enzalutamide, in addition to androgen deprivation therapy, either medical or surgical, could prolong the survival without much safety concerns. Then came the apalutamide. The apalutamide, the TITAN study, showing clear survival benefit. That's why these all are there up in category 1 recommendation in the clinical trials. But if you gave docetaxel, were you able to get, that number is too small to come to any meaningful conclusion, but that subgroup did not once again derive benefit. What about abiraterone? We finished 2 common drugs that we have, the enzalutamide and the apalutamide. The abiraterone acetate, which is also quite a popular drug, just that it comes with a small dose of steroid, which we as physicians are worried. In patients, irrespective of disease burden, across all comers, abiraterone acetate after androgen deprivation seemed beneficial. Now, as a physician, a word of concern to all my colleagues and the urosurgeons, because we do get patients come in with sepsis, come in with electrolyte disturbances, hyperglycemia, diabetic ketoacidosis, and we have to remember that when we put a patient on a chronic steroid suppression, every time they get any form of infection, they need the adrenal to kick in. And when we are going to suppress them with prednisolone, they will have severe Addisonian crisis. At least in the last maybe about 17, 18 years, I've lost 2 patients who came in with severe Addisonian crisis and they could not be pulled out. And when we went back, they had stopped the prednisolone. The initial fission had stopped the prednisolone when the patient had gone into the ICU. So these are certain problems when you use abiraterone. So anybody before prescribing abiraterone in their clinic needs to be very careful, and it's better to keep the physician in your loop. Now, we are clear about one point, enzalutamide and abiraterone, at least in the high volume patient, docetaxel definitely in the high volume patients does produce survival benefit. In the castrate naive patient, is more merrier? Can we add one more? Can we give chemotherapy? Can we also add one of these androgen receptor blockers or abiraterone? Is it going to transform into survival? Yes, we had 2 studies which addressed this, and of course the PEACE also had an arm on that. The Arescence trial, which used docetaxel in both arms, and then when they added darolutamide, definitely, the PEACE trial, which also had 4 arms, and then the last arm which had the addition of both chemotherapy as well as adding one of the newer drugs, that was the abiraterone, both had the best survival benefit. So for whom are we really going to, in which context are we going to look at triplets in our practice in India? If you have a very young patient, very fit patient, but patient comes in with visceral metastasis and a fierce looking disease, and this patient you want to give the best, yes, you can consider androgen deprivation therapy, you can consider a short course of chemotherapy, you can consider putting him on either enzalutamide, or you can put him on darolutamide, or you can put him on even abiraterone acetate based on the available data that we have in our hand. So, castrate naive patient, hormone-sensitive prostate, metastatic prostate cancer. ADT alone is not enough. You can add one of these additional drugs. Now, what about treatment of the primary? Dr. Sandy spoke about oligometastatic disease. Now, I am talking about a low volume metastatic disease. You can treat. Dr. Sandy put up the HORAD trial and the other trials that were following, which showed that addition of RT to the primary did produce a survival benefit. So this has also got into our guidelines. So it's all about the biology of the disease. So if you think your patient is going to live long enough, addition of RT to the radiotherapy to the primary will bring down the lower urinary tract symptoms, will give better quality of life, and also improve survival, and you have some data for that. So after all this, if you're going to go back and look for your guidelines, you will be spoiled for choice, because everything seems to be category 1 recommendation. And as I told you, bicalutamide is already off, and all of us said we are using it in clinical practice. You go back to ESMO, once again, there is no bicalutamide, and you're once again spoiled for choice, and any of these you can use. So once again, it's very difficult for us to see what we are going to do. It's like a typical buffet menu, and you're looking, still searching for a strategic protocol. You feel like running away from all these things. So I think balance is the key. We have different people practicing in different settings. You may have to see a patient in a government hospital setup, you may have to see a patient in a community hospital, you can see patients in corporate hospitals. More is not necessarily merrier. Sometimes you may have to sequencing and giving more number of drugs over time may probably produce the same result as giving more in the initial setting. You have to look at quality of life and financial toxicity also. So this is something from real world. I was only able to consolidate these points as to what we practice in our institute as our institute-driven protocol. When we have a low burden disease and the patient is extremely fragile with a very low ECOG performance status, let us say he's ECOG 3, we just go only with androgen deprivation therapy, with or without bicalutamide, with due concerns over long-term testosterone deprivation. We'll have to look at all the, muscle mass and the coronaries and bone health and so many things. If a patient is an elderly but apparently is in good performance status, yes, we can go for androgen deprivation therapy. We add radiotherapy to the local tumor and add one of the androgen receptor blockers or abiraterone, depending on the comorbid states. If a patient is already a diabetic, if a patient is already a hypertensive, we tend to edge and move towards an androgen receptor newer blocker. If the patient otherwise is fit, we are very comfortable because physiologically it is better to expose the patient to abiraterone initially and then take over to the newer androgen receptor blockers due to upregulation of receptors at a later time. And we can add docetaxel if really fit and if really very young. But high burden, we don't have too much choice. If he is fragile, once again, the choices don't change, but the choices may change in the young, fit, aggressive, high volume, high burden disease, where we will go for androgen deprivation with docetaxel with one of the abiraterone or androgen receptor blockers. Right away, we don't go for triplets actually, but yes, if it's a very young patient, we can start the disease. So this is absolutely a clinical judgment based on the disease and the biology with which we are dealing. Definitely a tumor board is called for. It is better we work together. The physicians, we have our own points. The surgeons will have their own points. So when we work together, we will be able to do all these assessments of the biology and the lower urinary tract issues, and we may be able to give the best for the patient. So I think that's all I have for today, and if there are any questions, I can answer. I was not able to cut short beyond this. I'm sorry if I was a bit fast.
No, it was absolutely fine. Thank you for the wonderful talk. Any questions before we break for the lunch?
I think excellent. I mean, I think the essence, I think you have put in for a metastatic disease in the most simplistic fashion. I would like to add two things because it's an Indian contest. Orchiectomy has not featured in the Indian contest, but I can tell you in a clinical practice, when we talk about financial toxicity, you take any middle class or low middle class person who comes to you with a budget, we already feel that the prostate cancer has become an expensive cancer. See, you need a biopsy, which is costly. You need an MPMRI, it's very costly. PSMA PET scan is costly. The new drugs are costly. So when he has a limited budget, what we incorporate here is do orchidectomy rather than putting them on LHRH analogs or antagonists. That's a cost-saving number one. So that you can put in Indian contest. Second thing is, I'm glad you pointed out that we have to give abiraterone along with steroids. But now, I think, propagate this sort of an information. We have a group which is called as the Asia Australia Pacific Cancer Group, APACC, which we meet every couple of years, and we try and sort of look at the international guidelines and see what is useful for Asia Australia Pacific region. There is a paper which has come from Hong Kong which showed that a low dose abiraterone of something like 500 milligram without steroid given with a full meal or a fatty meal is as good as abiraterone plus steroids. A lot of people challenge that. So the guidelines which have come from Asia, Australia Pacific region, which are going to get published now, we are trying to support this, that don't use steroids in these patients for the obvious reasons you have said. So the modification I would say in Indian context, use orchiectomy as an option, which is not a bad option if the patients are unfit or patients who are not keen to have that kind of drugs. And also, rather than sort of using prednisolone, use abiraterone, because ultimately it's a budget what we are talking about. And lastly, if you look at the efficacy of orchiectomy versus LHRH analogs or antagonists, you look the castration level, I think you get it very quick and fast. So I think this is little to additional modification I would suggest. I would like to propagate each and everyone that low dose abiraterone without steroid is much better choice than having enzalutamide.
Now, prostate cancer, rightly said, is a very expensive disease. Once you have it, you know how is it. And also, adding one more point to your point, now there is also a concept of intermittent ADT, which has come in. We don't give the continuous ADT, and that's again cut shorting and quite helpful in a country like ours. In the medical college setting, we all practice orchidectomy. Still, we give an option to the patient, and everybody, most of them will opt for orchidectomy. And there are some smaller drugs also like ketoconazole. We still, bicalutamide I use in the little higher dose. Bicalutamide, it's not the 50 milligram, 150
Actually, I think using Hormone and using estrogen, and it's still there in clinical practice. I could not bring it up for want of time because it's off all guidelines, so I think it's more spoken of. Orchidectomy, most of us prefer because of cost issues, people default. They don't take 3 monthly GnRH or 6 monthly GnRH, and you don't know about the pharmacokinetics of the drug. You don't know how much they are absorbing. Are they really maintaining the castrate levels? So if you take over 2 years' time, orchidectomy by surgical method would work out much less expensive than giving them 3 monthly jabs.
I think the bioavailability, the castrate level is important, but I think it's a classical example. I mean, don't get me wrong in sort of what I'm saying here, statement here. We always get swayed by the international guidelines. I won't name the organization, but the organization many years ago said bilateral orchiectomy is a barbaric procedure. Right? Now, I sat on many panels on the guidelines. I'm on NCCN, AUA, EAU, Asian, Australian. Few years ago, this bilateral orchiectomy is also an option has come in the guidelines. Why? Because they have stopped reimbursing the injection cost to the surgeons.
It's an OP basis. It's not.
Yeah. So I think this is how many times you get swayed. So this is not a bad option.
So I think we are totally with you, and we are practicing that in most of
One
our
more point, Doctor, I wanted to tell you is that now the world is moving towards use of triple drugs. So again, coming back to India, I am really afraid, and very less patients we have instituted with ADT, blockade and docetaxel. I'm quite afraid. So I don't know how to go about. Maybe we need more molecular markers to really classify who needs the triple drug. But in any conference you go, people talk about triple.
No, I think
being
there
a
are 2
medical
points,
oncologist, I have not
ma'am,
used.
in that, there are 2 points. India, we lack robust clinical trials. And towards the end of therapy or failure, we don't have too many choices for our patient which come free of cost. So I think as a musician myself, I would like that song, Save the Best for Last. So I would keep saving something and to keep pulling the patient along rather than giving everything at him. There was a question when to address to Dr. Sandy. With her permission, I would like to answer. They were asking, with triplets which are being spoken of nowadays, do we need to irradiate all the oligometastatic? I think she's been very clear. She's talking about the low volume, low biology disease. We are looking at longevity. So irradiating the primary and irradiating the metastatic sites will improve not only quality of life but also survival. So I think we are not talking at those high volume patients where you're looking at typical triplets. Otherwise, I think doublets will still stand for the time till we reach that point.
I think triplet, we use it only for a high volume young patients. I think that's the best chance they have. But if you have sort of, elderly patients, low volume disease, as it was said, or sort of, patients who have sort of, oligometastasis, I mean, I don't think we need to have a triplet.
I think the other important factor which from the medical oncologist perspective is the toxicity of ADT. So many patients, when you call them or follow them, you get that patient suddenly died. So the cardiovascular morbidity is also have to be looked for. And our Indian population are at already risk of diabetic and all. We know that our population gets all these. So we have to be very careful in terms of the long-term complication of ADT. Yes, so that has to be, yes. So, and the second most common cause of death is the cardiovascular in metastatic patients. So and we are now getting a younger patient population much more than previously.
Geriatric scoring needs to be mandatory done for all these cases. Yes. Yes, thank you. We asked you too many questions.
Nee, thank you. Thank you so much. Sir, can we please be on the stage for a group picture before we break for lunch? Thank you, chairpersons. Jen, thank you, speaker. Thank you again. Requesting all the attendees to please come back sharp at 2 to restart the session. We are running late by an hour, so we'll try to fix some things by being here on time. So we meet here at 2 p.m. Thank you.
we give you a warm welcome to speak on the differentiations and variant histologies of bladder cancer. Dr. Gladel P. Panner. Can we have a round of applause? Welcome for him. He has been waiting for almost half an hour to present. Sir.
Good afternoon, and thank you for having me here. This is an awesome, an amazing conference. And I would like to take this opportunity to thank the organizers, with special thanks to Sambit, he's not here, and also to Rajal. And again, I'm honored to be here. So I was tasked to talk about divergent differentiations and subtype histologies of bladder cancer. And the interest in this area has been growing for the past decades. And now it reached into the clinical guidelines. And we have to focus on this, not only in the management side, but also in the pathologic diagnosis and importantly in the reporting. So this is the spectrum, and the word invasive that is underlined because this applies to invasive urothelial carcinoma. As we know, more than 90% of invasive urothelial carcinoma are the conventional or the usual type. And there's also the subtypes. Now we're calling them subtypes. Before we used to call them as variants, so we have to remove the word variants. Variants is a word that is associated with genomic alterations. So to be relatively specific, we're using subtypes for histologic subtypes. And what we mean by histologic subtypes are that these are urothelial carcinoma with non-conventional histologies. And there's also these divergent differentiations. These are histologies that are at other epithelial lineages that admix with urothelial carcinoma. For example, squamous cell carcinoma, adenocarcinoma, also trophoblastic or Mullerian. So this is the current list in the 2022 WHO Blue Book. At this point, we have 11 subtypes, and then we have 4 divergent differentiations. Of note, two of these subtypes were actually discovered and first described by Dr. Mahul Amin, who's we're honored to be here with us. These are the micropapillary and also the lymphoepithelioma-like carcinoma. So for important points about these entities, so the demographics, symptomatology is the same as conventional urothelial carcinoma, so we're not going to talk about it. What's important for the pathologist in the audience is number 2 and 3. So this can mimic other lesions and tumor in the primary and in the metastatic sites. And beware that the expression of IHC markers, like the usual markers for urothelia, like GATA3 and P63, can be lower in these tumors. Now for our clinicians in the audience, number 4 and 5 is important. This entity presents with higher stage, leading to its worst outcome. And then an important point here is that although we try to lump them together as subtype, this is biologically heterogeneous. We should not be lumping them together. So right now in the guidelines, we really have to specify which subtype it is that will correlate with the appropriate management. So 2 years ago, we conducted this study. It's a comprehensive review. We're kind of curious, so how does these subtypes behave when we match them with urothelial carcinoma, stage for stage, and with other clinical pathologic variables? We know that they behave worse. So these are the references that we covered. However, at this point, the data is still limited in some of these subtypes, like lymphoepithelioma-like, and some of the others listed down there. We still have no data. When we did the analysis, 3 of the subtypes were identified to have an inferior or likely inferior outcome when compared to conventional urothelial carcinoma stage for stage. And we have to keep in mind this variance because we have to report it. Sarcomatoid, micropapillary, and plasmacytoid. The rest there, squamous, glandular nested microcystic epithelioma-like, they have similar outcome to conventional urothelial carcinoma when they are matched. And these findings actually correlate what's currently in the guidelines, in the clinical guidelines. If you look at the AUA, the latest guidance on non-muscle invasive bladder cancer, it's highlighted there that micropapillary plasmacytoid sarcomatoid, if they are there, in T1 disease, this is an automatic in the risk stratification as very high-risk group. And we know that if it's a T1 high-risk group, radical cystectomy is a consideration. So this is how important the reporting of these entities at this point. It goes further than that. In the EAU ESMO, they did a consensus statement 4 years ago. And there's a consensus that if it is a T1 micropapillary, then it should be treated with immediate radical cystectomy. These are from the European guidelines. And how is it in So, for the purpose of discussion, so the way we can easily remember, absorb this, because there's a lot, this is the way I'm going to group them. So we have the known aggressive subtypes, the three that's already mentioned. There's also these other aggressive. We know that these are aggressive, giant cell and poorly differentiated, just that we don't have enough reports or series to support this. The maskers and mimickers. There's the divergent differentiation. So the next 10 minutes, I'm going to discuss this according to these 5 categories. So first, and this is mainly for pathologists, for the diagnosis, for this part. So for the aggressive, the first one is micropapillary urothelial carcinoma. It has these features, small tumor nest, extensive retraction artifacts. It can have nuclear pleomorphism. But what's important is that for consistency of diagnosis, we have to look for relatively more specific features. And these are the following: multiple nests in same lacunae, the presence of vacuoles and epithelial rings. And this is an interesting pattern, this polarized nuclei at the periphery, as you can see. If we have this, then we become more confident that, hey, we are looking at micropapillary carcinoma. We did an inter-observer study about 15 years ago, and this is the kind of the more reproducible features. Now, why I am bringing this up? This is very important because the differential diagnosis is invasive urothelial carcinoma with retraction artifacts. So we should not be overcalling this as micropapillary urothelial carcinoma. If this is a non-muscle invasive with retraction artifact overcalled as micropapillary, what will happen? We put the patient at risk for immediate radical cystectomy. So that's how this call is very important. The other is plasmacytoid urothelial carcinoma. Plasmacytoid, the name is really descriptive, right? So it looks like plasma cells. So they are these cohesive cells, eccentric nuclei. CD138, a marker for plasma cells, it can be positive. It's highly infiltrative, often extensive, and because of the spread, it can percolate within the bladder wall, making the bladder wall thicken, as you can see there, somewhat like rhinitis plastica in the stomach. If you look at the image there, you wouldn't see the infiltrates on low power magnification. But in fact, they're all over the place. If you do keratin, they are there in the wall. Now, having this discrete infiltrates of plasmacytoid, sometimes they are hard to see. And that can be a challenge in the TURBT samples. And also the fact that they're infiltrating in the wall, you might not see them on the surface. More problematic is if you're looking at the lymph nodes. Like, for example, if you see in this image, we might not be able to see them there, but they're actually there. I honestly couldn't see them with H&E, but if I did keratin, they're there. So that's how difficult to stage these tumors, but you will have a high suspicion of metastasis if you are dealing with this tumor that has a high stage on the primary organ or the bladder. Now, the third is sarcomatoid urothelial carcinoma. We know the more common pattern is that it's high-grade spindle cells, and that's basically sarcomatoid carcinoma, but it can also have malignant heterologous mesenchymal elements, like as shown here, it can have rhabdomyosarcoma. Now, for a long time now, the WHO Blue Book has been lumping this together under the umbrella term sarcomatoid urothelial carcinoma, because basically both have the same behavior. Now, in terms of, for pathologists, when we're making a diagnosis of this, so we have spindle cells, right? Be careful that the markers can be negative. The urothelial markers can be negative in this tumor. Now, one strategy to do is that look for the areas that are least spindled, because if you stain this with urothelial markers, that marker will selectively stain those that are kind of relatively epithelioid cells, like as you can see in this example, the P63. So the differential diagnosis of sarcomatoid, very important, is inflammatory myofibroblastic tumor. They usually have long cells, stellate cells with mixed inflammatory cells. ALK can be helpful. So this is benign. This is a benign tumor, so obviously the management is different. So distinction is very important. Leiomyosarcoma is also a malignancy, but again, the management is different, and this can be positive with smooth muscle markers. So the next category is that we know that these two are aggressive, giant cells and poorly differentiated, except that, we only have scattered reports on this tumor. But morphologic, and in my opinion, it should be lumped together with those three in terms of the management. So giant cell urothelial carcinoma, these have sheets or individual undifferentiated pleomorphic cells, but often they are admixed with conventional urothelial carcinoma, as you can see with that image to the right. And this can be positive with urothelial markers. The fifth tumor is the poorly differentiated urothelial carcinoma. It has this one example is, one entity under this is the poorly differentiated urothelial carcinoma with osteoclast-like giant cells, which has this unique morphology. So it has this solid growth of mononuclear cells with mild atypia in the background, and those cells actually are urothelial lineage. And then you have this multinucleated giant cells, which are basically histiocytic in nature. So if you do stains on this tumor, very unique morphology, the background will pick up the urothelial markers, like GATA3 in this example, whereas the giant cells will pick up the stains for histiocytes, as CD68 in this example. Now let's go to the deceptively bland tumors, and there are 4 in this category: nested, microcystic, tubular, and large nested. We use the word bland, meaning the features for malignancy, cytomorphologic features are not there, so they are benign appearing deceptively. And under this category, we have 4, as I mentioned. So they have low-grade appearing nuclei, despite the fact that they are aggressive or invasive, and they can mimic benign and low-grade lesions in the bladder. So if we think about nested urothelial carcinoma, it can mimic Brun's nest superficially. Microcystic can mimic cystitis cystica. Tubular can mimic nephrogenic adenoma, and large nested can mimic inverted low-grade papillary urothelial carcinoma. Having this differential diagnosis of things that we usually see in the bladder, if we have a superficial specimen, we can encounter this difficulty. At this point, as already mentioned earlier, the management will be the same as conventional urothelial carcinoma. So let's start first with nested urothelial carcinoma. As already mentioned, it resembles Brun's nest on the surface, but in addition, it may also show some irregular nest, some fusion of this urothelial nest. And most of this presents with higher stage disease. So this will have a mass lesion and cystoscopy. So this is how important the clinical and pathological correlation is, right? Like if the cystoscopic report describes a large mass and we're reporting it as Brun's nest, so there's some problem there, right? So communication is very important in this regard. Look at the cytology, cytomorphology. They are bland looking, very low grade, in fact, almost looking like benign. But in this case, if you look at the tumors have infiltrated the lamina propria, and you can see it's already muscle invasive. So most of these presents with high stage. Now, how do we handle this in the practice? So if there's a mass lesion, there will be a TURBT, right? And for our urologists here in the group, if you have a mass lesion, you always have to go for the deep muscle, right? In my institution, what we do is we submit what we call the deep bite in a separate container. We expect muscle to be there. And if we have Brun's nest in the muscularis propria, then it shouldn't be Brun's nest, right? Think about the nested urothelial carcinoma. Now, there are some subtle morphological variation that we can appreciate. Like, for example, in nested urothelial carcinoma, the nests are usually smaller. They can be complex, meaning that they can fuse a little bit, irregular, and then, as I mentioned, confluence. The atypia can be greater going deep, but this is going to be a problem if we have a superficial specimen. The key here is muscularis propria involvement. So that's really what would make us to confidently diagnose this. Some suggested third promoter mutation, which can be seen in urothelial carcinoma and not in Brun's nest, although I personally have not experienced that because I have not ordered this for this scenario. For the Brun's nest, they are usually larger, but they can also go deep into the lamina propria. We have to keep that in mind. They have smooth, round contour, but not always. What's helpful for me is that when they have the cystitis glandularis, especially if they have this well-differentiated intestinal metaplasia admixed with them, to me that's really helpful. Now there are other types within this categories. One is a microcystic urothelial carcinoma. So in this case, the tumor will resemble cystitis cystica on the surface, and the diagnostic approach will be similar as in the nested subtype. Another image here, images of microcystic urothelial carcinoma. You can see how the nuclei are low grade, and you can see how infiltrative it is into the muscular wall. Now, tubular urothelial carcinoma, again, it have these tubular formations, and it kind of mimic nephrogenic adenoma in some areas, and it has a bland appearance. And if we stain this with PAX8, they should be negative. Now, there are now reports of tubular urothelial carcinoma that are PAX8 positive, and I think the Hopkins group have reported that, and they're calling it as urothelial carcinoma with Wolffian differentiation. So that's another different divergent differentiation on the horizon. Another images of tubular urothelial carcinoma, you can see how florid the tubule formation are infiltrating into the lamina propria, deep into the lamina propria and into the muscle. Now, the final entity in this group is the large nested urothelial carcinoma. It has this infiltrative large nest of cells with broad pushing border, verrucous-like, and often connected in the surface. But most of these have surface papillary component. Now, majority of this are 90% are muscle invasive. And if you look at the morphology here, the main differential diagnosis of this entity, and I'm going to talk about it later in the case discussion, is inverted papillary urothelial carcinoma. Now, this more than 90% presentation as muscle invasive may be because we have a bias here, because the way we can only identify that it is large nested is when it goes to the muscle, because that's almost kind of a clue that we are dealing with a large nested urothelial carcinoma. So the fourth category, I just created a name just to put them in a category together. I call them maskers and mimickers. So these are the lymphoepithelioma-like, lipid-rich, clear cell or glycogen-rich. So they have morphologic resemblance to other tumors or lesions, like the lymphoepithelioma-like would resemble chronic cystitis. Lipid-rich, it has some cells that can mimic a lipoblast. Clear cell obviously mimics clear cell renal cell carcinoma. So again, this is for just pathologists to remember that, of this mimicry. But from the clinical side, the management of these subtypes is similar to conventional urothelial carcinoma. So lymphoepithelioma-like urothelial carcinoma, it has this syncytium of high-grade undifferentiated cells, and it's in a dense background of dense lymphoplasmacytic infiltrates. So it's called lymphoepithelioma-like because of the lymphoepithelioma in the upper respiratory tract. Unlike in the upper respiratory tract tumor, this is not EBV associated. Now, interesting is that if we review the literature on this, it seems like the pure lymphoepithelioma-like the pure or extensive lymphoepithelioma-like have better survival, better outcome, or behave better than those with a smaller fraction of lymphoepithelioma-like. So this is kind of opposite to the rest of the subtypes. And an interesting finding, this is one of the preliminary findings of the Pure 01 study. This is a study on Pembro, that among the subtypes tested, lymphoepithelioma-like have good response to immune checkpoint inhibitor. And likely the reason for this is because, as we can see, lymphoepithelioma-like is rich with these immune cells. So maybe it's responsible for this good response. Now, in terms of the morphology, you can see that it's really, the infiltrate is masking the presence of carcinoma. So the carcinomas are those cells. I need a point. So the carcinoma cells, it's invisible. Anyway, so the carcinoma cells that are in the middle, they look like, all right, there you go. This is more powerful. Right, there you go. So the carcinoma cells, in this case, they look like germinal centers, but these are basically syncytium of malignant cells or carcinoma, as also as here. And you can see here, like it looks like basically a dense infiltrates, lymphoplasmacytic infiltrates mimicking chronic cystitis. If we look at this side of the image, it looks like a large follicular cystitis. You have a germinal center there, and maybe another germinal center there. But if you throw in keratin, it's actually carcinoma infiltrates. If you look at this image right here, we made mistake, oh, this is clusters of histiocytes amidst this lymphoplasmacytic infiltrates. But if you stain it with keratin, the carcinoma cells are all over the place. So this is a pitfall in making a diagnosis of carcinoma, lymphoepithelioma, like something you have to keep in mind. Now, GATA3 is usually stained poorly in these tumors. P63 is better. Now, clear cell urothelial carcinoma, as the name implies, it resembles clear cell renal cell carcinoma minus that chicken wire vasculature that we see in clear cell RCC. Obviously, this will be PAX8 negative, and it will be GATA3 positive because it's urothelial. The reason for this clearing is glycogen, so it's BSD positive, and as already mentioned, it's positive for urothelial markers. And finally, lipid-rich urothelial carcinoma, so it has these cells with multiple vacuolations, with indentation of the vacuoles of the nucleus, so that it would resemble as lipoblasts. It can be seen throughout the tumor. Interestingly, when this presents, it usually presents admixed with conventional urothelial carcinoma. And this is usually a minor component, usually less than 50% of the tumor as lipoid. And PM confirmed that this vacuole is because of the lipid content. And finally, we'll talk about urothelial carcinoma with divergent differentiation. Now, in the WHO Blue Book, it listed the squamous, glandular, Mullerian, and tropoblastic. So at this point, the management is similar to conventional urothelial carcinoma. So in terms of distinction, it's not that critically as important when distinguishing these two, for example, with conventional urothelial carcinoma versus differentiating them from pure squamous cell carcinoma or pure adenocarcinoma. And the reason for that is twofold. So one is that studies have shown, or there's no data that there's a benefit in neoadjuvant chemo for this pure squamous cell or pure adenocarcinoma. But for the other two, it has, and thus it can be managed like conventional urothelial carcinoma. Also molecularly, studies have shown that urothelial carcinoma with glandular differentiation is closer actually to conventional urothelial carcinoma. So it's like high mutational burden, it has the third mutation, whereas the pure adenocarcinoma is actually closer, interestingly, to colonic adenocarcinoma. It has this pathogenic mutation in KRAS, SMAD4, MYC. So distinction is more important in terms of it is pure squamous cell, pure adenocarcinoma, or it's a part of urothelial carcinoma as a glandular or squamous differentiation. So how do we make a diagnosis as a pathologist? So if we see an adenocarcinoma component in the tumor, go to the surface, that's one. Look for urothelial carcinoma in situ or an exophytic papillary urothelial carcinoma or admixed invasive urothelial carcinoma component. Diagnosis is basically morphological. If you want to do stains, you can do P63 will stain a little bit that urothelial carcinoma component, but CDX2 will highlight the adenocarcinoma component. Although the use of the stains is still questionable at this point, it is really consistent. Now, we had this consensus conference 2 years ago in Dublin. We covered glandular neoplasm of the bladder, and because of this molecular difference and then the difference in management between pure adenocarcinoma and mixed urothelial and adenocarcinoma, we agreed to distinguish these two by terminologies. That the word adenocarcinoma is recommended to be used only for pure cases of adeno. And if we have a mixed urothelial and adenocarcinoma, call that as urothelial carcinoma with glandular differentiation. Avoid the word adenocarcinoma. The reason for that is to minimize the complications or a mistake that the clinicians are dealing with a pure adenocarcinoma case. So the next is urothelial carcinoma with squamous differentiation. The diagnosis approach is similar as in glandular differentiation. Look for surface or invasive urothelial carcinoma. At this point, there's no reliable marker to distinguish between urothelial carcinoma with squamous differentiation and pure squamous cell carcinoma. Urothelial carcinoma with trophoblastic differentiations, very interesting. These patients may have elevated beta HCG. And there are also rare reports, I think in the Cleveland Clinic, of choriocarcinoma primary in the bladder. Now, in terms of the trophoblastic differentiation, what is the trophoblastic component? It's actually the presence of their syncytial trophoblasts. These are these large multinucleated cells. And interestingly, when they are mixing with urothelial carcinoma, they're also kind of tapping the urothelial carcinoma, the same as the relationship between cytotrophoblast and syncytial trophoblasts in choriocarcinoma or in the placenta. And of course, this will be beta HCG positive. The staining can be messy, but it's usually more intense in the syncytial trophoblastic cells. Now, what's the problem with this at this point? The problem is our detection rate is poor in the TUR specimens. This is a large study from Europe involving 24 institutions. This is retrospective in design, and the agreement varies from slight and then to good agreement. The problem is that the carcinoma that we are most concerned, for example, micropapillary, it has the least agreement. And that's the problem with this. So what are the causes for this? So it could be tumor heterogeneity, it could be sampling, it could be innate to the tumor itself or the way it was sampled. But there's also this under-recognition. And there's also this under-reporting. Under-reporting is that we know what it is, but we don't put it in the report, and the reason for that is because 5-10 years ago, we don't really care if we put it in the report or not because it has no clinical meaning. But now it does have clinical meaning, so we must report it. Now, in response to this issue, our society, GOPS, put out this paper 3 years ago, and now it is required to report the presence of divergent differentiation or variant morphology, and also as it's in percent. And also, there's a need to correlate the morphology of the variants in the TUR and also the cystectomy specimen. Our sister society also put out this paper, which has the same recommendation from GUPS, but in addition, it also states that in terms of the diagnosis, there's no percent cutoff that is required for the diagnosis of subtypes. The reason for that is that because the cutoff is not uniform in the previous studies that were done. And then in terms of grading, all of them are automatically high grade. And as I mentioned at the very beginning of the talk, we should not be considering this as a homogeneous group in terms of behavior. So that when it comes to management, we have to be specific which subtype, and also in future, in research, in AI, we should be sorting this out, not lumping them together as quote-unquote subtype or quote-unquote divergent differentiation. So as a response in the US, we put the reporting of these variants as well as their percent in the bladder cancer protocol. This was already discussed earlier, so I'm not going to go into the molecular subtypes. I just want to mention here that there's correlation of the subtypes. Some of the subtypes with the molecular subtypes, like micropapillary, for example, correlates with the luminal, non-specified, and squamous, of course, correlates with the basal squamous. Further than this table, sarcomatoid also correlates with the basal squamous morphology. And we are not done yet with subtypes and divergent differentiation, so there are others that are still not incorporated, like the chordoid and the myxoid features, the pseudoangiosarcomatous, the rhabdoid. You know, some of the rhabdoid we thought that are plasmacytoid, but I personally believe that the true rhabdoid exists in rhabdoid uterine carcinoma exists in the bladder. And then there's also this walk-in differentiations I alluded to earlier, and just two images here, the myxoid stroma, and then the pseudoangiosarcomatous uterine carcinoma. And that's my last slide.
Thank you so much, Dr. Panner. A big round of applause.
Thank you. A couple of questions. Yeah, any questions from the audience? Yes, Dr. Subhashis. Your mic is not working.
Presentation, sir. Sir, in a TURBT specimen, sometimes we confuse that the papillary architecture with the micropapillary pattern, which has a characteristic appearance and characteristic morphology as described in some literatures. Even Dr. Ankur has mentioned some ISC markers for this micropapillary carcinoma. Any take on this?
So regarding the use of IHC, no, for me, no. Personally, I have no experience in using IHC marker in the distinction of any of this. Like, to me, the distinction at this point is pure morphologic. I don't know if I'm getting that question.
Yes, that's the question, because this micropapillary carcinoma has very poor prognosis, and it's amenable to immediate cystectomy as per the management. So if we are sometimes having confusion with that, whether it is a papillary high-grade urothelial carcinoma or a sort of micropapillary carcinoma existing with that, that's the question.
Oh, okay. So there's a papillary in the surface, and then, I'm sorry, I'm not.
I think the surface micropapillary is not considered to be micropapillary. It has to be invasive to call it micropapillary. You are talking about surface micropapillary.
No, this.
Surface micropapillary is not to be considered as a micropapillary. It has to be invasive. These all belong to invasive.
No, some nests are also in this lamina propria.
Let me just comment on that, because in the very first slide that I had, I underlined the word invasive, because the variants, the subtypes should be only made through the invasive uterine carcinoma. If we're looking at the surface, there are reports of surface non-invasive micropapillary uterine carcinoma. We tried to avoid making that diagnosis because of the implication, the clinical implication. It can be mistaken as a non-muscle invasive micropapillary that can be
any strict morphological criteria for this micropapillary carcinoma? Any strict morphological criteria?
Yes. As far as from my experience, I use strictly morphology. Some other experts can comment. But for me, I'm just using strict morphologic criteria.
Yes, Dr. Mehra.
Nice talk as usual, Gladel. And so I agree with your comment on the use of TERT promoter mutation. I think we need to be careful. I think we have seen and actually published cases of TERT promoter mutation in actually the so-called benign proliferative cystitis like lesions, including the polypoid, von Brunnes as well, especially from patients with neurogenic bladder. So I think, like you mentioned, I think caution is very important. The question I had was, in our center at least, the lymphoepithelioma like tumors, what we have come across, actually the majority of them have not had a good prognosis. And I mean, and there are reports in literature that they might actually have, some predilection for a better response. Our urologists, medical oncologists, me,
Yeah, so most of these studies actually, at the initial studies, as you said, not only in terms of the percent, but overall, lymphoepithelioma like carcinoma at the beginning was suggested to be the opposite. It has a better survival or outcome than conventional urothelial carcinoma. But as you said, the subsequent studies are kind of contradicting that. So at this point, it's conflicting, as I would say, and I don't have the definite answer. So obviously, we need a larger series to determine that.
Exactly.
But what's interesting, though, is as I showed, this is a very latest data, is from the Pure 01 study. It actually has a good response. They have only 4 cases of, in that study of lymphoepithelioma-like, and 3 of those cases, after treated with Pembro, they became T0 disease, which is a very interesting finding. So,
a lot of PD-L1. Therefore, they are amenable to the immune checkpoint blocker, but as such, they have a little dismal prognosis than the usual.
I think for the want of time, we would move on. Thank you.
May I?
Sure.
Yeah, Gladel, nice talk as always. So my question is regarding what's your experience of tubular carcinoma bladder and regarding the Paxate positivity. If they show Paxate, how do we differentiate them from tubular adenoma, especially if we don't have a big mass lesion?
yeah, so it's interesting. So you brought out this Pax8. So there's a series published in Modern Pathology, I think a year ago, urothelial carcinoma with Wolffian differentiation.
Yeah.
We published separately this Wolffian adenocarcinoma in the urethra, but what we believe is that that's a bona fide Wolffian duct-derived. But the one that they're suggesting is that it's urothelial carcinoma undergoing this differentiation into the Wolffian route. And that's basically look like those tubules, but it's definitely Pax8 positive. I saw some cases, it's definitely Pax8 positive. So I would accept that because morphologically, some of the tubules actually look, but we have to be careful, as Roy said, because we should not be basing, right?
It can be very difficult. So one is metaplasia, other one is invasive CA,
yeah,
right?
so we have some criteria to call it as a Wolffian adenocarcinoma, right? Bland cytology, thyroid-like kind of follicles with colloid in the middle, those two.
So yeah, we also published, actually on the nested variant, I think you also alluded to that. I think 50% of those were positive for Paxate, no relationship to TERT promoter mutations, at least in our study, and I believe the Paxate positivity is a cell of origin phenomena, but there are parallel reports coming out like possible Wolffian differentiation. I don't know if there's a way to tell them apart, but we have seen benign urothelium to be Paxate positive, and so I believe there is a missing link over there. Thank you.
Thank you so much. I think the chairperson is also requesting to let us move. Dr. Panner, I would request you to also have a seat over here so that after the next talk, we will have a group photograph. I would like to invite Dr. Andreas M. Acosta for the next talk. He will be talking on germ cell tumor of the testis, diagnosis. That you do not want to miss. So a big round of applause for Dr. Acosta.
Good afternoon, everyone. Well, before I start, I'd like to thank the organizing committee of this wonderful meeting for inviting me to be part of it. I'm really glad to be here with you today. And in this presentation, I will go over 4 entities that you don't want to miss in testicular pathology and explain why you don't want to miss them. I will start each part of my talk by presenting an illustrative case, followed by a brief discussion of the entity itself, and then just a brief explanation of why it's important not to miss it. I have no disclosures. And our first entity, can we turn down the lights a bit? Yes. Thank you so much. Our first entity is an aggressive and systemic treatment-resistant phenotype of germ cell tumor. And our illustrative case is a console radical orchiectomy of a 40-year-old man with a 3.5 centimeter testicular tumor that was diagnosed at the outside institution as postpubertal type teratoma. And when we received the consult, we did not have any information on serum markers. And here you can see a low magnification micrograph of a representative section of the tumor, where you have components of teratoma on the right side of this red line, and this distinct expansile nodule on the left that measured more than 5 millimeters. And at higher magnification, you can see that this nodule had a biphasic histology characterized by the presence of tubules lined by low columnar to cuboidal epithelium and stroma that contain mostly round to spindle cells. And you can see probably better in this picture on the lower right. Thank you very much for the lights. And the tubular component was diffusely positive for keratins, and it also co-expressed WT1 and PAX8. So this was consistent with a so-called somatic type nephroblastoma, in this case associated with a postpubertal type teratoma. And the interesting thing about this case is that this somatic malignancy was presenting in a primary testicular tumor, whereas, as you may know, this phenomenon is most commonly seen in metastatic sites, especially after chemotherapy. But it's also been well described in primary tumors, and in fact here I'm going to show you another example of a primary testicular tumor, and you can tell it's a primary tumor by the presence of residual testicular parenchyma there. And then again, the red line is separating a component of teratoma with cartilaginous differentiation from this component that has neuroectodermal and glial differentiation with a distinct nodule that at higher magnification on the right is composed of diffuse sheets of small round blue cells that in areas they form pseudo-rosettes, and they diffusely express OX2 with focal expression of synaptophysin. So this is consistent with what we now know as embryonic type neuroectodermal tumor, and in the past we used to call PNET. And here you can see yet another example of a primary testicular tumor with a somatic type malignancy. You can tell it's a primary testicular tumor because you have a residual epididymis there. And the somatic type malignancy is here on the lower right. And it's composed of short fascicles of spindle cells. The lesion is very cellular, as you can tell. There were areas of necrosis. It was mitotically active. And it was diffusely positive for Desmin and also focally positive for MyoD1. So this is consistent with a component of somatic type rhabdomyosarcoma arising again in a primary tumor. And somatic type malignancies of germ cell tumor origin are currently defined in the WHO classification as teratomas with somatic type malignancy. And as we will see later on, this is probably it's probably an inappropriate term. And they are literally defined in the Blue Book as a teratoma that develops a distinct component that resembles a somatic type malignant neoplasm. But there's also a size criterion because the focus with somatic type histology has to measure at least 5 millimeters or span at least one low power field. And what's interesting clinically about somatic type malignancies is that they seem to have a very different clinical significance when they are present in primary tumors than when they are present in metastasis, especially after chemotherapy. That has been shown at least in 2 studies, and in fact, in the one from MD Anderson that you can see here on the left, you can see that the 5-year survival for patients that have somatic type malignancies in a primary clinical stage 1 tumor is 87%. And that's comparable to the 5-year survival that you see in stage match patients with non-seminomas, Whereas if you find the somatic type malignancy in a metastasis, especially after chemotherapy, the 5-year survival falls to 35%, and that is significantly lower than we would expect for stage-matched patients with non-seminoma. Other factors that negatively impact survival outcome in patients with metastatic somatic type malignancies is the presence of these components in redo RPLNDs, that is, re-resection of residual retroperitoneal masses or recurrences in the retroperitoneum that need to be re-resected, and their occurrence as late relapses as opposed to their occurrence within the first 2 years after chemotherapy. So recently the question has arisen of whether the somatic type malignancies are truly a somatic type neoplasm, and I think this is a very valid question because initially when these tumors were described, they were thought to arise in components of teratoma that acquired genomic alterations that were equivalent to those that we see in their true somatic counterparts. But molecular studies have shown that this is actually not the case in the somatic type malignancies that arise in germ cell tumors. For example, this study with fluorescence in situ hybridization for EWSR1 rearrangements in what we now call embryonic type neuroectodermal tumors demonstrated that they don't have the EWSR1 rearrangement that you would expect to see in Ewing sarcomas with similar phenotype. And studies that were performed in the era of next generation sequencing, in fact, have shown that the overwhelming majority of pathogenic mutations are shared both by the conventional and the somatic type components of these tumors, and so are the copy number changes that we see in the somatic type malignancies. And moreover, several studies have demonstrated that somatic type malignancies arising in germ cell tumors retain the hallmark finding of germ cell tumors, which is the presence of an isochromosome 12p or events consistent with 12p duplication or gains of regions of the short arm of chromosome 12. And this study performed in multiple hematologic malignancies arising from individual primary mediastinal germ cell tumors demonstrated that all these somatic type hematologic malignancies can be traced back to a single clone in the primary mediastinal tumor. And moreover, analysis of the mutational and copy number profile of these hematologic type malignancies arising in germ cell tumors shows that they are significantly more similar to the germ cell tumors they arise from than to their true somatic counterparts. We do know, however, that somatic type malignancies show enrichment for some genomic variants, in particular for KRAS mutations, for KMT2D alterations, and also for alterations of the TP53 pathway, mostly as P53 mutations or as MDM2 amplifications, and these are very rare in primary chemo-naive tumors. So that is something that is enriched in somatic type malignancies. However, when we looked at pair samples, we see that these mutations are typically shared by the conventional and the somatic type components of the same tumor, and therefore they are unlikely to be the driver of the phenotypic switch that we see. But we have, in contrast, we have seen that the methylation profile of the genome of these somatic type malignancies can distinguish them from conventional phenotypes of germ cell tumor, and therefore we now believe that this phenotypic switch is mostly driven by epigenomic changes. And in fact, in a recent study, we have found that these epigenomic changes can be seen in foci that have somatic type histology but don't meet size criteria for somatic type malignancy, and therefore these foci likely represent the precursors of full-blown somatic type malignancies. And it was recognized several years ago by groups led by Tom Albright that at least some somatic type malignancies probably don't derive from teratoma. And this data was from the observation of post-chemotherapy sarcomatoid and glandular tumors, because they realized that some of these tumors had a prior history of yolk sac tumor, a prior history of significantly elevated AFP, and some of them, of course, express some of the markers that we see in yolk sac tumor. And interestingly, this theory was in part corroborated by a recent very beautiful study by Felix Bremer's group that used proteomic profiling, showing that the proteomic profiles of ENTs and carcinomas are more similar to those of yolk sac tumor than to those of teratoma, and the opposite is true for the proteomic profile of sarcomas. And also using genomic methylation profiling, they demonstrated that the methylation profile of rhabdomyosarcomas is more similar to that of teratomas than to that of yolk sac tumor, whereas the opposite is true for carcinomas. And more recently, we've used analysis of microRNAs of the 371, 373 cluster to analyze these somatic type malignancies. And as you may know, this mRNA cluster is a very sensitive and specific marker for GCNIS-derived germ cell tumors other than teratoma, meaning that it's positive in all phenotypes of GCNIS-derived germ cell tumors except teratoma. And when we looked at the expression of these microRNAs in somatic type malignancies, as you can see on the left, we saw that sarcoma to yolk sac tumors, carcinomas, and some individual examples of ENT showed significant expression of these microRNAs, again arguing that some of them are more similar to non-teratoma than to teratomas. So there are two things that we know quite well right now. One is that these somatic type malignancies are not equivalent to their true somatic counterparts in terms of their biology and in terms of their genomic alterations. And the second thing that we know quite well right now is that there's probably a subset of them that don't derive from teratoma. And therefore, we have proposed an alternative classification that highlights the germ cell origin of these tumors. So going back to the question of why it's important not to miss the diagnosis of a somatic type malignancy of germ cell tumor origin, well, the answer depends on whether it is present in a metastasis or in a primary tumor. So in a metastasis, it's important not to miss it because we know this portends a poor prognosis and it's associated with chemoresistance, and therefore the presence of these components justifies a very aggressive surgical approach trying to excise all the disease with clean margins. And in some centers, they will use histology-tailored chemotherapy, not with the intent of curing the patient, but with the intent of shrinking the masses so that they can be completely resected. And in primary tumors, it's also important not to miss the presence of these components because at least in our center, they will likely perform an upfront RPLND if there is a somatic type malignancy in a clinical stage 1 testicular germ cell tumor. And the rationale for this is that we know that these tumors are chemoresistant, and therefore an upfront RPLND may resect subclinical metastases that we know are not going to respond to chemotherapy. The second entity that you don't want to miss is a clinically indolent phenotype of trophoblastic tumor. And our illustrative case is a 25-year-old man with a history of advanced stage testicular mixed germ cell tumor that in the testis was predominantly embryonal carcinoma with components of teratoma yolk sac tumor as well. And the patient is status post orchiectomy and 4 cycles of bleomycin etoposide cisplatin and an RPLND and partial hepatectomy for residual masses after chemotherapy. And now he is presenting with a bulky retroperitoneal recurrence. So here I'm showing a low magnification micrograph of the tumor that was resected from the retroperitoneum. And again, the line is separating 2 areas. The area on top consisted of large cysts that contained areas with stratified epithelium, including some areas with ciliated cells, and it was easily identifiable as a component of teratoma. Whereas the component that you see on the lower part of the picture was characterized by these multifocal small to intermediate sized cysts that contain eosinophilic secretions, and this epithelium that was focally stratified and contained these polygonal large cells with a very prominent dark nuclei that in some areas it kind of resembled urothelium. Here at higher magnification, you can see that there are nests and individual cells with similar characteristics around the cysts. And here you can see the tumor at even higher magnification that shows the cytomorphology well, showing this large polygonal cells with eosinophilic to clear vacuolated cytoplasm, large dark nuclei, some multinucleate cells that likely correspond to components of syncytial trophoblast, and you can appreciate that there's abundant eosinophilic fibrinoid material between the cells and also some eosinophilic intracytoplasmic globular inclusions there. We did a Ki-67, and this tumor showed a low proliferation rate, and of course it was diffusely positive for GATA3, and it was also positive for HCG, mostly in the multinucleate cells. So this is a classical example of a cystic trophoblastic tumor associated with teratoma. So cystic trophoblastic tumor is an indolent phenotype of trophoblastic tumors that we see are arising from germ cell tumors that we see typically in the post-chemotherapy setting. And as you can see in these two tables, it has significant difference with choriocarcinoma. It is always cystic and always associated with teratoma, usually well circumscribed. Immunoreactivity for HCG is typically limited, mostly to the multinucleate cells. And unlike teratoma, it typically has abundant fibrinoid changes. It doesn't have necrosis. It doesn't have areas of hemorrhage. Post-chemotherapy setting, we interpret these tumors to actually represent part of a spectrum of maturational changes that we see in choriocarcinoma. With one end of the spectrum showing tumors like this, which are very cellular, monophasic, may have necrosis, typically have significant mitotic activity, and are typically associated with significantly elevated HCG levels in the serum that we would call monophasic choriocarcinomas, to some other tumors in the middle of the spectrum that look like this, with large nests of large epithelioid cells with pink, bright cytoplasm, and even some cells that look squamoid. Again, look at the inclusions in some of them. In the literature, these tumors have been called epithelioid trophoblastic tumors. I don't like that term because I think they are very different from the true epithelioid trophoblastic tumors that are gestational, so I just call them unclassified trophoblastic tumor. But again, part of the spectrum of maturational changes after chemotherapy, and in the other end of the spectrum, we have tumors such as the one that I've shown, cystic trophoblastic tumor. So why is it important not to miss a diagnosis of cystic trophoblastic tumor, or more specifically, why is it important to not confuse cystic trophoblastic tumor with other more aggressive types of trophoblastic tumors? Well, in metastasis, because we know they behave as teratomas, and therefore they should be considered equivalent to teratoma, meaning that if they are completely resected, no additional chemo is needed. Whereas if you call it choriocarcinoma or even unclassified trophoblastic tumor, the patient may receive additional chemotherapy that they don't need. And in this context, sometimes, at least for our clinicians, it's useful to provide information on the proliferative index. So we tend to do a Ki-67. And in primary tumors, it's also important not to confuse cystic trophoblastic tumor with more aggressive phenotypes, because in some centers, they will use the presence of choriocarcinoma or other more aggressive trophoblastic tumors to decide on adjuvant treatment, which of course a patient with cystic trophoblastic tumor does not need. The third entity that you don't want to miss is a clinically malignant subtype of sex-core stromal tumor. And the illustrative case is a console radical orchiectomy of a 22-year-old man. Actually, the patient was from India with a 3.4 centimeter testicular tumor, and all serum markers were negative. And here you can see a low magnification micrograph of the primary tumor right adjacent to the epididymis. And at low magnification, the first thing that strikes when you look at this tumor is the presence of this very prominent inflammatory infiltrate. So when you see this in the testis, the first thing that you tend to think about is seminoma, of course, especially if the tumor is solid. Here you can see another micrograph at intermediate magnification, showing that the tumor consists of this intermediate nests of cells with clear to eosinophilic cytoplasm that are closely associated with the inflammatory infiltrates. Here you can see the cytomorphologic features of the tumor at higher magnification, showing that the cells are intermediate size, again with clear to light eosinophilic cytoplasm. And on the right, you can see that the inflammatory infiltrates contains not OMA, you tend to see bigger nucleoli. Also, the mitotic activity in this case was low, was about 3 mitoses for 10 high power fields, which would be also unusual in a seminoma. In the picture on the left, you can see residual seminiferous tubules that are negative for germ cell neoplasia site 2, and on the right, you can see that the tumor was extending to the testicular hilum. We performed immunohistochemistry, and the tumor was positive for SF1 and inhibin, which are sex-core stromal tumor markers in this context. And it was also positive for EMA and CD30, whereas SAL4 and OCT4 were negative, and so was beta-catenin. And so our diagnosis was that of a malignant sex-core stromal tumor, suggestive of inflammatory and nested testicular sex-core tumor, and we recommended EWSR1 FISH, which should be underway right now. And this, of course, is a new entity, and when I say new, that is a relative term because Tom Ulbricht's group had recognized many years ago that there's a subset of what they interpreted at that time as Sertoli cell tumors that were clinically malignant and overlapped with seminoma in terms of their morphology. But of course, these tumors were negative for germ cell tumor markers, and they were positive for inhibin, and also other sex-core stromal tumor markers. We retrospectively did SF1 in a recent series, and they are also typically positive. But we recently analyzed a series of these cases with NGS and FISH, demonstrating that the overwhelming majority of them show EWSR1 ATF1 gene fusions or EWSR1 rearrangements. So given their unique clinical pathologic characteristics, we believe that they are a distinct entity that we have provisionally called inflammatory and nested testicular sex-core tumor. And since we published that study, other reports have been documented both in the ovary and in the testis, confirming that this is typically an aggressive tumor, and we've seen a few additional cases in consultation as well. So why is it important not to miss this diagnosis? Well, first of all, because unlike other types of testicular sex-core stromal tumors, and unlike Sertoli cell tumor and OS in particular, this appear to be invariably clinically aggressive regardless of their histopathologic features, whereas if you say Sertoli cell tumor and OS, you're implying that 90% of these tumors are going to be benign. And therefore, these tumors require a more aggressive clinical approach that should include close surveillance and even consideration of an upfront RP-LND. And of course, for the few cases that we've seen that were misdiagnosed as seminoma, germ cell tumor tailored chemotherapy did not work at all, and therefore it's important not to confuse them with seminomas. And the final diagnosis that you don't want to miss is a sex-core stromal tumor with malignant potential. Our illustrative case is a radical orchiectomy case of a 7. You will see at higher magnification in these pictures that show that this area was composed of sheets of large polygonal cells with abundant bright eosinophilic cytoplasm, regular round nuclei, prominent nucleoli, and therefore this was easily identifiable as a component of Leidig cell tumor, whereas the area on the lower right had more of a nested appearance with some elements that were suggestive of a sex-core component, and also the cells had darker nuclei with smaller nucleoli. There were 12 mitotic figures per 10 high power fields, and we performed IHC showing that it was positive for inhibin and negative for germ cell tumor markers. So at the time it was diagnosed as a Leidig cell tumor with worrisome histopathologic features. And after we published some data, we did retrospective FH immunohistochemistry on this tumor, showing that it demonstrated loss of expression of FH with retained expression in internal control capillaries, as you can see there. And therefore, this is an FH-deficient Leidig cell tumor, in this case with worrisome histopathologic features which suggest a high risk of malignant behavior. Here you can see another example of an FH-deficient Leidig cell tumor, in this case with more prominent nuclear pleomorphism. And this FH-deficient Leidig cell tumors were first described about 10 years ago in a series of 29 adult Leidig cell tumor series that were analyzed with Sanger sequencing demonstrated that 2 of them had FH pathogenic mutations, and this included 1 patient with known HLRCC, whereas the germline origin of the second of the mutation seen in the second patient was inferred based on analysis of loss of heterozygosity for an intergenic microsatellite sequence. Well, later studies of unselected Leydig cell tumor from adult patients with FH immunohistochemistry demonstrated retained expression in 32 cases that were analyzed, and therefore the authors of this study concluded that FH deficiency is likely very rare in Leydig cell tumors. And that's likely because, as seen in recent studies, FH deficiency is enriched in Leydig cell tumors that are either clinically malignant or show aggressive histopathologic features, which are the cases highlighted by the yellow boxes here. And interestingly, this next generation sequencing studies also found that some of the FH mutations that we see in these tumors are associated with variants that were classified as of germline origin in ClinVar, including one that's clearly associated with HLRCC. So we believe, again, that this is a distinct entity, or at least an entity that warrants renaming to highlight the underlying FH deficiency. So why is it important not to miss a diagnosis of FH deficient Leydig cell tumor? Well, because these tumors seem to be aggressive, and FH deficiency in a primary tumor, especially if it has at least one aggressive histopathologic feature, probably warrants a more aggressive clinical behavior, at least close surveillance. And because we've seen that some of the FH alterations can be of germline origin, and therefore they can require germline assessment of the patient and eventually of the family. So that's all I have for you. Thank you very much for inviting me to this meeting in this wonderful country, and I'm happy to take questions.
Thank you. Thank you, Andy, for a beautiful talk. As always, I've been hearing this from you for like 6 months. We had this discussion last time. So I would like to have the audience and the chairperson to have a few questions. Yeah.
The photographs you showed, they were not having that typical FH morphology, you know, because I see some of the soft tissue, they have a separate, you know, inclusion like nucleoli, they are coded pattern, the edema is different. So was it morphologically different from the, I feel so after looking at the pictures.
Mm-hmm.
Did you?
No, and we kind of focus on that when we first published the paper and trying to find the morphologic features that have been published in other FH deficient tumors, such as the cherry red nucleoli with the perinuclear halos. The reality is that when you look at series of malignant Leydig cell tumors, we found those features in some that were FH wild type. And the ones that were FH deficient sometimes didn't have any of these features. So no, there was no correlation.
Did you do 2SC marker on succinate cysteine on this one? The other IHC which is?
No, but we sequenced them and none of them had, and the panel included SDH, all the SDH genes, and they were all wild type. But again, FH immunohistochemistry, I think going to your question, which is an important point, which I did not mention in my talk. So our current approach is whenever you see a Leydig cell tumor which has worrisome histopathologic feature, that's when you should do FH immunohistochemistry. The ones that are indolent don't seem to have it, having said that recently Maurizio Colecchia, a colleague from Italy, shared with me a case that of a patient that presented to his center with retroperitoneal metastasis of a Leydig cell tumor. So they did FH, it was FH, so it was FH deficient. They went back to the primary tumor, which was totally benign, and it was FH deficient as well.
Because even the kidney ones, they show the same morphology.
Yeah. But again, like currently recommended to do it when
any
you have
high-grade Leydig cell, you advise to do the?
Not high-grade cytomorphology, just worrisome histopathologic features such as high mitotic figure, high count, mitotic count, presence of necrosis. The presence of pleomorphism, of course, should be another feature to take into consideration. Always keeping in mind that some of these tumors can show like this endocrine type atypia that is not necessarily associated with aggressiveness.
Thank you.
So we have the last question for this session from Dr. Kossel.
So nice talk, Andy. Beautiful cases and beautiful family picture. So my question is a little related to your case too. So the similar scenario with the metastatic mixed germ cell tumor post-Yorkectomy and retroperitoneal mass. But instead of cystic trophoblastic tumor, I've seen a couple of situations where we have spindle cell proliferation, which is falling short of sarcoma or somatic type of sarcoma, and clearly over and above fibrosis. So what's your take on how do we take these cases, and any update on the nomenclature of these intermediate type of spindle cell proliferations post-Yorkectomy in a metastatic post-GCT?
So the question would be what to do whenever you get a post-RPLND, post-chemo RPLND, and you have spindle cell proliferation. So the first thing I think when I have that, right, one is to see if whether it's just cellular fibrosis, which can happen, especially if the RPLND is done close to the chemotherapy, right? So that's the first concern. And that's, I would say, relatively difficult because most of the time you can tell that they are myofibroblasts, right? They are not truly atypical. And once I have that, if I think it's all fibrosis, the next thing I do is go to the chart and see what were the markers, right? So if the markers are negative and I don't find any viable component other than teratoma, right, I usually let it go. But if I have elevated AFP or elevated ACG, what I do is additional sampling of 1 additional section per centimeter, focusing on areas that look viable.
Right.
But if you have viable teratoma or just fibrosis and negative markers, and you think you have good sampling, I just let it go.
All right.
Is that what you were referring to?
Yes. And do you recommend doing isochromosome 12p to help, whether it's residual malignancy or whatever, or is it just the fibrosis? Will that testing help?
For fibrosis, I usually don't need it. I might be wrong. Maybe some of the things that I've called fibrosis were not, but I think it's usually distinguishable by morphology. I think myofibroblasts don't have either the cellularity or the atypia that you would expect in a somatic type sarcoma.
Yes. So this is the problem.
Yeah.
So we struggle putting them in a bracket, whether it's sarcoma, somatic type of sarcoma, is some fibrosis. So
yeah, but I do isochromosome 12p analysis, especially in late recurrences when they have pure somatic type histology. Those are really challenging, especially when they look like carcinomas.
Right.
And in that context, I have a very low threshold for ordering isochromosome 12p FISH, because there you can make a mistake. And we've seen cases that recur 20 years, 30 years after chemotherapy now. And this patient present with a pure sarcoma in a lymph node, or a pure carcinoma in a lymph node, right? And carcinomas, you could expect that in a 50, 60-year-old patient. Yeah. So in that context, isochromosome 12p is very useful.
Yes.
Always keeping in mind that sensitivity is about 90%. Right. So, yeah.
Great. Thank you.
Our clinicians are not. At Indiana University, they understand that somatic type sarcomas are not sarcomas. Occasionally, for rhabdos and ENTs, they will consider histology tailored chemotherapy, but mostly to try to shrink the disease to a size that's completely resectable. If the tumor is completely resectable without chemo, that's what they will attempt to do. They will attempt to do just surgery. But if it's too big, they will just try, as a heroic measure to do histology tailored chemotherapy and then try to resect.
Gladiel has a question.
Yeah, great talk, Andy. I just have one question. Have you seen a case of cystic trophoblastic tumor in pure form? Because I haven't seen any. All the things that I saw are in the background of teratoma, mature teratoma in particular, and I'm curious if this is really a distinct tumor rather than a pattern of differentiation of teratoma. Traditionally, we say teratoma, mesoderm, endoderm, ectoderm, but maybe it has a mature trophoblastic component. Are there any evidence that can molecularly that can really separate this from teratoma? Because maybe we're just over-describing it as a tumor.
So that's a great question, actually, and a very valid one from a clinical point of view. There is some evidence. So we presented at the last European Congress of Pathology a study on this post-chemotherapy trophoblastic tumors, doing some molecular analysis, including isochromosome 12p and expression of microRNAs. they show the gene expression profile of teratomas. Clinically, they behave like teratomas. So I think biologically they are teratomas. It's true that, again, like in the context of a patient having a prior history of choriocarcinoma, you can interpret that they are part of the maturational changes, but biologically they are teratoma. And when I see very small foci, to be honest with you, I completely ignore it, and I just call it teratoma. Especially if it's a consult case, I just call it teratoma. If it's a big mass, like a big cyst, and it's impossible to just let go, I call it, and I put a note saying, like, this tumor is biologically equivalent to teratoma. Please don't give additional chemo if there are no additional criteria for giving chemo.
Thank you, Andy. And would you mind staying there on the stage for the group photograph? So, and we'll invite chairpersons Tanusri Mishra and Pritinanda Mishra. And I'll request you guys to stay back on the stage. Our next talk is on penile cancer, a pathologist's perspective on clinical current trends in diagnosis, staging, and treatment by Dr. Jasriman Dhillon from the Moffitt Cancer Center, Florida.
Okay, thank you for inviting me over, and today I'll be talking about penile cancer, a pathologist's perspective on current trends in diagnosis, staging, and treatment. Now, the incidence of penile cancer is extremely rare. It's 1 in 100,000 each year in the United States, and less than 1% of cancers in men in the United States. However, in some Asian, South American, and African countries, it is up to 10%. Now, why is it high? There are certain factors like low prevalence of circumcision during infancy, high rates of HPV infection, hygienic infrastructure, and other features like smoking and phimosis. And the incidence of penile cancer is on the rise in certain countries. Now, this is a map where the incidence of penile cancer is highest in certain Southeastern Asian countries, in India, Sub-Saharan Africa, and South American countries. Similarly, the incidence of deaths related to penile carcinoma are high in these regions. And if we divide it by different countries, India has one of the highest incidence of penile cancer cases. Okay, and in there are two viruses that are prevalent in southern Africa, the HIV and HPV. What happens is many patients are immunocompromised because of HIV, and on top of it, if they are infected with HPV, it becomes difficult for them to clear the HPV infection. So persistence so the persistence of the HPV infection leads to the development of the penile cancer, and it increases it by 2 to 3 times. I'll start with the basic lesion, the condyloma acuminatum, which is a benign lesion which is caused by HPV low-risk genotypes, types 6 and 11. It is commonly caused a genital wart and is characterized by papillomatosis and acanthosis. There is hyperkeratosis, maybe some parakeratosis, but there is no pleomorphism within these epithelial cells. And it is characterized by presence of coilocytes, which are enlarged nuclei. Some of them may be binucleated with perinuclear halos. For development of penile squamous cell carcinoma.
Just a minute, would you mind talking to the mic?
Okay.
The people sitting over in the back cannot hear you.
Sure. Now, squamous cell carcinoma is the most common malignant penile cancer. It is broadly categorized into HPV-associated and HPV-independent. In fact, 20 to 50% of the penile cancer is is HPV associated and the rest is HPV independent. Right now, there are no treatment differences between the two, and we know the integration of the HPV DNA into the DNA of the epithelium of the squamous cell is important for the squamous cells to develop into cancer, because it leads to the overexpression of the E6 and E7 proteins, which interact with P53 and retinoblastoma and lead to uncontrolled proliferation of the tumor cells. Now, the HPV-associated penile squamous cell cancers will strongly express P16 on immunohistochemical staining. More than 70% of the tumor cells have nuclear or cytoplasmic staining is present, and it is diffusely positive. To confirm if it is HPV infected, we further do HPV RNA-ish, which is characterized by dot-like nuclear or cytoplasmic positivity. Now, this positivity does not have a cutoff value. It can either be very strongly positive, as you can see on the left lower hand picture, or sometimes the positivity is so scant and so focal that you have to zoom in on high power to call it positive. A few words about the morphology of the HPV-related penile squamous cell carcinomas. Warty type is the most common subtype that we see. It is characterized by papillomatosis, a thickened epithelium, and the basal cells may sometimes look more blue to you because of the high N to C ratio, but as we go towards the superficial layer, there is more maturation, and we do see foci of the coilocytic atypia that is present in the superficial layers. And if you do P16 and HPV-ish, it will be positive. Another subtype is the basaloid subtype. This is a very aggressive subtype of penile cancer, and it is characterized by proliferation of these very blue cells that look very blue because they have a high N to C ratio, and they look very monomorphic. There is high mitotic activity, and abrupt foci of necrosis are present in these subtypes. Other HPV-related penile squamous cell carcinomas which are associated with HPV are the clear cell type and the lymphoepithelioma-like. Clear cell type is characterized by clear cytoplasm, and lymphoepithelioma-like is just like what we earlier had seen in the bladder, what Dr. Panner described, so I'm not going to go into the detail of the morphology. Few words of the penile intraepithelial neoplasias, which are HPV-related. It can be a basaloid pattern or warty pattern. The basaloid pattern is characterized by proliferation of these, again, monomorphic cells, high N to C ratio. They look very blue, and the surface may have hyperkeratosis or parakeratosis. The warty type pattern is characterized by acanthosis and these formation of these spike-like projections, and hyperkeratosis, parakeratosis, and presence of coilocytes in the superficial layer. On the left-hand side, you can see some of the coilocytes that are present, and if you do immunohistochemical stain P16, it will be diffusely positive in the epithelium. A few words about penile intraepithelial neoplasia. We do not grade them. We do not call them mild dysplasia, moderate dysplasia. We just call them penile intraepithelial neoplasia. Also, the terminology squamous cell carcinoma in situ is not encouraged to be used. So for HPV-related penile intraepithelial neoplasia, it has diffuse block positivity for immunohistochemical stain P16. Proliferation marker Ki67 will show positivity up to the suprabasal layers. P53 in HPV-related PIN is usually negative, and if you do ISH for high-risk HPV, it's positive. ISH for low-risk HPV is negative. And if you further want to subtype the different types of HPVs, viruses, PCR testing can be done. So this is, we did a survey, Dr. Mohanty and I, among more than 250 GU pathologists worldwide. characterizing how do they practice reporting in penile squamous cell carcinomas. So one of the questions we asked them was, do you perform HPV testing in penile cancer cases? So up to 33% of the respondents said that they either always do it or usually do it, but it was all over the place. Most of the respondents were that they either do it sometimes, rarely, or do not do it. The second question we asked was, do you perform P16 immunostaining in penile cancer cases? Close to 50% responded that yes, we always do it. So if the resources are not available to further confirm the presence of HPV infection, what one can do is do a P16 immunohistochemical stain, which is universally available, and combine it with morphology, and with this you will be able to detect most, if not all, of the HPV-associated lesions. There have been a few changes in the terminology with the 5th edition of WHO and the different subtypes of HPV-related penile squamous cell carcinomas. Basaloid and papillary basaloid are combined together as basaloid squamous cell carcinoma. Warty and warty basaloid are combined, and we only call it warty carcinoma. Clear cell and lymphoepithelium alike are retained. So what is the prognostic value of HPV infection? Do HPV-associated penile squamous cell carcinomas do better than HPV-independent or not? There were numerous studies that were done, and some of the studies initially said they are good, some said they are bad, and in this table, if you see, there are 2 studies with maximum number of patients. Both of them said that HPV has a positive prognostic value, and we are getting more and more evidence. Now, majority of the studies do believe that yes, HPV status is a good prognostic compared to the HPV-independent squamous cell carcinomas. This is on the right side, there's a cohort from the Norwegian study where they studied penile cancers that were HPV-associated from the last 50 years, and they compared the HPV-associated with HPV-independent cohorts and found that HPV-associated penile cancers, even with lymph node positive cases, did better than HPV-independent cases. A few words about the HPV-independent penile intraepithelial neoplasia, also called differentiated intraepithelial neoplasia. It is characterized by epithelial hyperplasia, hyperkeratosis, and parakeratosis. You may have dyskeratotic cells with keratin pearls scattered in between. The atypical cells may be very subtle. They may be present just towards the basal cell layer or suprabasal cell layer, and there is retained maturation of squamous cells in the upper layers. So how do you differentiate it from hyperplasia, which can be extremely problematic? You can look for basal cell atypia, which is very subtle and can be present just at the basal cell layer of the epithelium. Do a proliferation marker, Ki67. In hyperplasia, Ki67 is usually negative, or it's scattered towards the basal cell layer, whereas in hyperplasia like PIN, it will be positive in basal as well as suprabasal in a continuous pattern. If you do P53, it will be negative in hyperplasia. When I say negative, that means the positivity will be restricted to the basal cell layer. Whereas in hyperplasia like PIN, the P53 will be variably positive. Either it will be negative throughout, or it will be, the positivity extends from the basal to suprabasal cell layer. Doing P16, it'll be negative for both, so that will not help. Here is, again, you can see on the left-hand side the H&E image of differentiated PIN, which looks extremely bland, and it's very important to distinguish it from non-neoplastic hyperplasia. Doing Ki67, where proliferation is just not limited to the basal layer, but also stains the suprabasal layer, is helpful. And P53, this is the null type where it's negative no cell is positive, and that would indicate that TP53 is mutated. So coming back to the questionnaire, another question we asked them was, all the respondents were, do you subtype PEIN further into differentiated type versus warty, mixed, or basaloid type? Only up to 45% responded that yes, we always subtype them differently. The HPV-independent squamous cell carcinoma, there have been some changes in the terminology. The usual type, pseudohypertrophic carcinoma and the pseudoglandular carcinoma, they have all been clubbed together as squamous cell usual type. Verrucous and carcinoma caniculatum have been clubbed together. Now it's called verrucous carcinoma. And papillary sarcomatoid and mixed squamous cell carcinoma terminologies have been retained. Now, the HPV papillary type squamous cell carcinoma is characterized by formation of these papillae, which have fibrovascular cores, and other features of squamous cell cancer. If you do HPV testing, it's negative for HPV testing. The sarcomatoid type is characterized by spindle cells, and it again is one of the most aggressive subtypes of squamous cell carcinoma present. The verrucous type has the best prognosis. This has no metastatic potential and is characterized by these spiky acanthotic epithelium with hyperkeratosis, parakeratosis, and a very broad-based base towards the base. It does not have any infiltration. So what are the histological features of prognostic significance in penile squamous cell carcinoma? Histological subtypes, as I said, basaloid and sarcomatoid have very poor prognosis compared to the other subtypes. Grade of the tumor, poor grade or high grade has the worst prognosis. Depth of invasion, stage, presence of lymphavascular invasion, perineural invasion, resection margins, and metastasis to the inguinal lymph nodes are the features. The 8th AJCC cancer staging has changed the PTA subtype from verrucous carcinoma to non-invasive localized squamous cell carcinoma. The PT1A is further divided into PT1A and PT1B. If we have adverse features like high-grade perineural invasion or lymphavascular invasion. If any one of these three is present, it's staged as PT1B. However, the problem is with the poor reproducibility in grading models. Now, penile squamous cell carcinoma is graded as well differentiated, moderate, and poorly differentiated. The well-differentiated is on one hand of the spectrum where the cells are very well differentiated, and it's difficult sometimes to distinguish it from benign squamous epithelium. The poorly differentiated is characterized by presence of spindle cells or markedly pleomorphic cells, and it's difficult to recognize that this is squamous cell cancer. Now, anything else, any cancer which does not fit in these two subtypes is clubbed in the center, and it's called moderately differentiated squamous cell carcinoma. However, there is a lot of inter-observer variation. In our, this is data again from our questionnaire that we asked. We asked, do you, when asked, do you grade squamous cell carcinoma basaloid type as poorly differentiated? Only up to 70% said usually. Others had different answers, including never. Another question, do you grade squamous cell carcinoma caniculatum as well differentiated? About 75% said yes, usually they do. When we asked, do you grade squamous cell carcinoma warty type, usual morphology without pleomorphic features as moderately differentiated, it was all over the place. So this data kind of tells you the inter-observer variation that we have and the difficulty when coming to grading the squamous cell carcinomas. Another question that we asked about grading was, in a predominantly well to moderately differentiated penile squamous cell carcinoma, what is the minimum proportion of poorly differentiated component would you like to see to call it a poorly differentiated squamous cell cancer? So the responses, close to 50% said at least 5% or more. And some said they would like to see even less than 5%. And many respondents were saying they need at least 20% or more than 25% of poorly differentiated foci to call it poorly differentiated carcinoma. However, per CAP protocol, any proportion of anaplastic cells should be noted in the report and is sufficient to categorize a tumor as grade 3 cancer. So it's not only having uniformity of reporting among pathologists, also we have to keep upgrading ourselves to the new criteria that come very often these days. In the 8th edition, the corpus spongiosum and corpus cavernosa, they were segregated as PT2 and PT3 because many studies said tumors that infiltrate into corpora cavernosa do worse compared to corpus spongiosum. However, not all studies agree, and it has been suggested that this criteria be reevaluated. And some studies also suggest that similar to T1, we divide T1 as T1A and T1B depending on presence of left vascular invasion or perineural invasion. We should also divide PT2 as PT2A and PT2B. Also, the role of tunica albuginea into invasion needs to be further evaluated because currently, if the tumor is infiltrating into tunica albuginea, we are grading staging is at PT3. The PT3 includes invasion of corpora cavernosa, including tunica albuginea. There is no mention of urethra. So irrespective of urethral involvement, it's called a PT3. So currently, there is no significance of urethral involvement in the staging. However, many feel that invasion of a urethra within the corporal bodies may have an adverse prognosis and would need to be reevaluated. In the staging of the nodal disease, if it's 2 or less than 2 lymph nodes are positive without extranodal extension, it's PN1. If extranodal extension is present, it's up a stage as PN3. Many have suggested to add the lymph node density to the N criteria. That is, number of positive lymph nodes out of the total lymph nodes that were dissected, and also add the lymph node yield to the criteria. The regional lymph node metastases, there are certain primary tumor pathologic features of importance that predict risk of lymph node metastases. These include grade of the tumor, depth of invasion, lymph vascular invasion, and perineural invasion. Lymph node status is the strongest predictor of clinical outcome. The higher the stage, the lesser the cancer-specific or the overall survival is. A few words about the sentinel lymph node biopsy. It is used for inguinal lymph nodes for staging clinical N0 tumors where the tumors are not palpable, because 15 to 20% of clinically N0 patients can have micrometastatic disease in their lymph nodes. However, if the lymph node dissection is done without doing the lymph nodes, there is a lot of morbidity. Hence, the idea of sentinel lymph node biopsy has come in. A positive, if the lymph node biopsy is positive, radical, the lymph nodes are taken out. So what happens is if clinically the lymph nodes are positive and they are big lymph nodes, patients are given neoadjuvant chemotherapy, and this is followed by resection. However, if there is small volume disease, only resection is done. If the lymph nodes are negative and there are no high-risk factors involved, only active surveillance is done. If there are high-risk factors, like if the stage is T2 and higher, there is poor differentiation, lymph vascular invasion or perineural invasion, resection is done. And of course, depending upon the extent of the PN stage, if it's PN3 or PN2, the lymph node, it's extended, the resection is extended up to involve the pelvic lymph nodes. So clinically significant histological factors include staging of the penile cancer, T2, T3, presence of poorly differentiated cancer, lymph vascular invasion, perineural invasion, if extraneural extension is present or not, and HPV status. So we've seen tumors that are double negative, which are TP53 negative as well as P16 negative, tend to do worse. And if we look at the molecular data, TP53 mutations, CDNK2A mutation, third promoter mutation, and Notch1 mutations are seen more often in HPV-independent tumors compared to HPV-positive tumors. And this is the heat map where we analyzed 23 cases of penile squamous cell carcinoma, and we did find all the HPV negative cases were enriched with mutations involving P53, third promoter, and Notch1. So for immunohistochemical staining of TP53, it's considered mutated. If P53 staining is completely negative, that's called the null type, or more than 70% of the nuclei stain positive, regardless of the intensity. In this particular case, the intensity is good, but the percentage of nuclei staining were only 35%. So when we correlated with our molecular data, it had wild type. It was not mutated. So a few words about the treatment of penile squamous cell carcinoma. Once the first line chemotherapy is given and cancer comes back, there are a few options. Patients can be treated with anti-EGFR antibodies, receptor kinase inhibitors, and tumors with high tumor mutational burden and tumors which are MSI high can be treated with pembrolizumab. However, penile cancer cases, very few of them are high in show high TMB burden. Only up to 18% show high TMB, and they are usually microsatellite stable. PD-L1 is diffusely expressed in penile cancer cases, usually in HPV negative cases, and are associated with worse overall survival. So and this is the latest paper where they say the immune checkpoint inhibitors, there is no difference in outcome based on high-risk HPV status, and benefits of immune checkpoint inhibitor monotherapy in patients with advanced squamous cell carcinoma is limited. And usually there are different clinical trials going on with combination chemotherapies, but the results are awaited. For EGFR, although EGFR is expressed highly in more than 90% of penile squamous cell carcinoma, but that does not guarantee that tumors will respond to anti-EGFR therapy. Similarly, the mutational status does not guarantee that the tumor will respond. Another option is the antibody drug conjugates, where we have a couple of biomarkers, Nectin-4 and TROP2. So currently, clinical trials are being conducted with Nectin-4, and TROP2 is another biomarker that is being considered. Lastly, I'll talk about HPV vaccination and its role in prevention of penile squamous cell cancer. The HPV vaccination started in 2009, but there's not enough data for us to see if it has any effect in preventing penile cancer cases, because penile cancer is a very rare disease, and HPV-related penile squamous cell cancers are 50%, and there is a time gap between the infection and development of lesions. Although they do, it's very effective in reducing the incidence of genital warts by 90% and also reduces the anal intraepithelial neoplasia by 77.5%. Thank you.
Thank you, Jasmine, for that wonderful talk. If there are any questions from the audience?
Can I have a question? Thank you. Can I ask a question? Yeah, thank you for that very beautiful presentation. My question is how to differentiate between condyloma acuminatum and a very well differentiated squamous cell carcinoma, and would any IHC pattern help? Because on ground, it's sometimes very difficult on just histomorphology, and coilocytes are sometimes very deceptive.
Yes, so one thing that condyloma acuminatum, it's kind of similar question, can it have dysplasia,
Yes,
right?
exactly.
So what, one is morphology. If you see subtle atypia, or if you are convinced there is atypia, yes, I would say condyloma has dysplasia. Another thing that I do is I run low-risk HPV, and I also run high-risk HPV-ish on it. If it's positive for high-risk HPV, I will definitely say there is dysplasia associated with it.
Would P53 help in any case?
TP53, again, it's one of the stains where you need it, it never helps you. So I'm not very confident of
That's
that.
right, yeah. Thank you. Thank you.
I mean, here I would differ a little bit. If you see like a very dense up to the top layer, we have TP53 staining. You could give a suggestion, but yeah, because there are many labs who do not have the ISH for HPV, DNA or RNA. So that time, TP53 can be used as a surrogate marker if your changes are not very clear. What is your take on this, Rohit?
Actually, I think similar to what you have mentioned, I think we also tend to submit to both low risk and high risk. We do tend, we have the luxury of having both RNA issues, so actually we will do it. But I think it's understandable that in institutions where they don't have the privilege of having both low risk and high risk HPV, so I guess using the morphology and P53 as a surrogate may or may not be helpful.
Yeah.
But I agree with you. It's like doing the urothelial stains. When we need help, they don't help.
They don't help.
Just a minute. Sorry. I think P16 is one here. Sorry.
Yeah, P16 is definitely.
Yeah, P16 can be aberrant and can be ambiguous in some percentage of cases. Yeah. So we have had typical HPV independent cases which have come diffusely P16 positive. And that's where the role of HPV-ish is more important. So about 10-15% of the cases, the P16 can be very ambiguous actually.
And do you want to enlighten people regarding the clones they should use for PDL1 for penile cancer, because it's kind of not well established like lung or in oropharyngeal and oral cavity squamous cell carcinoma. So what is your take on that?
Sir, we usually do PDL1 penile. So Amit is here. Amit, we don't do PDL1 in many cases.
PDL1, there are studies upcoming in PDL1. So, we are not that well established, right, as squamous cell carcinoma, the oral cavity or something. But if you have to do, what is your take on like which clone people, in a futuristic way, I would say?
For PDL1? Yes, in our lab we had do 22C3 clone, but I believe there is a paper, you're the senior author on it, where you have shown that
we showed like
there are a couple of more stains and they are equally good.
They are equally good actually, yeah. But your center, you do 22C3.
Yes, we do 22C3.
And what is your take on doing a PDL1 staining, Amit, on penile squamous cell carcinoma?
Basically, this field is rapidly evolving. Recently, we have one paper for pembrolizumab, use of pembrolizumab. So in this scenario, I think at least Indian context, patient cannot afford much, but from a clinical perspective, what we have used in 2 or 3 patients, we have a good response. So in terms of the clone, even for lung, if it is positive from either Ventana or more or less same, so we generally go for 22C if it is available. Otherwise, the other Ventana kit is also good for deciding. But in day-to-day setting, what percentage of cutoff can qualify to give immunotherapy in, at least in penile carcinoma, we don't know that real answer, that whether to take 10%, 50%. So if patient is affording anything more than 10%, I usually counsel for taking the immunotherapy, but it's an arbitrary cutoff.
Yes, like we use CPS and the cutoff is so less that majority of the patients will qualify.
Yeah, as Amit said, in our study where SEMA is also involved as one of the co-authors, we used 10% at the, and we did CPS, the whole number. But what she said, like the interclone variability, what people usually see in the non-small cell carcinoma of the lung, where 22C is way superior to the Ventana stains, is actually probably not. And in our study also, we had an abstract last year where Anandi was the first author and I was the last author. We showed equal positivity pattern among the stains. Thank you, very nice talk. Thanks a lot. Would you mind stay back on the stage? And oh, you want to? So I'm sorry.
As in every solid tumor, have a standard
receptacle like in breast, head and neck, colon, stomach, that this much lymph nodes should be dissected, and that is the adequate sampling for you and also for us to see the reporting that adequate sampling have been done. But in penile cancer, as if the sentinel lymph node is positive, as you said that bilateral or ipsilateral, that pelvic and inguinal all node dissection should be done. So is there any guideline that minimum this number of nodes should be dissected by the surgeon to you, so that you can say that yes, the sample is adequate, and for us also to see that yes, the reporting is adequate?
No, in our institute, whenever they go for, they take out the inguinal lymph nodes, they are all sent for frozen section diagnosis. So if, and count. So they check, they say 4, they are happy if we say 4 or more. Yes. So if all the lymph nodes are negative, they will not proceed to take out the deep inguinal lymph nodes. If even one of them is positive, they will proceed to take the deep inguinal lymph nodes out.
SID.
Santosh, yeah. So I think actually we published in 2016 in Annals of Oncology. So I'll just read from the study we had done, and in that study, 62% of primary penile carcinomas were positive for PD-L1 expression, and there was a strong positive correlation of PD-L1 expression in primary and corresponding metastatic samples. PD-L1 expression was associated with high clinical pathologic features and poor clinical outcomes. We had used a 5% cutoff in that study, and this was in 2016 in Annals of Oncology. I believe that might also be an antibody difference, that is possible, but I think majority of tumors are positive.
You're not audible.
So if you take CPS, the key here is if you are taking TPS, your percentage would be little low, but if you are taking a combined positive score as CPS, it will bump up a little, but is again what Rohit said, it is kind of between 50 to 60% or 65%, the PD-L1%. And all the clones, they do well.
Yeah.
So, thank you very much. I would have all the speakers and the panelists to come in the,
Can you please
to the
come
middle
at
of
the
the
center for the group picture?
center, yeah, for the picture. Good sensation. You are, no, you have it here.
Thank you. Thank you so much. Now, can I please call upon the chairpersons for the next session, which would be case-based discussion?
Well, I'll just have to make an I'm so sorry. And as Dr. Anuradha is leaving, she has a flight to go take in the next 2 hours.
Okay.
Okay.
All right.
Thank you.
Can I please call upon Dr. Sandhya Sundaram?
Yes.
You are the one who is...
Yeah, madam is
I'm
coming.
sorry. Dr. Sonia Badwal, Dr. Rajni Parmar, Dr. Anuradha Sekaran, Dr. Paromita Roy. Can you please come up on the stage? And I would like to invite our speaker, Dr. Rajal B. Shah, who would speak on the topic treatment-related neuroendocrine carcinoma of the prostate. Over to you, sir.
Good evening, everybody. So I know it has been a long day, so I will be on the case. So 61-year-old man presented with multiple liver lesions. The patient had a history of grade group 4 prostate cancer, which was treated with radical prostatectomy with PT3B and 0 stage. And he was also on Leuperon and enzalutamide for recurrent prostate cancer. His recent PSA became undetectable, and patient underwent core biopsy of the liver lesions, which is shown here. So as you can see here, this is a clearly infiltrative high-grade process. And as we look at it a little closely, tumor cells are a very high NC ratio, has a very powdery type of chromatin pattern. You can appreciate very mitotically active tumor with numerous atypical mitosis. And here is one more close appearance. So I mean, with this morphology, clearly I think nobody would have any argument that this is a clearly like a high-grade neuroendocrine morphology. And with the history of prostate cancer, these are the panel that I did. prostatic markers were pretty much negative except rare NKX 3.1 positivity. Neuroendocrine markers synaptophysin and INSM were positive while chromogranin was negative, and Ki67 demonstrated high proliferation more than 90%, and here are some of the representative images. So I think the history that I have provided you kind of gives away the diagnosis, but I frequently get questions from colleagues that how can you call this a prostate metastasis when the prostatic markers are negative. So I think that is one very important treatment, very important practice related point, and I will show you later on why that is the case. So the diagnosis for this case is metastatic treatment-related neuroendocrine prostate cancer. And this is the WHO classification of neuroendocrine prostate cancer, and similar like lung counterpart, prostate also has a low-grade, well-differentiated neuroendocrine tumor and some of these other acinar differentiation with neuroendocrine differentiation. But when we talk about prostate neuroendocrine carcinoma, it is the high-grade spectrum which is clinically most relevant and important to understand. So I think another important point of the important point for the prostatic neuroendocrine carcinoma is that majority of prostate carcinomas are considered to arise from treatment emergent transdifferentiation of neuroendocrine cells from the prostate, naive prostate adenocarcinoma. De novo prostate small cell carcinoma is pretty rare. So that is another very important difference, that only rare proportion of prostatic high-grade neuroendocrine carcinomas are de novo. Majority arise from treatment-naive prostate adenocarcinoma following resistant to intense androgen suppression therapy and newer generation of androgen receptor signaling inhibitors, enzalutamide and abiraterone. So following the emergence of therapeutic resistant spectrum of diseases emerge which can be AR dependent with castration-resistant prostate cancer with standard phenotypic features. As another spectrum is AR independent, and small proportion of AR dependent, independent prostate cancer transdifferentiates into this treatment-related neuroendocrine prostate cancer, which is called in the latest WHO classification as a treatment-related neuroendocrine prostate cancer. So treatment-related neuroendocrine prostate cancer commonly present at metastatic sites but can also present as a primary. It represents 10 to 15% better outcome than the de novo small cell carcinoma with a survival of 53.5 months compared to 16.8 months for de novo small cell carcinoma. So here is some of the morphological spectrum. This is classic small cell neuroendocrine carcinoma, which has a morphology very similar to oat cell carcinoma of the lung, characterized by very high nucleus to cytoplasmic ratio, nuclear molding, powdery or salt pepper type chromatin pattern, very proliferative tumor. So when you do one immunohistochemical stain, you typically see more than 90% of positivity in these tumors. But keep it, so there can be some size spectrum that you may appreciate. Large cell neuroendocrine carcinoma, in my experience, they are quite difficult to diagnose. So particularly at low power, when you see geographic necrosis like seen here in this particular example, this type of geographic necrosis, nested architecture, they are very important clues. At high power, you don't see classical neuroendocrine features like you see in small cell carcinoma. You may have very prominent nucleoli and relatively more cytoplasm. Sometimes you may see peripheral layer with some palisading. So those are the important high-grade spectrum. So of various hypotheses, currently lineage plasticity, which is characterized by transition of AR-dependent luminal type pathway to AR-independent pathway in response to hypoxia and exposure to newer generation androgen blockade therapy is considered to be an important theory. There is a classically down-regulation of AR signaling pathway, so that's why all AR and downstream AR markers are typically negative. And the complex molecular events, which includes loss of tumor suppressor genes, retinoblastoma 1, TP53, and PTEN. There is also dysregulation of lineage-specific transcription factors, ASCL1, NeuroD1, and delta ligand factor 3. There is also amplification of oncogenes, particularly NMYC and ARUCA kinase, and even epigenetic reprogram is also considered to be important. So this is a complex molecular process, and recently at our center, we showed a model of progression of such neuroendocrine differentiation and showed that when you use this in vivo mouse models, ASCL1 and NeuroD1 are critical in neuroendocrine differentiation in prostate cancer. So what are the clinical features that may concern you for neuroendocrine transdifferentiation? When patient presents with visceral or lytic bone metastasis, there is a bulky advanced disease. In comparison, PSA is very low, so disproportionate PSA in compared to the volume of the disease, short interval to androgen independent progression after initiation of ADT, elevated LDH, CEA, or malignant hypercalcemia. These all could be important clinical presentation, but this is not specific only to neuroendocrine phenotype. Other tumors, poorly differentiated adenocarcinoma showing AR positivity, neuroendocrine negativity, double AR and neuroendocrine negativity, and double AR positive and neuroendocrine positive, also known as amphicrine carcinoma, can present with similar clinical features. Any component of high-grade neuroendocrine portends a poor outcome, so it is very important to report when you see that, and patient typically requires a platinum-based chemotherapy. So another very important point to understand that the neuroendocrine markers expression does not equate to clinically significant neuroendocrine differentiation. So if you stain poorly differentiated acinar adenocarcinoma with neuroendocrine stains, then very likely you will see some neuroendocrine expression. But most studies have shown no clinical significance of this phenomenon. So routine application of neuroendocrine markers, unless there is an evidence of neuroendocrine phenotype or neuroendocrine features, is not recommended. That is very important point to understand. A small proportion of these tumors can also have a diffuse co-expression of the luminal and neuroendocrine markers, also referred to as an amphicrine carcinoma. And in amphicrine carcinoma, this is relatively very uncommon, but the morphology is very subtle for the neuroendocrine features. So you see very poorly differentiated tumor with kind of subtle nuclear neuroendocrine features like salt and pepper type chromatin pattern, very high mitotic activity, but typically it is lower than the small cell carcinoma, and this is typically present at the metastatic sites, which can be an important point for the kind of diagnosis. And the importance of this phenomenon is that patient may benefit from both ADT suppression and platinum-based chemotherapy. So when you work up this particular tumor, you will have to use a panel-based approach. Keep in mind the three panels. You need all prostatic markers, so PSA, NKX3.1, PSMA, and AR, or you can use variable combination of these neuroendocrine markers. At least one marker is positive in 90% of cases, but again, you want to use a panel-based approach, and also use the proliferation marker MIB1, which is typically going to be more than 80% in small cell and more than 50% for large cell. But the important caveats to understand is that because of the AR down regulation, these markers are variably expressed, and negative ISC or negative AR or prostatic markers does not rule out prostatic origin in both non-NE and non-neuroendocrine and neuroendocrine setting. And another point of importance is that even in presence of ERG gene rearrangement, ERG immunohistochemistry can be weak or absent. So if you really want to confirm the prostatic origin, fish is recommended. So these are some of the take-home messages that I discussed with you. This is applied specifically to a high-grade tumor. It develops secondary to intense androgen suppression. In clinically localized prostate cancer, unless you see morphologic features of neuroendocrine carcinoma, do not use routinely neuroendocrine markers because that will likely confuse you, and that is of sometimes no significance. But in metastatic setting, you can have range of morphologic features, and ISC can be used in conjunction with morphology in a more supportive role, like a small biopsy, scanned tumor, or crush artifacts. Okay, thank you very much.
Thank you. Thank you for that wonderful presentation. Can I please follow up? We have questions?
One question which is clinically, we discussed multiple times with Santosh. So in a primary diagnosis, when the pathologist reports that it's an adenocarcinoma with neuroendocrine differentiation vis-a-vis the primary small cell carcinoma prostate. So for a clinician to plan a treatment, if his primary histopathology is acinar adenocarcinoma with neuroendocrine differentiation, so then we somewhere get confused. Should we take it as a, and then we ask what percentage is positivity, whether it's nodal positivity or not. So how to tackle that situation of a acinar adenocarcinoma with neuroendocrine differentiation vis-a-vis a small cell carcinoma prostate? We know that primary small cell carcinoma prostate we treat like any other small cell tumor. For the other entity, it's sometimes difficult to take a call. Should we add platinum to that? Should we continue with abiraterone? Should we add docetaxel in this scenario?
Yeah, I think this is a great question, and I think in my kind of experience, you can have small proportion of this high-grade neuroendocrine carcinoma with a mixed adenocarcinoma component. But in that setting, this is important. You have both still AR intact pathway and you have a neuroendocrine pathway, and patient could benefit from both therapies. I don't grade the high-grade neuroendocrine component. I would grade only the acinar component. But I think an important point that you want to make sure that I think the acinar adenocarcinoma is not expressing neuroendocrine markers. The significance of that phenomenon without a clear-cut high-grade neuroendocrine differentiation is very...
And is there any difference between the percentage? So like in whole biopsy, 10% is acinar and 90% is a differentiation component. So I think Dr. Sandy can also come into the picture too. So sometimes if they go to the other medical oncologists, they advise the carboplatin etoposide. When we feel that PSA is in the higher side, do we really want to add carboplatin etoposide at early? We know that it's not a pure small cell carcinoma. De novo is clear.
Right, no, for patients who are not prior ADT suppressed, for de novo, if they just have this neuroendocrine differentiation, I tend to just treat the adenocarcinoma component and wait till they really relapse, because it's not going to make a difference. And again, it's so rare at that early stage that you're better off just taking care of the adenocarcinoma component.
I would like to add something here. When we use a terminology adenocarcinoma with a neuroendocrine differentiation, this is largely a very ambiguous diagnosis. These are the cases where we have put, it's a high-grade adenocarcinoma, and we have put the neuroendocrine markers inadvertently, because any high-grade adenocarcinoma will give some amount of neuroendocrine differentiation, and we end up writing poorly differentiated adenocarcinoma with neuroendocrine differentiation. Yes. First and the foremost is to go with morphology. Small cell carcinoma will have a very characteristic morphology, and and even less than 5% is significant.
Yeah, I mean, unless you have this.
I think any
with neuroendocrine differentiation is something which should not be used according to the WHO, because if you put you use zenaptochromo in any prostatic adenocarcinoma, with the lowest grade to the highest grade, they show some kind of a positivity. So the NED, that confuses the uro-oncologist and urologist to an overtreat, and those are basically acinar tumors with some neuroendocrine granule. They haven't transdifferentiated to a AR-independent RB mutated pathway. So I would not use that terminology.
Okay, can I clear this?
This has come up like 5 times today. And it is a little confusing.
And it is not only in prostate, in
This is
lung,
every organ.
in
Every
other
organ is a
organs, the
glandular
same
tumor.
problem comes.
And partly it is created by clinicians who think that this patient is failing and that the pathologist has missed neuroendocrine. So let's make sure that all pathologists know how to diagnose small cell carcinoma. And if they don't say small cell carcinoma, don't bother them by asking them to do neuroendocrine. That's the message. There's a message for everybody. I'm trying to be, because it's come up so often today. And it's one that actually has begun because the clinicians have figured out over time that there are some transdifferentiation cases, and that if there is neuroendocrine differentiation, perhaps you start platinum therapy, right? So given the state, and it has been made very clear, but you take 100 prostate cancers that are Gleason 7 and above, 60% will show some chromogranin and synaptopathy.
Absolutely, that's right. Yeah.
So when you do that stain without, and then the pathologist has done the stain, so then you're going to say...
That's right. That is what... That is why we should be judicious. We should get the morphology first. And many times it has happened that your small cell carcinoma may not even express anaptophysin.
Yes. Yeah.
But if the morphology is true to a small cell and you have a very high Ki, almost reaching more than 80%.
And here actually
helps you to come to a diagnosis.
Here actually one thing I would like to very emphatically add, and if it's a de novo versus a treatment naive setting, or it is a post-treated setting, and I usually ask 4 questions to my oncologist. Is the PSA in a declining trend? What is the PSA level? It's close to 0. Do you have osteolytic metastasis in addition to osteoblastic metastasis? Third question, how long has been the tumor is there with the patients and you have treated those patients? And if I get, and bulky visceral metastasis, if I get a yes answers to all, despite, even if my synapto is not behaving, I have a typical small cell carcinoma histology, I'll call it as a mixed tumor or a pure small cell carcinoma.
I think most important point is you must correlate with the morphology.
So I just want to share my experience from the Prostate Cancer Foundation. I think very nice narrative, Raj, obviously. And so the PCF, about 2 years back, the Prostate Cancer Foundation in their Carlsbad meeting put together a neuroendocrine analysis working group, and there are about 15 pathologists, clinicians involved. I'm also a member of the analysis working group. And it was essentially addressed, that working group was put together to essentially resolve the questions what we are talking about right now. So the first study, the first paper and the recommendations I think are just out now in clinical cancer research. It's on PubMed. I think people haven't seen it because this just came out like 3 weeks back. But at least for patients with treated metastatic CRPC, any patient who undergoes biopsy, now there is a formal recommendation from that group to perform at least 3 stains on IHC, irrespective of the morphology. And the stains are Ki67, at least 1 neuroendocrine marker and androgen receptor. The rationale being that once androgen signaling axis becomes dysfunctional, the morphology and the immunohistochemical expression and the tumor biology are going to get discordant. The morphology is going to follow IHC and the neuroendocrine marker expression only in cases which have a functional intact androgen signaling axis. Yeah. Once that axis is deranged, morphology is not going to be able to predict unless it's a poorly small cell carcinoma. But about 20% of CRPCs are going to show lineage resistance as a mechanism for the therapy resistance. And that is actually the 20% cases which are being talked about. What are these trans-differentiated cases? But now there's a formal recommendation to do, and I think this is going to help further. It's not the final definitive answer, but I think it's going to help enrollment in the clinical trials.
I think this is true more for a large cell neuroendocrine carcinomas, wherein they have recommended, I think, minimum of 2 IHCs.
That's a different ballgame. This is essentially for any CRPC patient who undergoes a biopsy, I think.
So the question, Rohit, is that, so how do you deal with those cases that are not morphologically not neuroendocrine and expressing neuroendocrine marks? How are you going to put that in your report?
So exactly. So there are recommendations in that study in clinical cancer research now, like how to call those. Like there are poorly differentiated carcinomas with neuroendocrine features. It is not the final answer. The reason for doing this or having this approach is to be able to help to club patients better for future clinical trials.
and also how pathologists can actually formalize the reporting.
So
Yeah.
in my institution, I've been doing it for the past 2 years, just to clarify and to avoid confusion to the clinicians. In these cases, I call them as adenocarcinoma with synaptophysin or with chromogranin positivity. That's it.
Yeah.
I avoid the word
And that is
neuroendocrine
okay, and that is
confusion.
okay. But I mean,
I think, may I make one point?
Yeah.
So I think for practicing pathologists, an important point to keep in mind is that if you have a poorly differentiated tumor showing diffuse PSA expression, it is not likely going to be a high-grade neuroendocrine carcinoma. Very unusual for a high-grade neuroendocrine carcinoma to show diffuse PSA expressing markers. So in that setting, if you have a neuroendocrine markers expression, that is not going to be clinically relevant. Yeah, because the AR is typically down-regulated.
I mean, I have seen small cell carcinoma with also a good AR staining. I mean, AR staining per se, IHC is not very reliable alone. And what Rohit said, it's something on the pathway, because if you are trying to enroll more and more patients into the protocol in a metastatic castrate-resistant setting, so doing the stain, the 3 stains is basically trying to enroll more. And secondly, they are probably in the pathway of transdifferentiating to a full-blown small cell carcinoma phenotype.
We actually have a study on this. We compared synaptochromo and the new marker INSM1, and INSM1 actually performed better than these 2 other markers.
Yeah.
I would prefer in that they have the similar sensitivity and specificity as synaptophysin. I would say synaptophysin and old day stain is performed well. I mean, across the organ system. INSM was good when it was started, but it is losing its sensitivity, specificity. It is positive in a lot of other cells actually.
Sir, as a clinician, if the PSA is normal when a patient progresses, is there any other tumor marker that we can use to assess neuroendocrine differentiation? I have seen some reports of chromogranin being used. Serum chromogranin, not the IHC chromogranin. So serum chromogranin, when the PSA is normal and the patient has progressed, instead of doing a rebiopsy, many patients are very reluctant to undergo rebiopsy. So the role of monitoring serum chromogranin level to assess the
So basically serum chromogranin mostly it's in a high grade neuroendocrine, I don't think so that it will rise that fast. Mostly it's for a well differentiated low grade tumor. So I usually don't consider so if clinical picture is going towards that, no PSA rise, non-PSMA expressing liver lesion is there, even patient is not very keen for get a FDG PET. If that FDG is positive, practically it's a small cell if he is not willing for biopsy.
Thank you, sir.
Thank you. Thank you so much. Now I quickly call upon our next speaker, Dr. Rohit Mehra. He would speak about molecularly defined renal cell carcinomas. Dr. Rajil, I think you should be on the stage.
Thanks to the conference organizers, Sambit and the session chairs for having me here today. So I'll be talking about molecularly defined renal cell carcinomas. I do have 2 cases. I don't know how much time I might take on the first one, so I think we'll just have to see. All right. So all of us are aware of the intense morphologic diversity in between different renal tumors. So these are all attested, WHO-attested renal cell carcinoma subtypes. And I think if anyone is practicing GU pathology here, which I believe most of the audience is, so these are all WHO-attested renal cell carcinoma subtypes, and we know how different they look under the microscope. All of these tumors are distinctly different, and the questions we can begin to ask are, what are we seeing under the microscope? What are the underlying, what are the underlying pathogenetic mechanisms? What are the origin of these tumors, and how can we utilize this information to facilitate clinical diagnostics research, and obviously what are the patient level implications?
sharing.
All right. So I firmly believe that kidney cancer is a metabolic disease, and there are at least 12 studied genes known to cause kidney cancer, which are listed in this box, which include VHL, MET, folliculin, FH, genes of STH complex, MITF family genes, and the mTOR P3 genes. And each of these genes is involved in the cell's ability to sense oxygen, iron, nutrients, or energy. And Wahlberg effect still plays a very important role in kidney cancer pathogenesis. These genes are actually implicated in kidney cancer currently, both in a germline fashion and in a somatic fashion. Actually, if we look at our WHO classification of renal cell carcinoma subtypes, even the most common renal cell carcinomas like the clear cell RCC, papillary RCC, all have very distinct genomic signatures. So essentially, the WHO classification of renal cell carcinoma is a molecular-based classification. Either there is an aberrant molecular pathway or a particular genomic mutation which is present, but more or less high majority of renal cell carcinomas do have a definitional molecular event. We know this for clear cell RCC, papillary RCCs, a majority of chromophobe renal cell carcinomas, and then of course we have the newly discovered or newly recognized entities as well. The WHO has used the nomenclature of molecularly defined RCC for these particular tumors which involve rearrangements of the genes like TFE3, TFEB, ALOC, FH, SDH, ALK, or SMARCP1, and the reason is all of these RCC subtypes actually require a specific molecular assay to be able to faithfully and confidently diagnose these molecularly defined renal cell carcinomas. So while these tumors are so-called molecularly defined RCC, actually the majority of rest of the main renal cell carcinoma subtypes also have molecular or distinct and specific molecular signatures. When evaluating a kidney biopsy or resection for a particular tumor, I think it's important to remember that several non-primary renal processes can involve the kidney, which include urothelial carcinoma, melanomas, systemic tumors, as well as lymphomas. And within the renal cell carcinoma subtypes, we have now being able to very distinctly and accurately stratify tumors into the clear cell RCC, non-clear cell RCC, syndromic RCC, aggressive RCC subtypes, and there are still those tumors which we cannot really categorize into one of the well-recognized entities, and these are the ones we call them RCC unclassified or NOS. And the reason for this stratification at the pathologic level is that now there are management algorithms which are beginning to diversify for all these different renal cell carcinoma subtypes which have been listed over here. So actually there are quite a few clinical trials now which are focusing on non-clear cell renal cell carcinoma subtypes. So I think it becomes very important for us as pathologists to be able to accurately categorize the renal tumors so that these patients can be enrolled into molecularly informed and the correct clinical trials. And again, this is like a snapshot of where the therapeutic algorithms stand today as we talk about renal cell carcinomas. And while more or less they are similar, but still there is a distinct granularity now in between different renal cell carcinoma subtypes. Also, the sequencing of these different therapies is different. So actually, we are now able to tailor therapy for different venous cell carcinoma subtypes separately, and that is the reason we are having this conversation today. There has been a tremendous outpouring of molecular data from different bodies all over the world. For example, the TCGA, CPTEC, TracerX. There is this single cell sequencing data, and we are able to perform this very unique cell of origin analysis where we are now able to look at what is the cell of origin within a nephron for a particular renal cell carcinoma subtype. And all of this has really enhanced our insight into RCC pathogenesis as well as treatment. So this is my first case today of a 68-year-old male patient with a previous history of prostate cancer who recently presented with hematuria, abdominal pain, hypertension. Concurrent imaging showed lung and liver lesions, and there was also a 12.2 centimeter right renal neoplasm which was biopsied. This is the low power view, and I think, I hope all of you will agree, we can see the background renal tubules which are entrapped, and actually this is the first thing which caught my attention when I was reviewing this biopsy, that the background renal tubules are actually prominent. And then the neoplasm has a tubercular to solid architecture, and this is a high-grade tumor with clear cell and eosinophilic features. And my first differential which I thought of was this could possibly be another high-grade clear cell renal cell carcinoma. Again, we can see the admixture of clear cell and eosinophilic features. One feature which we do not see every day is this intranuclear inclusions, and there is some significance to these inclusions in this case, and I'll come back to it. The tumor did show nuclear anaplasia. So the possibilities I considered was this could be a high-grade venous cell carcinoma, it could be a distal nephron-based high-grade malignancy, it could be still an epithelioid pecoma, other high-grade malignancy, and of course this could be a process which could be related to the patient's original prostate cancer. So I worked up this tumor which was positive for Pathstate, pan-cytokeratin, negative for CK7, CA9 expression. The tumor was diffusely positive for CD117 as well as melanase expression by immunohistochemistry. In our clinical RNA-ish IHC lab at University of Michigan, we have this new biomarker which is actually a discovery from our department and our lab, and this is a gene called TRIM63, and this is an RNA-ish based assay. So these brown dots we are seeing is actually the RNA transcript of TRIM63. So actually we are visualizing the RNA or TRIM63 RNA transcript itself directly under the microscope. This is the power of this technology. So the tumor was positive for TRIM63 by RNA-ish. I haven't shown images, but the prostate cancer markers were negative. And because of Pathstate pan-cytokeratin positivity, we were able to rule out melanoma and epithelioid AML. And with the positive Pathstate CD117 pan-cytokeratin expression, negative P63, I considered this to be a primary renal malignancy. And with the TRIM63 and melanase expression, the first possibility based on the morphology and biomarker workup was of a MITF-TFE family altered renal cell carcinoma. So I rendered an initial diagnosis of renal cell carcinoma with morphologic and biomarker features suspicious for MITF family altered RCC. And in communication with this patient's urologist and medical oncologist at my hospital, we recommended FISH testing for this patient. So FISH for TFE3 and TFE-B gene aberrations is currently offered as one of the clinical assays at University of Michigan Hospital, and this assay is available at most of the tertiary centers across the world. And FISH analysis for TFE3 and TFE-B genes showed the tumor was negative for TFE3 rearrangement, but it was positive for a high-level copy number gain of TFE-B locus, thus indicating a 6P amplification. So based on the FISH findings, I was able to render a final diagnosis of TFE-B amplification associated renal cell carcinoma, and then the patient was started on off-trial pazopanib, which is a tyrosine kinase inhibitor. So the patient initially had a good response with significant reduction in primary renal mass as well as the metastatic disease, but the subsequent chest X-ray, perhaps 2 or 3 months later, showed near complete opacification of the right hemithorax because of the metastatic spread, and the patient was passed on to comfort care. So this is my current perception of MITF renal cell carcinoma, which I believe includes tumors with TFE3 translocation, TFE-B translocation, as well as those renal cell carcinomas with a high-level copy number gain of TFE-B locus, which is, and these are the tumors we call as TFE-B amplified renal cell carcinoma. So the MITF family genes regulate gene expression and differentiation in melanocytes and osteoclasts, and this is the reason that actually when MITF family genes are overexpressed, the melan A, cathepsin K, and other similar downstream pathway genes are overexpressed in patients who have renal cell carcinomas with TFE3 or TFE-B gene aberrations. And both gene fusions and gene amplifications result in TFE3 and TFE-B overexpression. And these are essentially, okay, I'm not sure what I'm doing. And TFE3 and TFE-B are oncogenes, and once they are overexpressed, these will lead to carcinogenesis. So the TFE3 renal cell carcinoma can easily overlap with clear cell renal cell carcinoma, clear cell papillary renal cell tumors, and other RCC with papillary features. Let us review this renal tumor. Here we can see the background renal parenchyma. Even at low power, we can see the papillary architecture for this tumor. And the high power view shows, again, the papillary architecture, some calcification, abundant eosinophilic cytoplasm, nuclear anaplasia, nuclear pseudostratification. This is actually a perfect fit for the so-called erstwhile type 2 papillary renal cell carcinoma. But actually it is not, because this is an example of a TFE3 altered renal cell carcinoma. TFE-B RCC tend to have a biphasic morphology with generally melanine overexpression. And this is a biphasic tumor because we have these cells with clear cytoplasm surrounding these smaller cells with more dense eosinophilic cytoplasm and perhaps with some basement membrane condensation. This is actually an example of a TFE-B translocation RCC, but this closely mimics clear cell renal cell carcinoma. So I think in a busy GU sign-out practice, I think it's easy to sign out this case as a clear cell renal cell carcinoma because of the racemose vascular network, but actually this is an example of a TFE-B translocation RCC. And the clue is perhaps more disorder in this tumor than what we might encounter in a high-grade clear cell renal cell carcinoma. The TFE-B amplified RCC have been more recently defined. These tend to happen in the elderly, and they're defined by more than 10 copies or more per cell in at least 10% of the cells on FISH evaluation. Again, these tumors can closely mimic high-grade clear cell renal cell carcinoma. This is again an example of a TFE-B amplified renal cell carcinoma, but because of the racemose vascular network, actually looks like a high-grade clear cell renal cell carcinoma. This is the morphology which I find relatively specific for TFE-B amplified RCC and perhaps some other MITF RCC as well, which is the high-grade oncocytic and papillary features with some linear array of nuclei away from the basement membrane. So whenever I encounter this histology, I tend to work up the tumors for a possibility of MITF RCC. This is a tumor which was sent to my consultation practice earlier last year, and this was initially diagnosed as a chromophobe renal cell carcinoma, but someone accidentally performed a melanine staining on this tumor. It was strongly positive, and then they sent it out for consultation. And actually this is an example of a TFE-B amplified RCC which had some morphologic overlap with chromophobe renal cell carcinoma. So I'm almost getting to my last slides now. So when to consider MITF RCC morphology, I think is a great suggestion. Older age does not rule out MITF RCC. The highest age I have seen is an 88-year-old female patient, with TFE3 translocation renal cell carcinoma. Please do not use pan-cytokeratin ISC as a screening tool for MITF RCC. I've even seen some experienced GU pathologists do that, and I do not think that is the correct methodology. And FISH demonstrates a high degree of sensitivity and specificity. So at University of Michigan, I direct our GU assay or molecular assay development service, and we have performed currently more than 1,000 FISH assays for TFE3 and TFE-B gene abrasions on more than 500 consecutive tumors. We have published the results from our first 800 assays we have done. And this showed that TFE3 and TFE-B rearrangements were never co-detected within the same tumor. The TFE-B amplification cases are significantly older than TFE3 or TFE-B translocation cases, and TFE-B amplification is at least 3 times as common as TFE-B translocation. We have also performed RNA-seq analysis, and I talked about this, how TRIM63 RNA-ish can be very helpful in diagnosis of MITF renal cell carcinoma, and this is positively expressed in all the 3 different subtypes of MITF renal cell carcinomas. Even the FISH elusive or the FISH negative RBM10 TFE3 RCC actually strongly expressed TRIM63. We have been utilizing the TRIM63 RNA-ish as a clinical biomarker for 2 years in our clinical-ish ISC lab, and we are presenting our results at the Boston USCAP in this year. So I think I'll be looking forward to share these results over there, and I hope to see all of you in Boston. Thank you very much.
Thank you so much for that elaborative talk. I'm sure it would be a feast for the students of pathology right here. Any questions?
For the non-clear cell primary renal cancers, do you have a favorite common IHC panel that you do?
Can you pull up my talk? Yeah, I'm glad you asked that question, actually.
Slides.
I think I have a slide. So I think I do have a baseline panel. I do. Yes, I do have a baseline panel which includes CK7, CA9, CD117, PAX8, P63. That's my basic panel. But beyond that, I think I do have a second panel. I don't know if you can. I think it's coming up. Yeah, I think if we go to the last slide of this talk.
So as an extension to her question, sir, for any papillary pattern of RCC, is it necessary that we should always, screen it for a molecularly rearranged? I mean, basically, say a simple papillary RCC, does it not exist anymore? I mean, I'm just asking you.
So this is like for the difficult to classify tumors, this is at least my approach. I have the first tier workup. In the second tier workup, we have all of these biomarkers. And so I think I have the privilege of having actually all of these biomarkers in our clinical survey. So I think depending on the morphology, we can be selective about these. And for institutions which do not have all of these markers, I think it's reasonable to send them out for consultation. Or I think I do keep a third tier workup for molecular testing for tumors, and these are essentially tumors with a metastatic scenario, and also cases which are like difficult to classify, or cases which have a possibility of a germline annotation. These are the ones I will send out for molecular testing. But I think I have a strong academic interest in kidney tumors, so I essentially don't stop till the molecular level is done. I know it's not feasible in every practice model, obviously, but I work in a tertiary practice center where we have this feasibility, so I generally don't stop till I'm able to accurately classify a tumor, or I'm convinced that I'm not able to accurately classify this tumor with the current tools we have, including the molecular testing.
Can I?
Yeah, that is actually, that's a great question. Yeah, that's a great question. I think so. Both TFE3 and TFEB are genes whose proteins are constitutively expressed inherently within the kidney, including the benign parenchyma. So TFE3 and TFEB ISC, I believe, is a very tricky stain. I think if someone has standardized the TFE3, TFEB ISC compared to the background renal parenchyma, and they have done a lot of cases, perhaps more than 100 cases, which are tough to do, I think it's a very challenging stain to interpret. I shared our experience with our FISH service. One of the commonest indications which we have for receiving a case for FISH evaluation of renal tumors is that a TFE3 or TFEB ISC was performed, and then they wanted to know the result, and in majority of those cases, actually, the FISH results are negative. So we actually stopped doing those stains in like 2014, so we do not do them anymore. And I'm sorry, I did not get your papillary question. Can you please repeat that?
Just the fact that the same extension, that if there is any papillary pattern, a simple papillary RCC, which is, do we have to assess it molecularly? And you showed one case which was like that solid oncocytic papillary, which was so close. I had a similar case, and I just called it a solid oncocytic papillary. And should I just work it up molecularly?
Sure. No, I think that's a great question, and I do not want to convey the message that we need to stain every renal tumor. So there are papillary renal cell carcinoma, and there are several different subtypes for which we do not need any stains. And I think those are just canonical papillary renal neoplasms, which WHO has called papillary renal cell carcinoma subtypes. Perhaps there are one or two, like the biphasic squamous alveolar, I might stain that for cyclin D1, and I think that I find helpful in staining amongst the papillary renal cell carcinoma established subtypes. The tumors which I feel, I think it's like, perhaps it's this, perhaps the tumors which do not have like the very well established morphologic features, or features which somehow do not fit well with the patterns which we know are accepted now within papillary RCCs, those are the ones I might work up further.
Can I make one comment, Rohit? Can I make one comment?
We have a question.
Oh, yes.
Oh. No, I don't have a question, but just for the benefit of residents and trainees. So whenever you deal with a clear cell tumor or something in that type of pattern, try to first see whether you have any classical features of clear cell RCC, and what are those. That do you see any low-grade cells forming acini separated by very delicate branching racemose type of vasculature? And that type of area typically you will encounter in low-grade areas, and if those are present, then that is your pretty much a guaranteed diagnosis that you can make a confident diagnosis of clear cell RCC. Second is that when you don't have that type of classical features and you have a high-grade tumor which is difficult to classify as a clear cell or papillary, you can look for other features like, as Dr. Mehra mentioned, intranuclear inclusions, stromal nodules, fibrosis, calcifications, and all those can, I think, when present, I think you can do basic panel like CA9, PAX8, and if tumor is CA9 negative with those features, then you have a high probability that you are not dealing with clear cell RCC, and that can help you guide towards the next step for the workup.
Thank you. Thank you so much. Can you please be on the stage for some time? Now I call upon our next speaker, Dr. Ming Zhu. He'll speak about ductal adenocarcinoma of the prostate.
Well, thank you. So, can you put it on the... Right. So, the patient is a 45-year-old man with a gross hematuria. So, he had urothroscopy, which showed a small the polypoid lesions in the prostatic urethra, which was resected. So, low power, you can see this. The mass is largely is composed of these large glands. And these large glands are lined with tall columnar cells with a stratified nuclei. And so at high magnification, you see the mild nuclear atypia. So what's your diagnosis? But let's look at the differential diagnosis for the papillary lesions that was diagnosed in the biopsies of the prostatic urethra. Basically, you need to consider these 4 types of tumors: papillary urothelial carcinoma, the prostatic tumors, and metastatic carcinoma, which is rare. And last group of the lesions you also need to consider is benign and reactive, including prostatic type urethral polyp, polypoid urethritis, and fibroepithelial polyp, and condyloma. So, but the most important distinction is between these 4 lesions: prostatic type urethral polyp, papillary urothelial carcinoma, prostatic lesions, tumors, and metastatic carcinoma. I think that if you do the 3 panels of these things, prostatic specific markers, urothelial markers, and prostatic basal cell markers, and that can really do the job in tell apart these 4 different type of lesions. So this is an example of the urethral polyp or prostatic type. You can see the polyp is lined with benign prostatic tissue, and which is positive for PSA and also positive for the basal cell markers. So for the atypical prostatic lesion of the large gland pattern, you need to consider these 4 lesions: high-grade ping-like carcinoma, ductal carcinoma, and the intraductal carcinoma. I think the key is to identify basal cells in these lesions. So coming back to our tumor, our case, P63 is negative, PSA is positive, and the CK7 is focally positive, CK20 is the positive. So putting the morphology and the immunostain together, I think the diagnosis is prostatic ductal adenocarcinoma. So let's talk about the ductal carcinoma of the prostate. It is a subtype of the prostatic the carcinoma, and the diagnosis is based on the morphology. You need to see the large glands lined with these tall columnar cells with pseudostratified elongated nuclei. But there is significant inter-observer variabilities in applying this diagnostic criteria, and that may explain the difference in the reported incidence and the clinical outcomes of the ductal carcinoma of the prostate. But the most the important diagnostic feature is this sort of a well-developed the papillary structures lined with these the tall columnar cells. And you may also see this cribriform the architecture, which in the past was referred to as endometrioid the carcinoma of the prostate. You may also see solid component, and sometimes you can see this flat architecture. And this type of ductal carcinoma is also called pin-like prostatic adenocarcinoma. One of the peculiar features of the flat pin-like carcinoma or the ductal carcinoma is the cystic dilatations of these cancer glands, to the point that sometimes you only see strips, not entire glands, in the prostate biopsies. And at high power, these glands actually do not have significant nuclear atypia. So these may lead to the misdiagnosing the flat carcinoma, the ductal carcinoma, as something benign. And the nuclear features ranges from significant nuclear atypia with enlarged nuclei, prominent nucleoli, to really the inconspicuous nuclear atypia. Therefore, the nuclear features are less important than diagnostic features, with the exception that you do need to see these stratified oval or elongated nuclei in ductal carcinoma. And you often see mixed ductal and acinine component in the same lesion. And sometimes you can see this intraductal spread by the ductal carcinoma, and similar to the intraductal carcinoma by the acinar carcinoma. That just indicates that the ductal carcinoma is an aggressive form of the prostate cancer. So ductal carcinoma is often mixed with the acinar carcinoma. Pure form is rare. As I mentioned, it is an aggressive form of the prostate cancer and associated with high grade and high stage, and also it has a high risk, a great risk of the PSA recurrence and mortalities. And the grading is based on the architectural pattern. For the flat pin-like ductal carcinoma is pattern 3, cribriform papillary pattern 4, solid and necrosis is pattern 5. So the ductal carcinoma is listed as the prostate cancer subtype in the current the 2022 WHO Blue Book, but there has been discussion to transition it to the histological pattern rather than a subtype of the prostate cancer for the reasons listed here. So for our case, again, the diagnosis is ductal carcinoma, right? So after diagnosis, the patient they had a radical prostatectomy, and which they really revealed no residual the carcinoma in the prostate gland, which is very surprising to us because we sort of expected a fair amount of the residual carcinoma in the prostate gland. So what happened? Why? How could we explain this discrepancy? So I think the answer lies in the fact that ductal carcinoma, depending on its location in the prostate gland, peripheral versus central, can have a different biology and clinical presentations. So if the ductal carcinoma is detected in the peripheral zone of the prostate cancer, it is invariably associated with high grade and advanced stage the prostate cancer. So you will see the prostate cancer with a ductal morphology and with these tall columnar-shaped cells and the stratified cells, the nuclei, and you may also see intraductal spread. On the other hand, the central type of ductal carcinoma is found in and around vermontanum. So it presents as the exophytic polypoid lesions, which is diagnosed on the transurethral resection or biopsy specimens. So majority of these central type of the ductal carcinoma is still associated with the aggressive acinar carcinoma, and it represents the spread from the peripheral zone, high-grade the prostate cancer into this central location. But minority of these cases, they're small and without concurrent adenocarcinoma. They may represent a in situ or a lesion involving these large periurethral ducts. So following this case I just presented, we had another case. The patient they had a diagnosis of ductal carcinoma in the transurethral resection of a urethral polyp, but the follow-up transurethral resection was negative for the residual carcinoma. So these two cases actually prompted us to do a study of the ductal carcinoma diagnosed on the transurethral biopsy or resection. And we found that the majority, over 90% of the ductal carcinoma diagnosed in the TURP and or the biopsy, the specimens represents aggressive disease. However, about the 10% of them actually represent the in situ or low-grade prostate cancer involving the periurethral large glands, and these the tumors can actually be eradicated by repeat biopsy or TUR alone without the radical prostatectomy specimens. So fast forward 13 years, in 2022, Dr. Epstein reported a cohort of 13 cases of the ductal carcinoma. The 6 of them were actually diagnosed on the transurethral resection or biopsy, and 1 of them had no residual carcinoma in the repeat biopsies. So these are the studies and they have a very important therapeutic implications. That is, if the ductal carcinoma is diagnosed on the transurethral resection or biopsies, in a patient should be recommended to undergo follow-up TURP and a prostate biopsies to confirm the presence of extensive disease before the definitive treatment, such as the radical prostatectomy, is offered. So, in summary, the ductal carcinoma is a subtype of a prostate cancer so far, and it is often associated with aggressive biological behavior. And there are 2 types: the peripheral versus the central type. Peripheral type, as I mentioned, is always associated with high-grade and advanced stage adenocarcinoma. However, central type, when it is diagnosed on the transurethral resection or biopsy, may represent a in situ or low-grade prostate cancer. And it can be eradicated by biopsy, repeat biopsy, and transurethral resection. So these patients, again, should be recommended to undergo follow-up the transurethral resection and prostate biopsy before they are offered the radical prostatectomy.
Thank you. Thank you so much. Now we proceed towards any questions? Any questions?
Since there was no tumor on the radical, the biopsies, 16 biopsies or the 12-4 biopsies were also done in that case. They were negative.
Sure. Yes. They were not radical. These patients were, just had the repeat biopsies or transurethral resection. And in those repeat specimens, there were no residual cancer.
Ming, can I make one comment?
Yeah.
Yeah, so I completely agree with you in terms of location, peripheral versus central. But at least in our experience, what we are seeing is that central with peripheral involvement, that is the prototypical form of ductal adenocarcinoma, which is associated with high volume, low PSA. They are associated with DNA repair gene defects and P13 kinase pathway alterations.
You see that in 90% of the cases.
While only peripheral involvement appears to be a biologically different disease, which is often associated with acinar adenocarcinoma, as you suggested. But that one is usually not associated with DNA repair gene defects.
There's some, even there's some study that suggests that ductal carcinoma may have the genetic the alterations that are different from the adenocarcinoma, but the studies or the findings are mixed.
Yeah. One question from the audience. That should be the last one, I guess. Mike.
My question is regarding radical prostatectomy specimen. If you find ductal differentiation in radical prostatectomy specimen, when to label it as a adenocarcinoma SNR with ductal differentiation? What percentage is required to label as a ductal differentiation? That is one thing. And second is how whether it makes any difference on post-radical prostatectomy follow-up and therapy.
Sorry, it's very difficult for me to hear the questions.
Yeah, it was not clearly audible. Can you please come again?
Yeah, if you can.
My question is regarding in radical prostatectomy specimen, how much percentage is required to call it adenocarcinoma SNR with ductal differentiation? That is one thing. And second, whether it has any implication on post-RARP management. RARP management.
Post-radical prostatectomy post-surgical management. Does it have any implication?
On post-RARP management.
Post-radical surgery management.
Yeah, so the question is, if you see the ductal component in the radical, right, how much do you need to see, right? I think in the WHO, the Blue Book, it says 25%, right? So if you have a mixed SNR and the ductal the carcinoma, if the ductal component is more than 25%, and then you can call it it's a ductal carcinoma. Otherwise, if it's less than 25%, or in the biopsy or the TRP specimens, you don't call it ductal carcinoma. Instead, you call it prostate cancer with ductal features, right? In terms of the post the radical prostatectomy management. So, I'm not sure that if there's any difference, right? So, the other than the managing it and based on the Gleason scores. So, any comments from?
Yeah. Yes, Shailesh bhai, I think so. Basically, the way I kind of is that if I see only ductal differentiation, I report that as a ductal adenocarcinoma. And in my experience, pure ductal adenocarcinomas are the one which are biologically very aggressive tumors. They have more central and peripheral involvement. But if I see ductal with clear-cut SNR component, then I would call SNR adenocarcinoma with ductal differentiation. And those in our experiences tend to be more peripherally located tumor. I believe there is no obvious difference in treatment, but often the one with that pure ductal with central and peripheral involvement, they tend to be not surgical, good surgical candidates, and those are the ones showing more DNA repair gene defects, higher tumor mutational burden, and can be potentially benefited from more aggressive treatment like PARP inhibitors and other things. We have recently did a study on that, which I will present tomorrow, and maybe hopefully we can have more discussion.
Thank you very much. Now I please call upon our next speaker, Dr. Gladale, to take over the next topic, endophytic tumors of the urinary tract.
Thank you. So before I start chasing the clock here, so I'm tasked to talk about endophytic tumors of the urinary tract. But to be clear, we call it tumors, but with the exception of inverted urothelial papilloma, this is really a pattern of growth, all right? These are not distinct tumor entities. And second is that for the past decade, there's really a paucity of literature on this subject. So for the benefit of the general pathologists here as well as trainees, I'm gonna focus or zoom in mainly on the morphologic diagnosis of these entities. And I'm gonna present it in a way of cases of these different entities. So I'll start with the basic, very simple tumor in this category. This is a 67-year-old male, underwent TUR, and it was described clinically as a large, quote-unquote, large mass. But as you can see here in this, in the histology, there's proliferation here in the lamina propria, and you can see one word that you have to remember, consistency. The consistency is there, and it basically shows thin trabeculae. On high power magnification, you see now this peripheral palisading, the classic features, and then a peripheral palisading, and then the central streaming of cells. And again, I'd like to reiterate, it has this thin trabeculae. On high power magnification, you see the cells are bland appearing, low grade. They have this ovoid nuclei with no atypia, no mitosis. So the diagnosis is inverted urothelial papilloma. Now, before I delve into the inverted neoplasms, I would start by explaining first for correlation. I would start explaining the exophytic, the papillary urothelial neoplasm, and then how to correlate it with the inverted growth. So in the WHO tumor categories for the flat, we have two options there. Dysplasia CIS for the papillary tumors, we have these 4 categories, and it's important to distinguish these 4, although pan-lump is controversial at this point. Is because of the differences in progression as well as in recurrence. So progression, urothelial papilloma, it's basically benign, and as you can see, the increasing rate of progression and recurrence as we increases the grade. Now, we codified this back in 2012 in the International Consultation of Urological Disease headed by Dr. Amin, and I really like this approach. It's kind of simplified thing. So this is a morphologic analogy, morphologic. This is not a biologic analogy or clinical analogy. These are completely different terms in terms of pathobiology and clinical significance. But in terms of morphology, they correlate, and it kind of make it easy to remember. So for the normal urothelium, it correlates with papilloma morphologically, hyperplasia with pan-lump, dysplasia with low-grade papillary carcinoma, and then CIS with high-grade papillary carcinoma. So if we conceptualize this, if we have a benign, normal-appearing urothelium, put it in a papillary core, you have a diagnosis of papilloma. If you have hyperplasia-appearing urothelium, you put it in a fibrovascular core, now you have pan-lump. It's easy to remember, right? So what's the difference between papilloma and pan-lump? Basically, you have thickening of the urothelium without the atypia, right? Both of them. Now, dysplasia, controversial entity, but if you put it in the papillary core, it simulates the morphology of low-grade papillary urothelial carcinoma. And of course, CIS, if you put in the papillary core, it becomes a high-grade papillary carcinoma. Again, this is just morphologic analogy, but it's easier to remember this way. Now, we have to keep in mind that high-grade papillary carcinoma is a spectrum, right? That's why we have a grade 2, grade 3 back in 1973, so we have to keep that in mind. Now, when it comes to the endophytic tumors, it's just the same. Classification is the same. We just look for this inverted growth. Now, what is inverted growth? So inverted growth basically is the non-invasive spread or growth into the lamina propria. Characteristically, it has this rounded contour and sharp epithelial stromal interface, no desmoplasia, and it's very, very important not to misdiagnose this as an invasive tumor. So going back to inverted papilloma, why we have this thin trabeculae, why we have this central streaming and peripheral palisading, it's because we're basically looking at 2 urothelium opposed to each other, so it's going in, and it proliferates downward into the lamina propria. That's why we have this pattern. And that, if you can imagine, these are basically 2 layers of epithelium opposed to each other. The central streaming represents the umbrella cells, the surface cells. That's why we have this classic patterns of urothelial papilloma. So once we have thickening, going back to pan-lump in exophytic tumors, if we have this hyperplasia appearing urothelium or thickening, then we exclude papilloma. So, diagnosis of inverted papilloma is morphological. There are some genomic features that are missing in inverted papilloma, like the genomic features of urothelial carcinoma, but you have to be careful. Like TERT, for example, it was also described in papilloma, and actually it can be seen in benign urothelium, as Rohit earlier said. So let's go to another example. This is a 46-year-old male with a 3.5 centimeter bladder mass, and you can appreciate now this inverted pattern or growth. Sharp demarcation, no desmoplastic response. You can see there regular contour of the urothelial nest. Now when it comes to higher magnification, you can see this, the nuclear ovoid, lack of mitosis. Some of them are rounding, some of them have discrete chromocenters. So for me, I would call this as a low-grade papillary urothelial carcinoma. Some of you may agree, we may call it a pan-lump. but for me, this is a low grade. It's a non-invasive. It comes to grading. So how do we grade it? Basically, we grade it exactly the same as the exophytic papillary urothelial carcinoma. We basically follow the same criteria. Now for the third case, so this is a 74-year-old female, multifocal bladder tumors, the largest 2 centimeters. This is from the largest piece. And again, you can appreciate there this endophytic growth into the lamina propria. Note the central streaming peripheral palisading. You can also see in higher grade tumors. Closer look, you can appreciate that this thickening here is too thick for inverted papilloma. On higher power view, you can see there abundant mitosis, pleomorphism. So this is and also this has an exophytic component, which is not uncommon to see in this papillary urothelial neoplasm with inverted growth. It's present here, and it shows high-grade features. So this is a high-grade papillary urothelial carcinoma with inverted growth. And for the last 2 minutes, I'm going to also, first of all, before that, what is the clinical significance for our clinicians? What is the clinical significance of inverted growth of papillary urothelial carcinoma? So nothing. Similar grading, staging, risk stratification, and management with exophytic papillary urothelial neoplasm. In fact, the terminology at this point, it's not required to report. It's not even standardized. But it's really a problem for us, for the pathologists. This may cause diagnostic and staging issues. There are some papers suggesting for the last 2 decades that this inverted growth may be associated with mismatch repair protein loss, MSI, or Lynch syndrome, especially in the upper tract. But this is also contradicted by more recent studies. So we all know how to make a diagnosis of invasive urothelial carcinoma, but just to show the contrast of invasive versus inverted growth. And this is a case 4. I'll just run through this in a minute. So this is a 66-year-old male with history of high-grade TA. 5 months later, have recurrence. It shows multiple areas of fluorescence on TUR. And this is the TUR chips. So this is one fragment. It shows kind of this downward proliferation into the lamina propria. Let's zoom in on this area right here. You can see some large nest of urothelium with rounded contour, desmoplastic response into the lamina propria. Let's zoom in this area. It shows clearly high-grade features, although some of the cystitis cystica-like structures have a lower grade appearance. In other areas, again, you see this downward proliferation. And then zoom in here, you see that high-grade appearance, and then some structures like cystitis cystica is present there. In some areas, again, you see this proliferation. In a closer magnification, you can see some Brun's nest. In other areas, you can see cystitis cystica. I just want to point this out as a differential diagnosis because staging here is important. So this is CIS extending into the Brun's nest. In a fragmented specimen, it can be mistaken as inverted growth. And as we know, clinically, in risk stratification, this is very important. TIS is different from TA. We have to make a good distinction. If it is if this CIS there is concomitant with, say, a high-grade TA or T1G, it would be categorized as very high risk. And we know for the Europeans, if we have a very high risk, then if you look at the treatment management, radical cystectomy is a consideration. So we have to keep this in mind, okay? So be aware that of this pitfall that CIS can go inward into Brun's nest, and it can mimic this inverted papillary carcinoma. Not only that, it can also go into cystitis cystica, as you can see there, and cystitis glandularis. And that's my last slide. Thank you.
Thank you. Thank you so much. Any quick questions? Okay. We can move towards our, so can you be please seated on the stage? So can I please call upon Dr. Jasriman Dillon for the next talk, non-epithelial tumors of the penis.
Okay. So I'll start with case 1. This was a 58-year-old male. He had a penile biopsy from a crusty lesion. And this is the photomicrograph of the biopsy. You have squamous mucosa, which looks little crusted. There is hyperkeratosis. As such, at this power, I do not see any dysplasia within the squamous mucosa, and there's a little bit of subepithelium present along with it. And little higher power, where you can appreciate the squamous mucosa showing no penile intraepithelial lesions, but there is hyperkeratosis, maybe reactive changes. And then we draw our attention towards what's happening in the subepithelial connective tissue. And this is the high power view where you can see capillary-sized blood vessels which are proliferating, which are lined by endothelial cells that are plump. And some of these vessels are clogged with red blood cells. And basically, what are we dealing with, right? Looks like a little vascular lesion. So my differential diagnosis here is it a hemangioma? Is this cellular angiolipoma or pyogenic granuloma? So we did some immunohistochemical stains. The lesion was negative for CD31. The native vessels were staining for CD31, but the vascular proliferation that we saw did not stain for CD31. So did the second stain, ERG. ERG was diffusely positive in native vessels as well as the little vascular spaces that we saw. So if we go back to the histopathological assessment, to call it hemangioma, I would like to see little fibrin thrombi, which would help me with that. We did not see any. For cellular angiolipoma, again, presence of fibrin thrombi would help. There were none. It was not encapsulated, and there was no adipocytic component to it. For pyogenic granuloma, we would like to see lobular architecture, which this lesion did not have. And there was really not many numerous neutrophils, which I would like to see. So let's go back and analyze our stains. So what does ERG stain? ERG stains the endothelial cells of veins, capillaries, and lymphatics. CD31 stains endothelial cells of veins, capillaries, and can also stain endothelial cells of lymphatics, but may be negative in that. So to confirm if these endothelial cells were lymphatic, we did D240, and the lesion was diffusely positive for D240. So now we have a vascular lesion, which is comprised of small blood vessels, which are filled with red blood cells, showing lymphatic differentiation. So what could be the diagnosis here? Okay, that's a good possibility. So what we did is, this was, one of the other diagnoses could be Kaposi's too, right? It has, it does show lymphatic differentiation as well if you do the immunostains. But the morphology is very odd for it, right? There are no spindle cells, no slit-like vascular spaces that we are classically taught about. And however, when we did HHV8 staining, it was diffusely positive. So this is the angiomatous variant of Kaposi sarcoma. Okay, and how do you differentiate a Kaposi from hemangioma? ERG will be positive in both. CD31 will stain endothelial cells of hemangioma, but will be either negative or weakly stain the endothelial cells of Kaposi sarcoma. D240 will stain Kaposi sarcoma, but will not stain endothelial cells of hemangioma. HHV8 is very important stain, which will stain endothelial cells of Kaposi sarcoma and will help clinch the diagnosis. So before we gave the diagnosis of Kaposi sarcoma, we decided to check the history of a patient if the patient was HIV positive or negative. This patient was HIV negative. Serology was positive for HHV8, and patient had history of multicentric Castleman disease. So So what's the relation of multicentric Castleman disease with Kaposi sarcoma? Kaposi sarcoma has been reported to occur in association with multicentric Castleman disease. It could be a consequence of immunosuppression, which is caused by MCD itself, or it could be a manifestation of MCD. So multicentric Castleman disease should be kept in mind in a patient with Kaposi sarcoma who is HIV negative. This is the second biopsy which was performed from a separate penile lesion, which showed more a classic histomorphology, where you can see slit-like vessels which were lined by these short spindle cells. So this patient, as I mentioned, PCR was positive for HHV8. Patient was HIV negative, and unfortunately passed 3 months later due to acute hypoxic respiratory failure. So I'll move on to case 2. This is a 33-year-old male who presented with firmness in glands for 1.5 years. It gradually became painful, difficulty in urinating, and the excision of the mass was done. So this is the low power view where you can see it has a squamous mucosa, and it looks very proliferated in the subepithelium. And on high power, you see these cells which are epithelioid to short spindled with moderate amount of eosinophilic cytoplasm. And here again, you can see the cells were infiltrating all the way till the corpus spongiosum. Again, the morphology is very similar, epithelioid cells, pink eosinophilic cytoplasm. The lesion recurred after 6 months and glandsectomy was done. So I'll show you more microphotographs of the lesion. It's composed of epithelioid cells, round nucleus, prominent nucleoli. Some of them are short spindled. And another one. So we have a big list of differential diagnoses here. It could be rhabdomyosarcoma. It could be metastatic melanoma or primary melanoma. It could be metastatic renal cell carcinoma with rhabdoid change. Squamous cell carcinoma is most common. I would like to keep that in my differential. It could be sarcomatoid squamous cell. Epithelioid sarcoma, epithelioid hemangioma, and epithelioid hemangioendothelioma were other differential diagnoses. So we did immunohistochemical stains. This lesion was positive for pancytokeratin and strongly positive for vimentin. And it was negative for melanoma markers like S100, HMB45, melan-A. Desmin was negative, so rhabdo is excluded. INI1 is retained, so epithelioid sarcoma excluded. P40 negative, PAX8 negative. So it's not a squamous cell cancer, it's not metastatic RCC with rhabdoid morphology. Now if you look at the non-epithelial penile lesions, vascular lesions form 1/4 of the lesions that was reported in this article. So we did ERG. This tumor was strongly positive for ERG and was also positive for FOSB. So this is the immunoprofile that we had, and molecular study done showed fusion of SERPINE1 and FOSB gene fusion. So a diagnosis of pseudomyogenic hemangioendothelioma is made. This is an interesting vascular lesion in the sense it does not form any vascular spaces, it does not have any intracytoplasmic inclusions, and yet it is a vascular lesion. So this is also called epithelioid sarcoma-like hemangioendothelioma. It is a vascular neoplasm of intermediate biologic potential, has indolent low malignant potential with predilection for extremities in young adults. Rare case reports of primary penile tumor have been reported. Frequently, it can show multifocal presentation. Co-expression of keratins and endothelial markers is common, and SERPINE1 with FOSB gene fusion is diagnostic alteration. Has to be distinguished from epithelioid hemangioma, which can also have strong nuclear positivity for FOSB, but the fusion gene is different in epithelioid hemangioma. For epithelioid hemangioendothelioma, PHOS-B is negative and gene fusions are again different. The clinical presentation can be very similar to epithelioid sarcoma in the sense both of them occur in young adults and involves the soft tissue of the extremities. However, in epithelioid sarcoma, INI1 is lost, whereas it is retained in pseudomyogenic hemangioendothelioma, and gene fusions again help with the differential diagnosis. Thank you.
Yeah, thank you so much. It was a wonderful talk on this topic. And any questions? Perfect. Okay. Thank you so much. Can we please gather on the stage, all of us, for the group picture, the speakers and the chairpersons? Thank you so much. Thank you.
So the day has been a really concluding the first day. We have 2 more talks left. I would like to invite the chairpersons and the speakers both together to the dais.
Positions, we call them Jonano. It is essentially an ode to Lord Jagannath. It goes as Monoparare, Shiketra Jibu Uri Uri. Shiketra is Lord Jagannath Dham, and the mind, the poet here is Radhanath Das, and he has compared the human mind and soul to a frivolous dove. And he says, O dove, dove is personified as a mind. You should now fly towards Shikshetra because you are coming to the end of your mortal life. And do not waste any further time. Your feathers are dropping off. And you have very little time to fly off to Shikshetra. That is where you should wait on the Lord, the temple, the big temple, the precincts, the door of the Lord. Even if the Lord doesn't talk to you, Jagannath is known to be a Mauna Deva, which means that he is just quiet. Even if he is that, and he just remains quiet, he doesn't even look at you, or he looks the other way, don't bother, don't get disturbed. Just hang on there, just be there, flutter around there, and you will find salvation in that. You can go to the sea and take a nice dive into the sea. You can go into the river there and bathe in the river. But remember that keep your mind there at the Lord. And only then, if you prostrate there on the Baisi Pahacho, it has 22 steps. There's a lot of interpretation there about the levels of life, etc. in Jagannath Mandir. So at that 22 steps, the Baisi Pahacho, you rest yourself there, spread out the wings and breathe your last there. What greater salvation is there for a mortal like you than to die at the feet of the Lord? And your corpse will be lifted up by the bhaktas of Vishnu, which is Lord Jagannath incarnate. And there is no greater thing than that. So do not waste any time, flutter and fly away to Shikshetra. So this is composed by Radhanath Das, a medieval Odia poet, and the music composition is by the legendary Bhikari Bora. And I have composed this specially for this occasion, and I hope you will like it.
ମନୁଆ କାଳିଆ ମନ ମାରି ଦେଇ ମନୁଆ କାଳିଆ ମନ ମାରି ଦେଇ ମଉନେ ବସିଛି ସେଠି ମନ କଥା ତୁହି କହିବୁ ବୁଝେଇ ମନ କଥା ତୁହି କହିବୁ ବୁଝେଇ ମନ ରଖିଥିବୁ ତାକି
you very much, sir. That was indeed a very lovely performance. Now, I would like to request on stage our co-host group, our very own pathology residents from KIMS. अरे माइक लेना है क्या?
ठीक है जी
हाँ
पोजीशन एक बार देखना और नीचे
आएगा ना
जयाची
सुहाने सहमे नजारे हैं, सोए सोए वक्त के धारे हैं, और दिल में कोई कोई सी बातें हैं। कहने को जश्न बहारा है, इश्क ये देख के बहरा है, फूल से खुशबू कफा कफा है गुलशन पे। छुपा है कोई रंज फिजा की जुल्मन में, छुपा है कोई रंज फिजा की जुल्मन में। कागज के दो पंख लेके उड़ा चला जाए रे, जहाँ नहीं जाना खाए वही चला खाए रे, उम्र का ये ताना बाना समझ न पाए रे, जुबां पे जो मोह मारा नमक लगाए रे, ये देखे न वाले न जाने न गाए रे, दिशा हारा केमन बोका मोटा रे। रास रसीलो सज सजेलो शुभ घड़ी छे आवे, आजा आजा टमटमाता सुमना ओढ़े लागे ओ लागे, ओ लागे।
Thank you, students, and you have done an amazing job. So we have the second part of the Odissi dance, again by Professor Kanishka Das, the next one.
Wait a second.
So how can you come to Odisha and not see an Abhinaya based on Radha and Krishna? Normally in an Odissi repertoire we have a piece from the Gita Govinda. You must have heard of it, Jayadeva's poems. But I will present to you one from Balaram Das's composition. He was also a 16th century poet of Orissa, and this piece is composed, the music is composed by Pandit Balakrishna Das. He is a legend in Odissi music, and it is, the original choreography is by my great Guru, Grand Guru, Guru Padma Bhushan Sri Kilcharan Mahapatra. So I have made some changes here and there. The music credits, this is a recorded music from Guru Madhavi Mudgal's collection, so the credit goes to them. And this goes as Prana Sanginire Kalimu Laki Laje Budili. So Radha is recounting the previous day's experience to her Sakhi, Lalita, and saying, yesterday, oh my God, I was so very full of shame. And what exactly happened? Then she recounts how Krishna came in the guise of a beautiful lady, and he had alta with her. Alta is the red coryllium that we put on the legs, alta. So had alta with her, and he came in that guise, and he said, come, I will apply alta on your legs. And beguiled as I was, I just sat down there. I didn't even cover myself fully as I would do if others come, male members come. And he put alta so beautifully on my leg. And after that, when I got up to see, I found that he's written his name, Krishna, Krishna, all over the place. And I cannot imagine how ashamed I am of this, that the Lord came himself and he wrote his name on my feet. And this is what she recounts to Lalita. So this is how it goes. Prana Sanginire, oh dear friend, Kalimuki Laje Budili. Yesterday, I was so very taken aback, and I was filled with shame at this experience. So for you, an Odissi composition.
Teri jib milakya ଶୁଣିତା ମୃଦୁ ବଚନ ରହିଲା ମୋ ଚେତନ ଶୁଣିତା ମୃଦୁ ବଚନ ରହିଲା ମୋ ଚେତନ ପିନ୍ଧିଲି ଅତି ନିରୁଣ ପିନ୍ଧିଲି ଅତି ନିରୁଣ ଝିନ ମାସ ପୁରାତନ ପିନ୍ଧିଲି ଅତି ନିରୁଣ ଝିନ ମାସ ପୁରାତନ ଯାଇ ମୁଁ ବସିଲି ଠକାଇ ତାଙ୍କୁ ଦେହ ଯାଇ ମୁଁ ବସିଲି ଠକାଇ ତାଙ୍କୁ ଦେହ କାହିଁକି ସୁଖାନିବ କାହିଁକି ସୁଖାନିବ ହୁଅନ୍ତା ସଜନି କହ ଯାଇ ମୁଁ ବସିଲି ଠକାଇ ତାଙ୍କୁ ଦେହ 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 କାହିଁକି ସୁଖାନିବ କାହିଁକି ସୁଖାନିବ ହୁଅନ୍ତା ସଜନି ଶୀତନାଦ କଳାକ୍ଷମ ଦିଲାଖ୍ୟା ଅନୁପମ ଶୀତନାଦ କଳାକ୍ଷମ ଦିଲାଖ୍ୟା ଅନୁପମ ପଦ ତଳେ ତାଙ୍କ ନାମ ପଦ ତଳେ ତାଙ୍କ ନାମ ପଦ ତଳେ ତାଙ୍କ ନାମ ଲେଖିଲେ ଶ୍ୟାମ ଶ୍ୟାମ ପଦ ତଳେ ତାଙ୍କ ନାମ ଲେଖିଲେ ଶ୍ୟାମ ଶ୍ୟାମ ତୋର କି ତାହାଙ୍କୁ ଗୀତ ଚଞ୍ଚଳ କରନ୍ତି ଚିତ୍ତ ତୋର କି ତାହାଙ୍କୁ ମିତ 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 ଚଞ୍ଚଳ କରନ୍ତି ଚିତ୍ତ ଧରି ପାଦ ବ୍ରଜ ସୁତ ଧରି ପାଦ ବ୍ରଜ ସୁତ ଧରି ପାଦ ବ୍ରଜ ସୁତ ଧରି ପାଦ ବ୍ରଜ ସୁତ ନ ଛାଡ଼ିଲେ କଦାଚିତ ଧରି ପାଦ ବ୍ରଜ ସୁତ ନ ଛାଡ଼ିଲେ କଦାଚିତ କାଲି ମୁକିଲା ଯେ ବୁଡ଼ିଲି ପ୍ରାଣ ସଙ୍ଗିନୀ କାଲି ମୁକିଲା ଯେ ବୁଡ଼ିଲି ପ୍ରାଣ ସଙ୍ଗିନୀ ରେ କାଲି ମୁକିଲା ଯେ ବୁଡ଼ିଲି ପ୍ରାଣ ସଙ୍ଗିନୀ ରେ କାଲି ମୁକିଲା ଯେ ବୁଡ଼ିଲି କାଲି ମୁକିଲା ଯେ ବୁଡ଼ିଲି କାଲି ମୁକିଲା ଯେ ବୁଡ଼ିଲି
That was a brilliant performance. May I call up on the stage all the international faculty to felicitate and honor Dr. Das. With Dr. Saurabh, can you call Dr. Amin? He's just outside. Okay. Yeah, please come. Please come. Dr. Meena. Bye, Asun. Felicitation. Ranjana, Andy, you all have to call. Dr. Amin, please. Put it on the neck. Sandy, please. Dr. Amin, this is one. Okay, may I call up on stage Dr. Surabhi Mohanty to join us? I'll call also. And also Rumila and Garima was done like working all day long. Please come over. And Saurabh, please. Where is Saurabh? Dr. Mohanty is wife. She is a pediatric pathologist, the professor here. And Anandi, I'm sorry, I'm extremely sorry. Anandi, please. Anandi and Seema, both from the organizing committee, please come over. Seema. And Rudra Bhanu Satpathy. So we are going to have an exclusive faculty dinner tonight here in the ground, and tomorrow we are going to start at 8 a.m. in the morning. Okay, kali kari ba kise mane tired he gani kali kari how to tell a
Thank you so much, girls. That was an energetic performance. Now, all the way from Assam, we have Dr. Mayuraki with an folk bihu dance. Thank you so much. This brings us to the end of our cultural program. Thank you.